but you cannot eliminate the lithium from the brain, and this will take time to go out of the brain. Lithium is the perfect toxicant that could be eliminated by dialysis, and this has been demonstrated for a long time based on Albert Jäger's investigations in the 90s, and he showed that half-life could be decreased and clearance enhanced. But you see, and that is interesting, you have a rebound after the stopping of the hemodialysis due to the redistribution of lithium from the erythrocytes to the plasma. Who to dialyze? This is the question. You have to rely on three important aspects. First, of course, you have to consider the severity of the poisoning. That means the presence of severe neurological features like coma or seizures. Second, you have to consider the existence of some alterations in renal elimination. And third, of course, you have to consider the concentration of the lithium in the plasma, and you see that this concentration will vary according to the pattern of poisoning. In chronic accumulation, you will have a lower threshold to decide hemodialysis, and in acute overdose, a higher threshold. We reviewed our cases in Paris, in our ICU, and we divided the patients according to two parameters, serum creatinine and lithium concentration. And you see that we were able, with a good sensitivity and specificity, to separate the patients according to if they were or not hemodialyzed based on the advices of the physician in charge. And we showed that these two criteria seem to be relatively easy to decide to dialyze or not a patient. So if a patient has a concentration of creatinine above 200 micromole per liter or a concentration of lithium above 5.2 millimole per liter, then it's recommended to hemodialyze him. And we were able to demonstrate that in the patients who presented these criteria but who were not dialyzed based on the advice of the physician in charge, it seems in this subgroup that neurological impairments were more important at ICU discharge, despite an ICU stay length of the same length, an ICU stay of the same length. So maybe this is a sort of evidence to support the role of hemodialysis in these patients. The third situation is toxic alcohol poisonings, methanol and ethylene glycol. We talked about that previously. Both alcohols are not toxic, but their metabolites, due to alcohol dehydrogenase, are responsible for metabolic acidosis and organ injuries. Methanol is responsible for blindness mainly, and ethylene glycol for acute renal failure. And here the management is based, of course, on alkalinization, but mainly on the administration of an antidote, ethanol or famotidine, and of course the consideration of intermittent dialysis to remove the toxic metabolites and to shorten the course of hospitalization. The choice of antidote is debatable. In France, famotidine is the first-line antidote to treat toxic alcohol, but if famotidine is unavailable or expensive, you may use ethanol with the same effectiveness. Famotidine has the advantage not to require monitoring of its concentration, and it is devoid of any neurological side effects. So it is easier to use, and in some rare cases it may obviate the need for hemodialysis. So in a number of cases, hemodialysis should be considered, especially if you have a severe metabolic acidosis, renal failure, deterioration of neurological situation, or the onset of visual impairments with methanol. Based on the concentration, there's no necessity for absolute hemodialysis with ethylene glycol. So ethylene glycol of more than 50 milligram per deciliter should not remain an independent criterion for dialysis. However, with methanol, this criteria is debated because, of course, if you dialyze, you may shorten the duration of management in the ICU, and it is possibly cost-effective. So in the US, all the patients with methanol more than 50 milligram per deciliter are hemodialyzed, while in France, we have the chance to be able to spend more money for health problems. We can not dialyze such patients. The fourth situation is metformin poisoning. You know here that this is an increasing situation due to the large prescriptions of metformin in diabetic patients. There are two situations. The first one is acute poisoning, so you will have very elevated metformin concentrations, but a rather better prognosis. And the second is the chronic overdose by metformin due to acute renal failure in a patient who has a comorbidity or an acute morbidity like sepsis or like drug-drug interaction. So here you will have low concentration of metformin, but very bad prognosis. Dialysis is also the treatment. This was established only recently. You see that before 2009, metformin poisoned patients were not dialyzed because metformin has not good parameters suggesting its easy elimination by hemodialysis. Its volume of distribution is very elevated, so that if you want to use hemodialysis, you have to increase the duration, 16 hours of intermittent hemodialysis to eliminate metformin. And you see that the kinetics is in two phases. The first one is relatively quick. You eliminate rapidly the metformin from the plasma. And the second is, you see here, the first one is not working, but the first one is rapid and then very slow because you have to eliminate the metformin from the erythrocytes and from the tissues, and this is slower. So you need 16 hours, and your indications are severe lactic acidosis with acute renal failure and situations with increasing lactate above 5 millimole per liter. And in this situation, you may save, hemodialysis may be life-saving in the majority of the patients. Are there alternatives to hemodialysis? Of course, continuous dialysis and continuous treatments are interesting because they are more available. They could be suitable in hemodynamically unstable patients. They are easier to use to regulate fluid volume, and they may increase the clearance of mid-molecular weight solutes. However, they have some inconveniences. They have, and the most important one is that they have a lower clearance, so you will eliminate the toxicant more slowly. And the second inconvenience is that you require continuous anticoagulation to avoid the clotting of the extracorporeal circuit and the membrane. So when to use these continuous techniques? In lithium poisoning, it is recommended to use it immediately after hemodialysis. So you hemodialyze the patient during 6 hours, and then to avoid the rebound, you put a continuous hemodialysis. And in this case, as shown here, you have no rebound. In methanol poisoning, especially in case of an outbreak, you will have so many patients who will be referred to the ICU, so hemodialysis devices will not be sufficient to treat all the patients, and this was the case in the Czech Republic methanol outbreak, and patients were treated with continuous hemodialysis. And you see on this slide that, of course, clearance was lower but the patients were correctly treated, and the condition is to increase to the maximum the blood and dialyzed flow rates to increase the rate of elimination. Are there any additional or any alternatives techniques? Charcoal hemoperfusion. Of course, you may increase the clearance of some toxicants with charcoal, like carbamazepine, phenobarbital, phenytoin, paraquat, theophylline. So there may be some advantages. However, there are major inconveniences. You require greater anticoagulation. The charcoal cartridge are rapidly saturated, so there is a cost for this technique, and the tolerance is very bad. So, to my opinion, don't use charcoal hemoperfusion. What about exchange blood transfusion and plasmapheresis? It's more complicated. It is, of course, not so obvious to think that if you change the blood, then you will eliminate the toxicant, because the toxicant is in the cells, the tissues. But in some very specific situations, like acute and severe hemolysis, intravascular hemolysis with, for instance, methemoglobinemia, it may be appropriate to do exchange blood transfusions. So just exceptionally use these techniques. What about albumin dialysis? It may be interesting to use albumin dialysis to enhance the elimination of toxicants that are linked to albumin. And this is the principle of the Mars system. But the problem is that this technique is very difficult to set up. You require a specialized nurse, and he will require about 3 to 4 hours just to set up the device. So it is very time-consuming, and the benefit till now is not proved. So just use this technique if you want to investigate the ability of this system to increase the enhancement, to increase the clearance of the toxicant. So, as you see, there is no recommendation, and there is no high-level evidence to use or not dialysis, or to use or not such device. So there is an international group, I have the chance to be a part of this, called XTRIP, and we met several times, and we made some recommendations regarding the elimination techniques and indications in poisonings, and many of the resulting recommendations are published, and you can find them on PubMed. So in conclusion, for most severely poisoned patients, supportive care and antidotes are all that is necessary. There is no need for anything else, and no need for extracorporeal renal support. But in some limited cases, there is an indication. And this indication could be life-saving and is urgent. So in practice, hemodialysis should be considered in severe poisoning with salicylates, lithium, methanol, ethylene glycol, and metformin, and in all other toxicants, it should be discussed at the basis of a case-by-case discussion. And of course, as you understood, further studies, and especially randomized studies, are needed to evaluate the benefit, and further experience is also needed to evaluate the other techniques than hemodialysis, like continuous techniques. Thank you very much.
Thank you very much. That was a wonderful overview. At this point, we'll have the questions at the end of this session, so thank you. And so we'll move on to our final speaker. It's really my delight to introduce Dr. Praveen Agarwal. Praveen is a professor of emergency medicine at the AIMS Institute in New Delhi. He's chairman of emergency medicine, and one of the leading toxicologists in India, along with Sheesh Bala, who you heard from earlier today. And I also had the opportunity to be involved with training Dr. Agor many years ago in the States to teach him a little bit about American toxicology, but he's taught me much now about Indian toxicology. And they have a lot of particular expertise, particularly coming to the topic that he's going to be discussing today. And he's going to discuss an update in the management of OP pesticide poison patients in the emergency department.
Thank you, Dr. Paul, for your kind introduction. In fact, as he said, I worked under him in 1999, got training in toxicology at USA. Thank you, Dr. Paul. So I'll be discussing about the management of acute the pesticide poisoning and update in emergency department. So as you know, pesticides are widely used in industries, in the agriculture, in the domestic houses for various purposes. And it's a major problem, the poisoning is a major problem across Asia-Pacific region. Nearly 3 million cases of poisoning occur every year across the globe. And of these, about 200 to 300,000 people die because of pesticide poisoning. Majority of these pesticide poisoning are because of organophosphates. So remember, organophosphates is the major killer across all over the world, but most likely in the Asia-Pacific region. Now this slide just shows the various organophosphates. We have diethyl, dimethyl, and atypical organophosphates. The importance here is that dimethyl organophosphates, when they combine with acetylcholinesterase, they form a complex with the aging of about 3.7 hours. The half-life is about 3.7 hours only. While the diethyl compounds, they form the complex with aging of about 33 hours. So there's a wide window for the diethyl organophosphates in case you want to use pyridoxine. This is just the physiology of various acetylcholine receptors present in the body. And you can see that the receptors are present in the autonomic ganglia, in the postganglionic fibers, in the adrenal glands, in the heart, in the sweat glands, in the gut, in the bladder. All of these can produce various features of acute cholinergic poisoning. This is the mechanism of toxicity of organophosphate. Normally what happens is that when acetylcholine is released into the synaptic cleft, it is metabolized, it is inactivated by acetylcholinesterase to inactive compounds. But when organophosphate is there, it inactivates acetylcholinesterase, resulting in stimulation of the post receptors by acetylcholine, causing various cholinergic features. Now, organophosphate poisoning, there are 3 phases of organophosphate poisoning. The first and the most important for the emergency physician is the acute cholinergic crisis, which occurs in the first few minutes to first few hours of ingestion. The second is the intermediate syndrome, which occurs with some organophosphates about 24 to 96 hours after ingestion. The third is the organophosphate-induced delayed polyneuropathy, which occurs about 2 to 4 weeks after ingestion, which is a sensory motor neuropathy. Generally, these patients won't present to the emergency department. These are the typical clinical features of organophosphate poisoning. We have dumbbells for the muscarinic, but the 3 important are the 3 killer Bs: bronchoria, bradycardia, and bronchospasm, and of course the low blood pressure. The nicotinic ones are the respiratory failure mainly, and the CNS were the confusion, coma, and convulsions. Now, important about organophosphate poisoning is that organophosphate generally dissolved in hydrocarbons. So when somebody ingests organophosphates, the person can aspirate hydrocarbons into the lungs, causing breathing difficulties, can cause ARDS also. These are some of the ECG changes which can occur with organophosphate, but important thing is the QT interval prolongation and some ventricular tachycardia, including ventricular fibrillation also. Now, this is the score which we commonly use in our emergency department, Paradenia scores for severity of poisoning, which is based on the clinical features only: the pupillary size, the respiratory rate, the heart rate, presence or absence of fasciculations, the level of consciousness, and the presence or absence of seizures. This is a quite good, reliable score for defining severity of organophosphate poisoning. The diagnosis is generally by clinical only. We hardly use the plasma pseudocholinesterase levels or the RBC cholinesterase levels. Now, intermediate syndrome is an important thing for emergency department. The patient may come to us with mild organophosphate poisoning with few features of cholinergic toxicity. You may discharge the patient, but the patient may come back again after about 24 to 96 hours with acute respiratory failure. So that is why patient with organophosphate poisoning should remain in the hospital for at least 96 hours. They should be closely monitored for any respiratory failure, and if required, they should be ventilated by intubating the patient. Now, coming to management of the patient with organophosphate, if there is external exposure to the patient, suppose the patient is exposed to the organophosphate through skin, external decontamination is required. Otherwise, for the injection, the patient should be resuscitated, stabilized, given muscarinic antagonist like atropine, and if indicated, gastric lavage. The role of pralidoxime, the acetylcholine reactivator, is very, very doubtful. We do not use it. And definitely, if the patient does not respond to these therapies, then we need to give some novel therapies to these patients, which I will discuss later on. Now, the only thing about external decontamination is that you must protect yourself when providing the external decontamination. It should not happen that we have one victim of organophosphate poisoning and then we become the second victim of poisoning. So for the initial stabilization, the standard the ABC for any emergency. But the important thing here is that if the patient comes in cardiac arrest, we start the ACLS protocol, but in addition, we start the atropine therapy also. So remember, atropine is indicated in very few situations in ACLS program. Atropine is removed from the ACLS guidelines now. But if the patient has organophosphate or carbamate toxicity and comes in cardiac arrest, then the patient will require atropine to be given to the patient. Of course, to avoid aspiration, keep the patient in left lateral position, give high flow of oxygen because they are often hypoxic, intubate the patient if the airway is breathing compromised. Now, one of my previous speakers talked about the intubation. Avoid succinylcholine again to re-emphasize it because it also gets metabolized by the pseudocholinesterase. And if we give succinylcholine along with the OP poisoning, the duration of succinylcholine duration will be prolonged to 6 to 12 hours. Now, atropine is the initial drug of choice for patients with organophosphate poisoning. If the patient has meiosis, small pupils, excessive sweating, has bronchoria or bronchoconstriction, has bradycardia and hypotension, the patient requires atropine. But if the patient does not have any of these 5 markers of cholinergic toxicity, then the patient should be still observed for about 12 hours for delayed toxicity. The dose of atropine is 2 milligram intravenously, and it should be given even if oxygen is not available. The dose for children is for about 0.05 milligram per kilogram, the first dose. After 5 minutes of giving atropine, check the 5 markers of cholinergic poisoning. If there is no improvement, double the dose of atropine to 4 milligram and continue to double it every 5 minutes till you get the endpoints. The endpoints will be clear chest to auscultation, heart rate more than 80 beats per minute, that is there is no bradycardia. The systolic blood pressure is more than 90 millimeters, that is there is no hypotension. Of course, you can look at the pupils, they should no longer be constricted. There should be no sweating, that is axilla should be dry. This just shows a schematic diagram for the atropinization. Give doubling dose, 2 milligram, 4 milligram, 6 milligram, 8 milligram, 16 milligram, and so on. The important thing is that patients often lose a lot of fluids because of recurrent vomiting, because of urination, because of salivation, because of sweating. So along with atropine, start IV fluids, give about 500 ml to 1000 ml of saline. And also once the patient is atropinized, start the infusion of atropine at a dose of 10 to 20% of the total dose given initially. That is every hour. And assess the five parameters of cholinergic toxicity every 50 minutes. Make a diagram, make a chart in your emergency department about the various vitals. Monitor them every 15 minutes. The patient may require boluses of atropine in between, or the patient may develop atropine toxicity. Once the patient is stable, reduce the dose of atropine by 20% every 4 hours, so that generally by about 24 to 48 hours, you are able to stop atropine. This patient can also have hyperthermia, so external cooling is also important in this patient. Now, these are the features of atropine toxicity: agitation, confusion, urine retention, and paralytic ileus. Of these, most important is paralytic ileus. So keep on auscultating the abdomen every 15-20 minutes initially for any signs of atropine toxicity. If the patient develops atropine toxicity, stop infusion of atropine. Wait for about 30 minutes. The signs of toxicity disappear. Start the infusion again at about 75% of the initial infusion rate. Now, this is the one which we often use as the first intervention. Remember, gastric lavage can never be the first intervention in any of the poisonings, particularly for the pestilential poisoning. If you want to do a gastric lavage, it should be done only after the initial resuscitation, the initial dose of atropine, and there also the role of lavage in organophosphate poisoning is very, very doubtful. Again, as I said, it will increase the chances of aspiration pneumonia because organophosphate dissolved in hydrocarbons. Again, activity charcoal, probably no role again. There are studies showing that it probably doesn't act in patients with organophosphate poisoning. Now, do we have any evidence of doubling doses of atropine? We keep on doubling doses every 5 minutes. There are two studies which were conducted, one in Sri Lanka and second in Bangladesh. In the first study done in Sri Lanka, the 3 hospitals were chosen, and there were about 272 patients. In 2 hospitals, they gave doubling doses of atropine, and in the 3rd hospital, the standard routine was given, just the boluses of atropine were given. And what was found was that patients who received doubling doses, they received less of PAM and less of atropine. They also had lower occurrence of atropine toxicity. But there is no difference in mortality or ventilatory rate in both the groups. In contrast to this study from Bangladesh, this study was done in Bangladesh. Again, they divided into 2 groups. There were about 156 patients. And they found that giving the doubling dose of atropine reduced the mortality, reduced time to atropination, reduced the incidence of atropine toxicity, and also reduced the incidence of ventilation. So this study clearly showed that doubling dose of atropine is quite effective in reducing all the parameters associated with organophosphate poisoning. Now coming to the second antidote, which is pralidoxime. Many physicians still use pralidoxime, and the dose recommended is 30 milligram per kilogram of PAM chloride over 15 to 20 minutes, followed by infusion of 8 to 10 milligram per kilogram per hour. In India, we have mostly PAM iodide, which is less effective compared to PAM chloride. There are several adverse effects associated with the PAM, which include tachycardia, hypertension, muscle rigidity, laryngospasm. Now, let's see whether pralidoxime is really effective or not in patients with organophosphate poisoning. It may be ineffective if there is aging of the organophosphate acetylcholinesterase complex. Also, there is a variation between the different organophosphates. They may or may not respond to pralidoxime. There are no effective protocols in terms of doses which have been established for pralidoxime. In various studies, the dose have varied from 0, that is no PAM was given, to 24 grams a day. It is also not likely to address the non-acetylcholine effects of the organophosphate. Now, organophosphate have many other effects. They can directly affect the tissues. They can directly affect the neuromuscular junctions. So that's why it is not possible that pralidoxime is going to affect all other non-acetylcholine effects of the organophosphates. In addition, in developing countries, we have the problem of cost. It costs about $5 per gram of pralidoxime. And suppose you want to get 24 grams per day, it will become very high cost for us. Now, there are many studies done on comparing various doses of pralidoxime. The first studies were done from India in 2006, reported in 2006, in which 200 patients were included. They were given, one half was given high dose of pralidoxime. The second group was given the normal low dose of pralidoxime. What they found was that in the high dose group, there was less need of atropine during the first 24 hours. There was less need of intubation, and there was lesser duration of mechanical ventilation for the patient who received high dose of pralidoxime. But there was no change in mortality. There was a second study was done from Sri Lanka, which was again a double-blinded placebo-controlled trial of 235 patients. In this study, they found the mortality was higher in pralidoxime group, and the need for intubation was similar in both the groups. There were 2 meta-analyses published in 2018 and 2019, and in the first meta-analysis, what they found was there was no significant difference in terms of risk of death, intubation, development of intermittent syndrome, complications, and duration of intubation between the patient who received pralidoxime and the patient who did not receive pralidoxime. The second meta-analysis was published in 2019, which again found that the mortality was probably higher in patients who received pralidoxime. So with these 2 meta-analyses, it is possible probably that pralidoxime should not be given to a patient with organophosphate poisoning. Now, some people do use glycopyrrolate in place of atropine because it controls the secretion better. It produces less of tachycardia. it does not cross blood-brain barrier easily, and therefore will not cause much of confusion or delirium. But the problem with glycopyrrolate is that it is less effective in treating bradycardia induced by organophosphate, and it may not reverse the CNS effects of organophosphates. So most of us may give glycopyrrolate in case the patient is not having much of bradycardia and not having much of CNS effects, but it is costlier than atropine. Now, there are several novel agents which have been used in the past, which include magnesium sulfate, clonidine, sodium bicarbonate, and recombinant bacterial enzymes like butyryl cholesterase inhibitor, cholesterase. There are small studies conducted on the use of these novel agents. The first study about magnesium sulfate was on about 45 to 45 patients. One group got 4 gram magnesium sulfate over 24 hours as infusion. The second group did not get any magnesium sulfate. Oxime atropine was used in both the groups. So what was found was, in the magnesium group, none of the 11 patients who received magnesium died. While in the control group of 34 patients, 5 patients died who did not receive magnesium. So probably they concluded that magnesium may be effective in patient with organophosphate poisoning. But there was a study from Iran in the year 2018, which included 80 patients. Again, one group received magnesium sulfate, 2 grams every 2 hourly for 3 doses versus saline, and they found there was a reduced duration of admission for patients who received magnesium sulfate. This was a meta-analysis of patients who received magnesium sulfate versus no magnesium sulfate in OP poisoning, and it was found that it probably decreased the mortality if patients were given magnesium sulfate. The second drug would be sodium bicarbonate to alkalinize the blood to a pH of about 7.45 to 7.55. It has several mechanisms of actions, including it increases the OP clearance by hydrolysis, it expands the intravascular volume, it has a direct effect on the neurovascular junction, it has probably effect on the aging of the acetylcholinesterase OP complex, and probably improves the oxime activity also. Again, very small studies are available. This is a study of about 53 patients. One group received sodium bicarbonate, the second group did not receive sodium bicarbonate. So what was found was that total doses of atropine in the control group were higher than the group which received sodium bicarbonate. The admission rates were higher in the control group, that is patients who did not receive sodium bicarbonate, than the test group, that is the patient who received the sodium bicarbonate. Again, this is a very small study. Salbutamol is also being recommended, or at least thought of, as a treatment for patients with organophosphate poisoning. It relieves OP-induced bronchospasm. It increases fluid elimination from the lungs, thereby improving the oxygenation. But there is a recent study conducted in Bangladesh which did not show any benefit of use of salbutamol. Now, diazepam is another antidote which is being tried in patients with organophosphate poisoning. In OP poisoning, what happens is there is uncontrolled stimulation of the respiratory center, which causes decreased phrenic nerve output. Diazepam, what it does is that it attenuates the respiratory system activity, thereby inhibiting the CNS respiratory depression paradoxically. But again, we don't have much of evidence in favor of diazepam. This is a study done in animals, in rats basically, and what they found that if the patient was pre-treated with diazepam before giving diclofenac, 44% animals or the rats survived at 10 minutes, but none survived at 24 hours. So probably again, diazepam may not be really effective in patients with organophosphate poisoning. Another concept is the use of bioscavengers, like use of cholinesterase enzyme, which sequesters organophosphate compounds in the blood so that the target level, that the target concentration of organophosphate is reduced. The second is the use of hydrolysis, which hydrolyze the organophosphate in the blood, thereby reducing the concentration of organophosphate in the blood. And one of them, that is OPDA, has been found to be useful in animals. Now, there are 2 or 3 studies on bioscavengers. In the first study, again very small study, 33 patients, 20 received atropine plus PAM, 9 received plasma which contains butyryl cholinesterase, and 2 received plasma after they developed intermediate syndrome. Now what they found was that patients who received only PAM and atropine The intermediate syndrome developed in 28.8% of the patients, that is 6 out of 21, while in 9 patients who received plasma, in none of them intermediate syndrome developed. There were no deaths in the patient who received plasma, so thereby probably meaning that the plasma, giving plasma to this patient may be effective if the patient has severe organophosphate poisoning. But on the other hand, there was a second study in which they did not find any evidence of any benefit of use of plasma or 20% albumin in patient with organophosphate poisoning. Now, nicotinic receptor antagonists are also being tried because nicotine is one of the receptors at the neuromuscular junction. So if it gives something which is antagonizes the nicotine receptor, it may produce beneficial effect in patient with organophosphate poisoning. So there's a trial in the animals, not animal in the humans, but it's a phase 2 trial where the use of rocuronium has been shown to improve the outcome. But again, the number of patients very small, only phase 2 trial was there. The last one is the second last would be the use of intravenous lipid emulsion. Now it is being used in almost every poisoning. This was a study conducted from Chandigarh. Dr. Ashish Bala is here, who conducted this study. This was a study on 40 patients who were symptomatic because of organophosphate poisoning. But they found that there was no significant change in the hemodynamic parameters in patients who received intravenous lipid. Compared to the historical control, there was no change in mortality, but there was some reduction in duration of ventilation and hospital stay. There were no adverse effects. That's an important thing. Now, there is a review of literature from China. About 7 randomized controlled trials were systematically studied. All were reported from China in Chinese literature. And they have studied about 630 patients. So what they found was that intralipid improved the cure rate, it decreases the mortality rate, it decreases the respiratory muscle paralysis when the patient received intravenous lipid emulsion. So what we require is probably a larger trial on the use of intravenous lipid emulsion in a patient with severe organophosphate poisoning. Now, Dr. Bruno talked about the extracorporeal removal of the toxin. This was a study from Turkey, in which they had 260 patients who were divided into 2 groups. They had severe organophosphate poisoning. All received, at least 40 of them received hemoperfusion within 3 hours of injection, which decreased the mortality, decreased the incidence of intermediate syndrome, and decreased hospital and ICU stay. 44 patients received organ transplantations from these 20 donors, and the outcome was really good. 3 of the recipients died, 3 had graft dysfunction, but 34 had good graft function within first 6 to 12 months. So probably again, we should not declare these patients that they are not fit for organ donation. They can be taken as organ donors. If the kidneys are functioning well, the heart is functioning well, they can be good organ donors for the other patients. So to summarize, what we require is basically a large multi-center trial using these novel drugs, like we have plasma, we have sodium bicarbonate, we have intravenous lipid. Right now what we have is a single center studies having very small number of patients most often, except for the hemoperfusion study which has 260 patients. So I would feel that probably we require as a research, a multi-center group thinking about the various drugs which we can use in patients with organophosphate poisoning. Thank you.
Thank you very much. Really an excellent presentation. At this point, because of time constraints, I think we'll end this session. We're running a few minutes behind, and there is a break right now. So why don't we take a 10-minute break and begin at 4:40 for the final session of the day. Thank you.
Yeah, I'm Hussein from Tehran, and we are working together to moderate this session. And please introduce the first speaker.
All right, we're going to have an abbreviated session in that we have a couple of talks that have been canceled. So our first speaker is going to be Mohammed Al-Malki. Mohammed is a practitioner of both internal medicine and medical toxicology. He did his medical toxicology fellowship with us at Emory University. He is currently also the chairman of internal medicine at this hospital in Riyadh, which is King Saud Medical City, and he's been a board member of Minotalks for over 4 years. So we want to thank him for his contributions and looking forward to his next 15 minutes of his talk.
Hello, everyone. So my talk today will be about utility of drug screen in emergency department. So this is the outline of my talk. We'll start by giving you introduction about emergency drug screen methods that we are using for emergency drug screen, including immunoassay and chromatography techniques, limitation of immunoassay techniques, some evidence from the literature about use of drug screen in emergency departments, and then a conclusion. So basically, urine drug screen is a panel of tests that are done on biological samples, and most of the time it's urine, even it can be done on other samples. Then it can give you like a result it will tell you whether a specific drug or even its metabolites are present in that sample or not. Most of these screening tests does not give you quantity. Like they will tell you like if this drug is positive or negative, but they will not give you a specific concentration, despite some newer machines can give you like specific concentrations. So basically, drug screen is a two-step process. Initially, you have to do a screening test using immunoassay, and if that biologic sample tests positive for any drug, this does not mean it's positive. You have to confirm your result using another test. We call it confirmatory test, and different techniques used for that, like liquid and gas chromatography. So basically, like checkpoints at the airport. So initially, biologic sample will be screened to see if any drug is present there or not. If the test is positive, this does not mean it's positive. So you need to confirm your result by doing another test, confirmatory test, using gas and liquid chromatography. So for screening, we are using different machines are available. And most of these machines, they are using immunoassay techniques. Like, and they use antigen-antibody interactions. They have specific antibodies against specific classes of drugs or even its metabolites. So if the biologic sample contain that specific drug or even one of its metabolites, then it will give you a positive result. But again, this is not specific test. You have to confirm your result using chromatography. So commercially available immunoassays, they will test for different drugs. The most commonly tested drugs are amphetamines, barbiturates, benzodiazepines, cocaine, opiate, THC, and phencyclidine. Some machines, they will even test for more drugs like tricyclic antidepressant and the others. But these are the most commonly tested drugs. So immunoassay techniques are inexpensive, widely available in the emergency department, and easily automated. It's not a sophisticated technique and can give you the results quickly. What is the problem with immunoassay techniques? We have three problems. The first one, these tests are qualitative tests. So they will not give you specific concentration for that drug. They will tell you if the drug is positive or negative, but they will not give you specific concentration. Some newer machines will give like specific concentration, but the majority of immunoassay techniques, only they will tell you if the drug is positive or negative. So the second problem with immunoassay technique is reliability issues. So these are screening tests. So they are highly sensitive. Their sensitivity is very high. So you will have a low and false negative results, but they are not specific. their specificity is low. Also, their negative predictive value is low. So if you have a positive result with the immunoassay, this is not a confirmatory test. You have to do a second step. You have to confirm your result with a more specific and diagnostic test like chromatography. So these diagnostic tests are highly sensitive and specific. The third problem with immunoassay techniques is cross-reactivity. So they have a lot of cross-reactivity with a large list of drugs. For example, if you will eat this meal, you will test an immunoassay positive for opioid. So in poppy seed, they have cross-reactivity with the opioid immunoassay. So if you can see here, like there's interaction between different immunoassays for of different drugs. It's like amphetamines, they have a huge list of interactions. They can give you a false positive result with dextroamphetamine, ephedrine, with MDMA, labetalol. Also, they can give you a positive result with if someone is using granitidine and others. So they have cross-reactivity with a large number of drugs. For example, also THC, they have cross-reactivity with non-steroidal anti-inflammatory drugs. They have cross-reactivity with proton pump inhibitors. Opioid also, they have cross-reactivity with poppy seeds. They have cross-reactivity with rifampin, phencyclidine, and tricyclic antidepressant. Tricyclic antidepressant, they have cross-reactivity with carbamazepine. They have like similar structure, so it can give you a false positive result in someone who is using carbamazepine. And also, they have cross-reactivity with quetiapine. So you can see a huge list of drugs that can give you false positive results. So these are not diagnostic tests, only used for screening. So if you would like to confirm your result, you have to use more sophisticated techniques like gas chromatography, liquid chromatography, and mass spectrometry. Confirmatory tests are highly specific and sensitive, but again, they require more trained technician and to perform these tests. And also, you need an expertise to give you interpretation for the results. They can give you quantitative concentrations. It's not like immunoassay techniques for a specific substance or even its metabolites. But again, they are not available everywhere. And you cannot get the results immediately like immunoassay techniques. So, clinical scenarios where emergency drug screen is used in the emergency department. Emergency drug screen has been become like standard of care for a lot of patients. It's frequently ordered in patients who present with a drug overdose to the emergency department. Also, frequently ordered in patients who presented with CNS signs and symptoms, like someone with agitation, altered mental status. It has been frequently ordered. In psychiatric patients who present to the emergency department with psychiatric signs and symptoms like agitation, psychosis, delirium. Also, it has become a standard of care in trauma patients. So it's frequently ordered, but what is the utility of these tests? Do we need it? Does it change the management of these patients and their disposition in the emergency department? So what does the literature say? We have a lot of published articles discussing this issue. Over the past few decades, several articles have been published to address the utility of emergency drug screen. One of the earliest studies that has been published was in 1974. So this was a retrospective trial. 148 patients enrolled in this study, and they concluded that there is no utility for emergency drug screen in the management of patients in the emergency department. Later on, another study has been published in 1987 by Kellerman. This study was a prospective clinical trial and they enrolled 196 patients in this study. And the main question of this study was how often emergency drug screen will have substantial change in the management of patients in emergency department. And they concluded that only 6 out of 196 patients, there was change in their management. And even 3 of these patients, the change was to discharge home as they have negative results. Sorry, just. What about psychiatric patients presenting with psychiatric signs and symptoms like agitation, delirium? So emergency drug screen has become one of the commonly ordered investigation in these patients. One study has been done in 2000. It was this one was a randomized controlled trial. They enrolled 2 groups of patients in this study. 198 patients enrolled in the urine drug screen versus 194 patients enrolled in the traditional treatment arm. And the question of this study was like if emergency drug screen has an impact on disposition of psychiatric patients in the emergency department. It has been found that there's no change in disposition of psychiatric patients who presented with psychiatric manifestations to emergency department. What about trauma patients? So emergency drug screen has become one of the standard of care for trauma patients. It's frequently ordered in these patients. And even it has become like one of the requirement to be certified as level 1 and level 2 trauma patients to have available urine drug screen. Multiple studies has been published in the peer-reviewed literature about the utility of urine drug screen in these patients. And all of these studies, they concluded that there is limited utility of routine drug screen in trauma patients. So at the end, the conclusion from the literature review, the literature does not support an emergency drug screen as being helpful in the acute management of patients in the emergency department. Also, it does not change the disposition of these patients. Screening results rarely change clinical management of patients who presented to the emergency department. What about the clinical guidelines? So a clinical guidelines that has been developed by a UK clinical scientist and toxicologist and by a clinical toxicologist and clinical laboratory scientist, they recommended against the availability of emergency drug screen in the emergency department. Also, a similar guideline has been made by the Alberta Medical Association, and they also make the same recommendation. There is no utility for emergency drug screen in the emergency department. So, conclusion, emergency drug screen is unlikely to significantly impact management of patients in the emergency department. Also, it has no impact on disposition of these patients. That's it, I'm done.
All right, we have some time for questions. Then on subsequent follow-up with psychiatry, it may not change their disposition at that time, but that could help the psychiatrist, someone who's an intentional adult, to know that someone has cocaine use disorder or marijuana use disorder, and that could help them get targeted to just different treatments that could benefit them.
I did not get across any article discussing if they are useful for follow-up. I have no idea if there's any published article to discuss utility of these emergency drug screen as a follow-up modality in psychiatric patients. I came across studies talking about useful if these urine drug screen are important for disposition in the emergency department in psychiatric patients who presented with psychiatric manifestations like agitation, delirium, etc. But I'm not sure if there are any study about usefulness of these immunoassay like as a follow-up modalities.
Okay, thank you. Sure, after we finish with these questions, yeah. Okay.
I have a question, Mohammed. As a physician, I'm wondering what should I do? From tomorrow, I should stop ordering drug screening for my patients?
So,
Does it mean that I should follow drug screening by confirmatory tests? Or should I do confirmatory tests from the beginning?
so basically for intoxicated patient, what we need, we mainly depend on clinical signs and symptoms. So you have to rely mainly on your toxidrome recognition. It can help you, but again, as I told you, like if you have, for example, a urine drug screen which tests positive for opioid, this does not mean that your patient was using opioid, because you will have a lot of cross-reactivity, and this test should be confirmed by another confirmatory test, which is sophisticated techniques, not available everywhere, and even you need like more. It will need like sometimes 1 day or 2 days to have the result. So basically for acute intoxication, you have to depend on your toxidrome recognition. But they can help, yes, but if you have a positive result, you have to put in your mind that you can have a lot of false positive results, and also a loss of cross-reactivity with the other drugs. Like for example, if someone is using tricyclic antidepressant, it can give you a false positive result with a lot of drugs, as I showed you previously. The amphetamines, they have large list of cross-reactivity. Other questions?
Any other question from Flu?
Okay, thank you.
Let me introduce Semik Krukut from Turkey. He is currently working in Ministry of Health as a director of the emergency medical service in Turkey. That doesn't work.
Teşekkür ederim. İlk önce İngilizce sunum yapacağımı biraz önce öğrendim. Behçet Hoca'ya o yüzden biz sunumu Türkçe hazırladım. Behçet Hoca da ceza olsun diye çevirimizi yapacak Behçet Hoca.
Önce bir soru salonda. Who can speak? You cannot understand Turkish? How many of you? You, both, and you. You don't know Turkish, eh? No. Okay. You are here. You already know Turkish. Okay.
Hazır mısın? Şimdi
Just a minute. Dr. Semih Korkut, he is the manager of the emergency service of Ministry of Health of Turkey, especially for the pro hospital. He's working a very hard-working man. You can see in the morning he's east of Turkey. In the same day of the evening, he's at the south of Turkey. So he want to present his apologize because he planned to join us for the opening ceremony. In the morning, the Ministry of Health called him to go to join another meeting. So that is why he didn't join us. So he presented his apologies again. Why not he didn't join us? Okay, you are welcome. And he's also the member of the EPOD. I have to say it. Okay.
Türkiye'deki afetlerdeki toksikoloji durumunu anlamak için ilk önce afetleri anlamak lazım.
To understand the toxicology of even in Turkey, first we have to understand the other events, disasters.
Şimdi Türkiye deprem bölgesinde.
Turkey is an earthquake place.
Ulaşım yollarının
Located in
üzerinde.
earthquake.
Her türlü afete açık bir ülke. Son bir ayda başımıza gelen felaketleri buradaki toksikolojiden bahsedeceğim.
In recent days we have 3 big disasters.
Evet. İlk önce küçük bir şeyimizi hatırlatayım. Türkiye'de 35 bin tane acil sağlık hizmetlerinde, hastane öncesi acil sağlık hizmetlerinde çalışan personelimiz var.
We have staffs at the 35 location for pre-hospital staff working.
5600 ambulans, bunların yaş ortalaması 3.6, dünyanın en genç filolarından bir tanesine sahip.
5,600 ambulance, 17 helicopter and 3 aircraft for
Evet.
transfer.
3 uçak ve 17 helikopter. Helikopterde ve uçakta da dünyanın genç filolarından bir tanesine sahibiz.
We are one of the youngest for the aircraft transportation
Evet.
in the world.
24 Ocak'ta Elazığ depremi başımıza geldi. 6.8'lik bir deprem. 20.55'te meydana geldi. En yakın istasyonumuz bir göçe 2,5 kilometre mesafesindeydi ve 4 çağrı o istasyona geldikten sonra 4 dakika içerisinde o istasyon göçük alanındaydı.
At 25th of the January, we had an earthquake in Elazığ location. At 20:55 time, the nearest location for help was 2.5 kilometer far from the earthquake location. Okay.
Şimdi depremden yaklaşık 15 dakika sonra Sağlık Bakanlığı'nda bir koordinasyon merkezimiz var. Genel müdürlerin toplandığı. Burada önemli Halk Sağlığı Genel Müdürü, Kamu Hastaneleri Genel Müdürü olduğu veya onların olmadığı ortamda Genel Müdür Yardımcının olduğu bir ekibimiz toplandı. Ben Acil Sağlık Hizmetleri Genel Müdürü olarak o anda uçak arıyordum. Yani Elazığ'a nasıl gidebilirim diye.
Just after 5 minutes after the earthquake happened, they had an organization centers in the Ministry of Health. 50 minutes later, they became together for organizing this earthquake help.
Bakanlarımıza ait özel uçakla saat 0, gece saat 12 civarında hem Sağlık Bakanımız hem de bizler olay yerindeydik ve bir kriz merkezi ortaya çıkardık.
Just 3 hours later after the earthquake, the Ministry of Health of Turkey with their personnel, they arrived to the location of the earthquake.
Elazığ, Malatya'da tabii iki tane en çok etkilenen illerimiz Elazığ ve Malatya. Burada da
The
tabii
most
sağlık
affected
personelimiz
cities
var.
was Malatya and Elazığ.
Şimdi Elazığ ve Malatya'da toplam 153 ambulansımız, 13.000 sağlık personelimiz, yatak kapasitesi 5.990, yoğun bakım yatak kapasitesi iki ilde 1034.
For Elazığ and Malatya cities, they have 153 ambulance, 3,300 personnel staffs for health, and about 6,000 bed capacity, and over 1,000 intensive care unit bed.
Bu çok önemli. Bizim depremden sonra hızlı reaktif olan bir şeyimiz var, bir yapımız var. Onlara biz hazır olun, depreme gidiyorsunuz, afete gidiyorsunuz demiyoruz. Bizim ekiplerimiz hazır oluyor. Sonra yola çıkarken biz yola çıkıyoruz diyor, biz dur veya kal diyoruz ona.
They have a very active team. They are always ready for help.
8 saat içerisinde 2625 tane personel deprem bölgesindeydi.
Just within 8 hours after earthquake, over 2,600 personnel were transferred to the earthquake location.
Evet. 317 ambulansımız oradaydı.
317 ambulance were there.
Ki bu ambulans sayısı İstanbul'un yaklaşık 1.3-1.4 katı.
It is about 1.3 of Istanbul ambulance.
Aynı anda 2 helikopter ambulans, 2 uçak ambulans, bir ambulans uçak, 4 seyyar hastane, 18 seyyar hastane ünitesi ve işte ısıtma sistemlerimiz ve jeneratör sistemlerimizi götürdük.
Simultaneously, at the same time, the two ambulance, helicopter ambulance, 15 helicopter ambulance, 2 ambulance aircraft, and four mobile hospitals, 18 mobile units, and 30 heating system was constructed at the earthquake location in Elazığ and also in Malatya.
Orada geceleyin ciddi soğuk vardı. Eksi 14 dereceye kadar soğuk.
It was very cold at the same time.
Kurduğumuz çadırlarda halk gece artı sarsıntılar olduğunda çadırların iyi bir ısıtma sistemi vardı. Hemen ısıtma sistemini kurduk. Yanında da bir jeneratör var. Artı 30 dereceye kadar içerisini ısıtabiliyordu. Halkın birçoğu tedavi olmaya değil ısınmaya bize geldi.
They constructed the heater system at the same location in a very early time.
Evet. Kurulan çadır kentlerde hızlı bir sağlık hizmeti vermeye başladık hemen. Gördüğünüz kırmızı çadırlar sağlık hizmeti verilen çadırlar. Toplam 11 tane seyyar acil sağlık ünitesi kuruldu. Buralarda hemen tedaviye başladık.
They constructed a very well done tents location for the people, injured people, within very short time.
Önemli olan şeylerden bir tanesi bizim depremlerde öğrendiğimiz şey. En son İstanbul 5.8'de yaşamıştık. Haberleşme çok önemli. Haberleşmenin kesintisiz olması lazım. Biz buraya 5 tane mobil komut aracı gönderdik.
Nice. The communication in such disaster is very important. We can understand again how the communication is very important. So they communicate, they construct the communicate systems also at the same time within a very short time.
5 mobil komut aracından 2 tanesini yalnızca kullandık. O da telsiz desteği için. Yeni gelen 300 küsur ambulansa telsiz desteği vermek için kullandık. Yoksa telefon kapasitemiz iyiydi. Yerel ağdaki telsiz sistemimizde herhangi bir sıkıntı yaşamadık.
They prepared and constructed 2 mobile cars for communications.
Hastaların %65'ini orada bir yeni oluşturduğumuz bir şehir hastanesi vardı. Toplam 1631 hastanın %65'i Elazığ Şehir Hastanesi'nde tedavi edildi.
Of the injured patients, about 65% were treated in the Elazığ State Hospital, University Hospital, sorry.
Burada en önemli nokta afetçiler için enkazdan canlı kurtardığımız 45 tane yaralımız vardı. Hiçbir tanesini kaybetmedik bu yaraları. Canlı çıkardıktan sonra stabilledik, aldık, hastaneye götürdük. Hiçbir tanesinin hayatı gitmedi.
The most important point is that they took about 35 injured people under the destruction, and all of them are alive, still alive.
Evet, önemli konulardan bir tanesi halk sağlığı hizmetleri. İnsanlar hemen anında göçükten çıkarıldıktan sonra başka problemler ortaya çıkmaya başlıyor.
Another one important point is the community health system. To organize it. Organizing community health system is very important.
1000'in üzerinde su numunesi alındı.
They get over 1000 sample from the water.
Hızlı bir şekilde göçmen sağlığı, orada da Suriyeli göçmenler var. Göçmen sağlığı merkezi kuruldu.
They have also Syrian migration refugees at the same location.
Riskli gebeler tespit edilip anne otelimiz var bizim orada. Anne oteline misafir ettik.
They take the pregnant women in a very short time.
Şimdi burada 2 tane hastane var. İlk göreceğiniz videodaki hastane, oradaki daha önce yapılmış bir hastane. İkinci hastane Elazığ Şehir Hastanesi. İkisinin arasındaki fark, bir tanesinde izolatör var, bir tanesinde izolatör yok. Depremde izolatörlü hastanelerin ne kadar önemli olduğunu orada daha iyi anladık.
Okay, another important issue is that having an isolator in the hospital. They have 2 hospitals in this location. One of them had, the other doesn't have.
Müzik benden değil.
This is a view from the time of the earthquake. It is about 5.4, I think, isn't it?
İkinci hastane izolatörlü hastane, şehir hastanesi. Başkanımıza bu görüntüleri vermeyeceğim. Şu gördüğünüz izolatörler.
These are the isolators.
Elektrikler kesiliyor. Otomatik aydınlatmalar devreye giriyor.
Electricity is cutting. Destroyed, totally destroyed.
Yukarıdaki sallanan hastaneyi görüyorsunuz.
As you see, it is sliding due to the earthquake.
İstanbul'da bu yıl içerisinde bir tanesi 2800 yataklı, 2 tanesi 1000 yatağın üzerinde, 3 tane hastane bu şekilde devreye giriyor.
In Istanbul?
İstanbul'da, evet.
Okay.
Bu kızımız böyle 1.50 boyunda, küçük bir kız. Orada umkeciler tamamen gönüllü biliyorsunuz. Kısa boylu birisini arıyorlar göçün altına sokmak için. Bu kızımız gönüllü oluyor. Böyle gözüktüğü kadar büyük bir şey değil.
The majority of the helpers or supportive are involunteers. This is a very short girl. She is also a volunteer for helping, for supporting the injured patients.
Ben evdeydim o sırada, kek yapıyordum. Hemen çantamı hazırladım ve yarım saat içinde
She was at home at the same time. When heard the earthquake, left the home immediately.
Olduğu için ona müdahale edecek ufak tefek birine ihtiyaç olduğunu söylediler. Ben hemen gönüllü oldum. Hayatımda açtığım en zor damar yoluydu diyebilirim. Benim sıvıyı gönderebileceğim bir alan söz konusu değildi. Çünkü serum setini yukarı dahi
She's when
kaldıramıyordum.
injured people and having intravenous assessment and give the fluids to these patients.
Ayşe Hanım'a böyle bir müdahalede bulundum.
It was very difficult for her to have an intravenous assessment. She's volunteer, not official staff.
Şimdi göçün altına giriyor. 5-6 metre ilerliyor. Alan çok daralıyor. Sonra hareket edemiyor ve montunu çıkarıp öyle ilerliyor.
She enters the inside of the injured destructive area 5 or 6 meters to the deep for following the injured patient.
Bunun en güzel tarafı bir tarafta artçı sarsıntılar oluyor. 4 şiddetinde, 5
At the same time the
sarsıntılar oluyor.
earthquake is continuous.
Bu sarsıntılarda bu kadar yerin altına girip bu kişi gönüllü olarak bu işi yapıyor. Yani bu işi yaptığı için herhangi bir para almıyor.
Even though the earthquake still continues, she inserted 6 meters underground for rescuing the patients, injured patients.
Göçük altından 5 kişi 112 arıyor.
Under the destruction, she called for the 113 staff, emergency med staff.
112 göçük altındaki arayan kişilerle göçün oradaki olan sağlık personeliyle konuşturuyor.
The emergency staff called with this lady while she was under the destructive area and connected to the patients.
Azize bak sen bir annesin. Aşağıdaki herkesin şu an annesi sensin. Ve bizim tek iletişim kurduğumuz kişi sensin. Bütün güç sende. Tamam mı canım? Sen daha güçlü olacaksın.
She is trying to stabilize the patient who are under restrictions.
Evet, Türkiye'de 11.900 tane gönüllü var. Günlük rakamı değişiyor,
We have
artıyor, eksiliyor.
about 12,000 volunteers for disaster management.
Dünyadaki örnekleri Çin, Amerika Birleşik Devletleri ve Türkiye karşılaştırması var.
This is a comparison of Turkish and the United States volunteers.
Üst tarafta nüfus, ortada medikal kurtarma ekibi isimleri, aşağıda da toplam personel sayısı.
Yes, in the up you can see the population number, and down you'll see the volunteers numbers. Turkey is about 83 millions. US is over 27 millions, but their volunteers is just 5,000. The Turkish volunteers is about 12,000.
Bu gönüllerin tamamı sağlık personeli.
These all volunteers are staff. They are working in different places.
İşlerinde acil tıp uzmanı, radyoloji uzmanı, toksikoloji uzmanı,
This
halk sağlığı uzmanı.
These teams includes emergency medicine physicians, health physicians, and general practitioners, and also paramedics.
Yalnızca tabii başımıza deprem gelmedi. Aynı dönemde depremden yaklaşık 15-20 gün sonra Van'da bir çığ felaketi yaşadık.
We didn't just have the earthquake disaster. We also have an snow sliding just 20 days after this earthquake in the east side of the Turkey.
40'ın üzerinde hayat kaybı yaşadık.
We have over 14 deaths in this sliding, snow
Bu da
sliding.
Dünya Sağlık Örgütü'nün UMKE ile ilgili, bizim kurtarma örgütümüzle ilgili düşünceleri. Dünya Sağlık Örgütü'nün Türkiye temsilcisi konuşuyor.
This is one responsible of the WHO, the WHO. He's declared his opinion about the Turkish team supportive.
The standard procedures are in line with the best international practices for rescue medical teams. The last 15 years proved that UMKE is also an indispensable rapid response team regionally and globally. UMKE provided support during many emergencies, from Haiti to Japan or Indonesia to Iran, and recently in Albania. With its 12,000 volunteers, health professionals, UMKE is surely ready to respond rapidly and save lives all over the world.
Yaşadığımız afetlerden sonra devlet büyüklerimiz bize çok ciddi destek oluyor.
After this disaster, the manager of the, especially the president, they supported this team very well. They thanked to them.
Evet. Teşekkür ederim. Bunun peki toksikolojiyle ne ilgisi var?
Okay, he thanks and he's going to explain what is the relationship with this presentation and toxicology.
Evet. Şimdi başta gördüğünüz gibi
as you see in the beginning, very beginning,
kurtarma örgütümüz var. 112
we have yes, rescue teams.
Evet. İlk herhangi bir vakayla karşılaştığımızda sahada 112 ve UMKE ekiplerimiz olay yerine gidiyor.
When we face any problem, especially disasters, our UMKE is a team for first aid. They transfer to the location.
Üst kuruluşumuz olan AFAD bizden önce ulaşmışsa kırmızı bölgede yaralıları çıkarıp bize teslim ediyor. Eğer bizden önce ulaşmamışsa ve geç geleceğini düşünüyorsak bizim buna karşı donanımımız var ve olay yerine biz giriyoruz.
AFAD is the top construction for the first aid in Turkey. Firstly, they are transferred to the location when they get firstly they get the injured patient and deliver this patient to the next teams.
Buradan hastayı aldıktan sonra eğer olay yerinde çok fazla hasta varsa, yıkanması gerekiyorsa, KBRN gibi düşünmemiz gerekiyorsa onunla ilgili modüler taşıyabildiğimiz çadırlarımız, konteynerlarımızı ve hastayı oradan alıp temizleyip araçlarımızı alıyoruz.
Okay, they are doing triage for triage and the location, the scan. They have mobile cars for first aid, especially for the chemical exposure or biological exposure in the scan. They have mobile. They are doing this jobs in mobile cars.
Burada temizledikten sonra en yakın hastaneye götürüyoruz. En yakın hastanede yine temizlenmesi gerekiyorsa burada da KBRN ünitelerimiz var. Hastayı temizleyip sonra izole bir odaya alıyoruz.
Okay, they do this triage in scan during the transfersion. When they arrive to the hospital or any units, they do the same triage at all parts, and then transfer the patient to the available units or intensive care units or bed.
Depremde toksikoloji ile ilgili ne olmuş olabilir? Başımıza ne gelmiş olabilir?
What about in the earthquake about toxicology?
Çadırları kurduktan sonra çok
After they
sayıda kişinin
constructed the tents,
elektrikli ısıtıcılar yetmediği için veya gazlı ısıtıcılar yetmediği için soba kurduğunu gördük ve sobadan karbon monoksit zehirlenmelerine maruz kaldığını gördük.
Due to the deficiency of the electricity, they construct the heater. So due to this heater, the carbon monoxide intoxication maybe happened.
Çığ bölgesinde de
Because these patients are not used to live with the heater.
bizim kurduğumuz bir çadırda orada bizden izinsiz bir soba türü bir şey kurulmuş. Bir gazlı ısıtıcı kurulmuş. O bölgede de kurtarma personelinin oradaki gazdan zehirlendiğini arkadaşlar fark ettiler, müdahale ettiler. Çok büyümeden önledik.
In snow sliding disaster, some of patients they established in the tent without getting permission and constructed that heater, and they had a carbon monoxide intoxication.
Ve burada bahsetmediğim Sabiha Gökçen uçak kazası oldu. Sabiha Gökçen uçak kazasında 183 tane kazazedemiz vardı. 3 kişi hayatını kaybetti.
After the snow sliding, we had an aircraft accident in the Sabiha Gökçen airport. It enrolled 183 injured patients.
Biz buraya 105 ambulansla müdahale ettik ama beklemediğimiz bir şey daha oldu.
We act with 105 ambulance to this accident.
Aynı anda uçak kazasının olduğu halde uçak kazasına yardıma giden, desteğe giden aynı anda 5 polis bir araçta giderken araç trafik kazası yaptı. Aynı yerde oluyor bu olay. Uçak kazasının olduğu yerde. Onlar yaralandı. Aynı tarafta onlar da kazazede onlara koştuk.
For supported this accident, a police car included 5 persons had an accident at the same time, at the same location.
Pendik'te olaydan yaklaşık 30 dakika sonra Pendik'te bir metro çökmesi olayı oldu. İnşaatı çöktü. Orada da 4 yaralımız vardı. Onlara da aynı anda müdahalede bulunduk.
Okay. After 30 minutes, just after this aircraft accident, a metro accident has happened. Very clear, very close to this location.
Ve toksikoloji ile ilgili bir şey oldu. Tahmin etmek isteyen var mı?
A toxicological event happened that. Who want to imagine?
Ve 16 kişi maruz kaldı bu olaya.
16 persons were affected. Chemical, kimyasal maruziyet. Petrol.
Yok, hayır.
What else? Want to imagine?
Şöyle,
Just wait.
uçak
Do
yakıtında...
you have any gift? Do you have a gift for? Yani bir ödülünüz var mı bilene?
Nasıl?
Bilene bir ödülünüz var mı?
Ödül,
Do you have a gift?
ödül konusu Başar hocamın. O zaman biraz da...
Yes, President, he's going to give a books. No. Who will say three answers?
Ne oldu? Ha?
You? Can you ask the question again? Sorunuzu tekrar sorun diyor. At the metro accident,
Bir toksikolojik bir olay yaşadık.
they had
Aynı
a
anda.
toxicology event.
16 kişi,
What could be?
16 kişi zehirlendi.
16 people were injured in this toxicology event. So what could be? Huh?
In some way, yeah.
No, what did you say? What did you say? I didn't hear. Metroda mı?
Yok, hayır, yorum yok. Ha?
There is no comment for
Havalimanında.
location. Huh? No, there is no comment. There is no comment for location. They have 3 accidents: aircraft accident, metro accident, and car accidents.
Kurtarma ekipleri
Just
hocam.
a minute. Did you understand the question? Let me. Just. They have 3 accidents at the same time. First, aircraft. Second, car accident includes 5 injured, and metro accident includes 16 injured. In this 3, among these 3 accidents, there was a toxicological events, and 16 persons were injured. What could be? This is the question.
It was inside the subway or somewhere else?
Huh?
It was inside the subway or somewhere else?
There is no comment. No comment.
Evet hocam şey yapalım. Uçak yakınında zehirlendiler. Şöyle.
Yeah.
Evet. Şimdi
They were the toxicological event happened due to the aircraft oil.
Şimdi 16 kişi uçak yakıtından zehirlendi ve biz bu hastaları taşıdık. 105 ambulans, Sağlık Bakanı'nın ambulansı artı diğer ambulanslarla birlikte havalimanı ambulansları, belediye ambulanslarla birlikte 123 ambulansla müdahale olduk.
Yes.
Müdahale olduğumuzda...
They act with 126 ambulance
Altına
to the this
geçti mi?
event. Dr. Hussein, imagine it. Dr. Hussein of the right question. Let us have a coupling to him. Dr. Hussein, you gain an book. Sit down, sit. Have a seat, please. Have a seat. Then after lecture, find President Dr. Bashar, get him from him a book.
Hocam misafirlerimize kısa bir şey yapayım. Amsterdam uçak kazasıyla
He is going to compare the accident, similar accident happened in Amsterdam.
Sabiha Gökçen uçak kazasının kısa bir karşılaştırmasını yapmak istiyorum. Amsterdam uçak kazasında ilk hasta olay yerinden 74. dakikada hastaneye nakledildi.
A similar accident, aircraft accident happened in Amsterdam. The first patient transferred to the hospital get 74 minutes after accident.
Türkiye'de ilk hasta 21. dakikada hastaneye nakledildi.
This
Hastanedeydi hasta.
As this accident happened in Sabiha Gökçen Airport, the first patient was transferred to the hospital within just 25 minutes. But you should imagine the crowd in Istanbul and in Amsterdam.
Amsterdam uçak kazasında 54. dakikada bir hasta uçağın yanında, bir kazazede uçağın yanında ambulans beklerken hayatını kaybetti.
One patient in Amsterdam accident that died in 54 minutes while waiting for the transfer to hospital.
Türkiye'de uçak düştükten sonra hiçbir hastamızı olay anı haricinde kaybetmedik.
In Turkey, never any patient was lost during this accident happened in Sabiha Gökçen.
Teşekkür ederim.
Thanks.
Soru, katkı?
I just want to thank to Dr. Semi and his team. They are really very hard working and they are have a well done organizations. and acting the accident immediately with their whole team, included emergency medicine physicians, health physicians, paramedics, and also with securities person. So really, their results is very, very nice when we compare this with the other event happened in the world. They are going to establish this. They are going to publish this results, I think, isn't it? Bunları yayınlayacaksınız herhalde bu sonuçları. Yes, they are going to publish this results soon, so you can be able to find and to follow them from the publishments. Any questions?
Sorry.
Thank you. Halas. Evet.
Olarak bize oradaki tecrübelerinizden az da olsa bahsedebilir misiniz? Özellikle hastane öncesinde ne gibi hazırlıklar yapıldı?
He's asking about their experience that they did in snow sliding.
Sağlık ekipleri orada doğru yerde duruyordu. Olay yeri yönetimine doğru yaptılar. Olması gereken yerde duruyorlardı ve sağlık ekipleri ikinci çığdan sonra olaya ilk müdahale olan ekipler.
Okay. I need an explanation. May our guests do not know it. In the snow sliding, first we have a snow sliding, and about 5 persons were lost. Why, during the people were working for rescue, a second one happened. Just after the second snow sliding, the person who were trying to rescue the patients, about 35 of them, they injured and died. He's asking about their experience for this event.
Teşekkürler başkanım. Teşekkür ederim, çok sağ olun.
Allah, خلاص.
I get the privilege to introduce the next speaker. This is Dr. Amin Kazi, who's a professor of emergency medicine at the American University of Beirut in Lebanon. Amin did emergency medicine residency at Henry Ford Hospital in Detroit, Michigan, and he has many passions about the practice of emergency medicine, and today he's going to talk about emergency medicine practice in the MENA region.
Hello. Good afternoon. So I was preparing for 15 minutes. So I tried to reduce my slides to something that would drive a message that I think would bring us all in common as we are opening a new page in our relationship, hopefully, across the region, across the world. The sky is the limit in terms of collaboration, and I look forward to working with my new friends, the ones I made in this visit. I want to start by thanking EPAT and MENA Talks and all the sponsors and everybody involved in making this event happen. I'm going to talk about something basic that we all live, but is simple enough that I guess we will have some lessons all to really derive from. It's about the challenge of establishing the specialty of emergency medicine. What I have learned personally from experiencing emergency medicine from the time I was a student in the late 80s in Detroit to the time when I was a junior faculty to the point where I was chairing departments and establishing residency programs and journals and books. And the journey has given me the privilege of remembering what Turkish emergency medicine was like in the early 90s when I used to climb hills with Tintinelli here. It has given me the pleasure of, today actually I was talking to Dr. Gucha about the existence of two societies in Turkey. And what I tried to highlight, and it's very important to remember that the emergence of more than one society in the actual description of international emergency medicine is actually a sign of health, not only of positive challenge, but actually it highlights the complexity in which emergency medicine has gotten to be in Turkey. That itself is a sign of development that has taken you from being embryonic emergency medicine to developing to developed. You are now in the developed phase of emergency medicine where you have the complexity that it takes to be able to build new models and think differently, complement each other, and we'll move forward towards the future. So, what can we discuss today that could be a good ground rule for us all to collaborate? Let's go to the next slide, or I guess I can do that. How did emergency medicine start? You may have seen some of these slides because they talk about the history of emergency medicine in the United States. In between 1940 and 1955, emergency department visits had gone up by 400%. Industrial revolution, people were moving from the model of having a primary care doctor in the small village in Ohio to having people from New York living in California with no access to doctors. Everything, it's an industrial revolution. People are traveling, living, moving. There was a collapse of the traditional model of the primary family doctor who knows you, tells you, oh, you got a pneumonia. Why don't I admit you to the community hospital? So you go to the community hospital where they put you on their name and they take care of you with IV antibiotics. Things changed. Numbers were going up. People had nowhere to go but to the hospital, to the emergency room. To the emergency room, which at the time was a room. At the same time, early then, we didn't have the interventions we had now. There was no defibrillation. It was in the late 60s, mid-60s that they started introducing that on humans and in emergency departments, that people started using that as a therapy. We did not have CT scans. We did not have thrombolytics. People were still actually, who were our grandfathers, did not have the complexity in interventions, diagnostic tools and protocols and standards which we have now. They were still embryonic in their thinking in the resources that they had. They had antibiotics, they had laparotomies, but they did not have everything we have now in advanced airway techniques and in different perspectives on the management of disease and clinical conditions. When they came back from Korea, the Americans noticed during an accident where somebody kind of had multiple injuries in his own family in the Midwest, Dr. Kennedy realized and published in the Bulletin of the American College of Surgery at the time, the Annals of Surgery, which is now the Annals of Surgery, he published a statement in which he said, the weakest link in the chain of hospital care in most hospitals is the ER care of the injured. Of course, he's a surgeon. He would think normally of trauma. But to them, in Korea, they were providing better care for injured patients than they were in everyday life in their own country. Why? Because there was no categorization, no trauma systems, none of this existed. So they were receiving poor care in the community hospitals. It does not really help to just have a wonderful tertiary care center. You need to have the type of care go across the whole nation into community hospitals in the smaller communities, be able to uplift and improve emergency care everywhere. Public pressure, public awareness that there was a problem grew. And the public, through lawsuits, through articles in the media, pressured authorities and declared that what they needed, this was in the New England Journal of Medicine in 1958, they were calling for experience and judgment of the physician who's directing this. This was no longer just about providing a good defibrillator, a very solid bed. It wasn't about the physical space and equipment. It was now about experience, therefore retention of experience, and judgment. To have judgment, you have to have training. You had load and complexity increasing, and it was increasingly important to have adequate training and mature judgment experience, and adequate training was for the personnel, not only physicians. So they started calling for comprehensive training in around 1958. There were no emergency physicians yet. And everybody was calling for physician experienced in the emergency ward for medical and surgical patients. Certainly, they were internists and surgeons talking, so they missed pediatrics, ophthalmologic, obstetric, gynecologic, urologic, toxicologic. So you can imagine the scope. I'll spare you the history. The history is how they started developing staffing for emergency departments, where in Pontiac and in Virginia, in Michigan and in Virginia, doctors started working part-time. 24 doctors left their practices and started doing part-time rotations to staff an emergency department. Another model, 6, 7 doctors left their practices full-time and started practicing full-time emergency medicine to take care of patients. This was the early 60s, the Pontiac and the Virginia plans. The Alexandria, Virginia plan. Those two plans were the first people who said, we are emergency physicians, part-time and full-time. By the late 1960s, 68, people were starting in the United States, in Canada, in Australia, at the same time. People were coming together and starting to do training in emergency medicine. Dr. Bruce Janiak, who wrote his own curriculum in the University of Cincinnati and started introducing himself as an emergency medicine resident, even though there was no program. So he's a resident without a program. And then in USC, University of Southern California, Gail Anderson, an obstetrician, actually was appointed to start a residency program at the time with four spots only, that were basically the first residency program in 1970. 1970, 71, you had a surge of programs such as Henry Ford Hospital, University of Chicago, where Peter Rosen was, and there was, then you had this growth of programs across the United States and later across the world. And it's not for me, thank you. Here we go, we should close it. What would the nation, a community, or government want? What is the ideal center? What do you know? What do they want? 3 things. The people, the community, the nation wants 3 things. Easy access to emergency care, quality emergency care, affordable emergency care. They want easy access, they want quality, and they want to be able to afford it. What is easy access? It has to be nearby, proximity, no obstacles, no restrictions, no gatekeeping, no need to pre-authorize the care, no financial administrative bureaucracy, none of that. They don't want to do fill paperwork, they just want to show up, receive the care and leave. No delays in receiving a CAT scan, a study, a consultant. If you break your leg, you want the orthopedist to be there before you. This is what the public wants. Easy access is having all these resources without bureaucracy and nearby. On the other hand, of course, if you welcome all comers, you have a problem. So the other option is to limit access via pre-authorization requirements, denying care, restricting care, and the institution of co-payments, annual deductibles, qualified triage and medical screening, with directing patients or away from the ED to the clinics, or securing prompt access to alternative resources where they can get the care. So you have a balance between these two in restricting or making available these resources with regard to the concept of easy access. Of course, proximity to an emergency department when every minute counts and the golden hour of trauma is a principle requires proper planning, proper distribution without redundancy and duplication. You want to avoid the fragmentation of services. You can't have an obstetrician waiting in every room 24/7, just for 1 to 2% of our cases are OBGYN in my department at AUB and the University of California. So if all those cases are 2% of the cases we receive in the emergency department, should we have an obstetrician waiting there at all times? Or should we train someone to do the stabilization and avoid the redundancy and the fragmentation? When I went to AUB, we had an OB room, OB ED, pediatric ED, surgery ED, ortho room. I mean, everybody had sectioned the place, fragmented it, and God forbid you came with abdominal pain because of Mediterranean fever, and you were a woman, you'd go from OB to internal medicine to surgery, and you'd be flipping around, and delayed and sometimes missed. So you need, avoiding fragmentation, you need to categorize emergency services in all hospitals, addressing the plan especially addressing and having a plan for the special challenge of rural and remote area. We can make rules that can apply in Istanbul, in Antalya, but can we apply that in small little villages, have the same staffing and concepts apply? What do you do? Telemedicine, lower level providers that are agreeing to pay less, to be paid less, and yet to do more? And how do you provide that support for them? Provide teletransportation, transport these patients every time they have an issue. How many scanners do you have? How many emergency departments, ultrasounds? The Russians, in a country as big as Turkey, they have for every 20,000 to 40,000, for every 1,000 people, they have a GP. For every 20 to 40,000 patients, they have an ultrasound and an urgent care center. For every 200,000 people, they have a scanner. For every 2 million people, they have MRIs and tertiary care centers. So you have to think, compare that to your own countries and realize redundancy, fragmentation, cost of care. Easy access requires categorization based on capacity. And when I say capacity, it's not the ED capacity only. It's the institutional capacity. Institutional capacity because it requires ICU, stroke capacity, imaging, turnaround times in reading of this imaging. So that's how you end up having the capacity to define level 1 and level 2 trauma centers, paramedic receiving centers for cardiac cases, cardiac receiving centers with cath labs, stroke centers, replantation services, as well as classifying them as urgent care. There's no shame with just being an urgent care center. If you don't have the capacity, do not claim to have it, you will hurt people. Very difficult in the MENA region. I don't know about Turkey, but I can tell you 150 institutions in Lebanon, the size of Orange County, we need 25 to 30, 40 maximum emergency department. We have 150 that claim to have it. Therefore, you have 100 at least places where you can have disasters every day because people don't know how to intubate and they're receiving any cases. Nobody will agree to say, we don't have it. So you have delays and problems. It's Georgia. Second concept is quality. Easy access, okay. Quality. What defines quality? And how do you measure quality? When you're arguing with other disciplines over emergency medicine and how necessary, often I used to hear, prove to us that you're better. How do you prove that? There are a few studies that prove that we can do things better, but not many. Not many. We can prove that we can make a difference, but there aren't a lot of studies that do so. However, we all agree that to have quality, you need training, clinical experience and maturity, maintenance of quality, and administrative excellence. I believe these 4 elements are necessary to secure quality. Quality of training through emergency medicine residents and the development of EM specialists, as well as the provision of proper support to have community emergency physicians who may not be trained in emergency medicine yet, or may never be, because some of our graduates will not work in Yosemite National Park where they have to deliver babies and provide treatment for diaper rashes. They're the only doctor for a large community. They will do things that are not strictly resuscitation and diagnosis. They will have to be the family doctor also for these rural areas. So where is the proper balance and how can we embrace it rather than deny its existence is a challenge. We train physicians, but if we don't train nurses and our paramedical providers, we are, and I'm not talking only about paramedical pre-hospital personnel, I'm talking about the clerks, the technician, the orderly, the transportation. Everybody has to have a code of ethic and code of work. And they have to be oriented, trained, and retained. Retained is a very important concept. Leaders and administrators in the ED also require training to be able to be effective. Training has to be curriculum-based, supervised 24/7 by qualified faculty. The concept of having a consultant drink coffee in the office while the resident is seeing patients and they just review the charts or only the bad cases is not an option. Proper supervision in this day and age, quality supervision, requires the resident to be your assistant while you are overseeing how they are performing. When they are more senior, to have independence and autonomy and be able to supervise them is in a different way, is something we grow into. But supervision has to be at the bedside and 24/7. We no longer should be having supervision without that. With every patient encounter, these training centers must be accredited by national or regional or international agencies as meeting adequate standards for specialty training. And my hope is that we will be able to work in the MENA region with the EPAT and other organizations to develop these standards for specialty training, for accreditation of training centers, and accreditation of certification bodies. The minimum is 3 years of full-time categorical residency training. This little bit here, little bit there is not, these small little courses are not training. Accreditation through categorical programs with proper ED volume. You have to have a minimum number of patients in the emergency department to provide this training, and they should be audited to make sure that we have enough trauma, enough procedures, enough pathology that can provide the training. And if you don't have it, you go to another center to secure that too. Continuing medical education activities to cover the curriculum for the residents and for the graduates, as well as research and administrative training. They're both important to really provide the success of the specialty. Unrestricted access to all clinical conditions. It's not good to have trauma cases. I went to UC Irvine. When I arrived in 1992, we were holding the curtain. The trauma team would come in and we're no longer allowed to touch the patient. That didn't last more than 6 months. By that time, the trauma surgeon moved to Santa Barbara. But the point is, we won that battle and we started doing if you don't have access to patients to do things to them, you don't get access to the training. It's not enough to be a witness. It's also important to start teaching our residents and physicians who to admit, who not to admit, to do workups in the ED rather than in hospitals in Lebanon. The way to avoid, when they don't have good training, what they do is they over-admit everybody. So you have 60%, 40% of emergency patients get admitted so that they get the workup inpatient. In our ED, when we developed the residency program, we went from 21% admission rate to 16% admission rate, because we started doing longer workup, more expensive, but less costly in terms of total admission because we were sending patients home. So indirectly, you develop clinical skills and you reduce the cost of care. And you need to maintain quality through continuing medical education, long life learning assessments and exams, through the retention. You know, we have annual exams we take to make sure we're up to date. This concept should be maintained for all our graduates. It's not enough to just graduate and get certified. It has to be ongoing. And in my department, I can tell you, we provide every 3 months ongoing individual OPPE, professional physician performance assessment evaluation, where we sit with every doctor and we give them the number of patients that they admitted, the percentage they admit, how many times they used carbamazepines, how many times they order troponins, how many CT scans they order. So we monitor the average and the trends, how many bounce backs, how many mortality, morbidity they have had. This is done on every 3 months to make sure we are maintaining quality. Day-to-day operational oversight with the medical director or program director, operation performance improvement measures, administrative resources are required to do that. Therefore, money, time, protected time is essential to provide quality. Maintaining quality requires also maturity. I spoke about this earlier. It is important to retain emergency physicians and nurses. To have experience and maturity, people have to stay, and our field is extremely demanding. We have a high burnout, high attrition. We have high risk with exposure to tuberculosis, to violence, to aggression, to liability issues. So we have undesirable practice conditions and physical demands, working night shifts, working weekends. People have to be careful about the number of hours we work and we have to support our physicians and nurses to be retained within the specialty. This support is critical to retain people and retain the expertise, and requires a commitment by institutions and authorities to do so. Last is affordable emergency care. What's affordable emergency care? Who pays for emergency care? Where does the money come from? Government, government agencies, private insurance plans, cooperative funds, self-payers, and personal means. People who use cash, their own. Anybody knows any other way to really pay for health care? Because I mean, it's so easy to say, to see people say, you need to take care of the poor, you need to take care of so and so, how could it be so expensive? But people cannot want two things at the same time. At the end of the day, what we provide is going to cost money, and somebody has to flip the bill. And if it's all paid for by the government, then expect high taxes. So, and then therefore also higher bureaucracy. So what is the proper balance? To patients, affordable means free. Get someone else to pay it. To insurance, affordable means coerce facilities and providers to accept the least for providing it. To the government, affordable means restrict access to resources, to limit utilizations when it is most needed, and yet most difficult to say no to the patient. So when the patient comes in distress and you cannot say no, limit it, restrict it. So everybody is pushing you in a different direction, and this requires a lot of maturity and diplomatic skill to be able to steer emergency medicine the right way. And I'm confident that EPAT and the authorities in Turkey are working on this together. So is access to all emergency care and urgent care a civil right? Is it a legal right, a humanitarian right? What do you do with illegal immigrants? With the unemployed who do not pay taxes? Do you provide them everything? Will you go bankrupt to provide a transplantation for someone who can't afford it, who's not even Turkish or Lebanese? Big questions. Or do we transport them back to Syria? We've had those questions come in our department. Who makes the decision? And are we really providing everything ethically? What would the public, the voters paying patients or private insurers do if they realized they were paying for the others who do not contribute through cost shifting or a high tax burden? Are they aware that this is the case? Is the public educated? I'll stop here. The rest would be more negative. So, any questions? So, in other words, I hope that we will be able to work with EPAT on establishing the criteria and the standards for proper training and certification and ongoing lifelong learning. Standards that we need to provide that are tailored to our region and to our nations. Thank you for having me. Any questions?
We had a slide, it was written there, avoiding for fragmentation to emergency service. What did you mean?
Fragmentation, the biggest classic, the biggest classic form of fragmentation, Bashir, is when you remember the traditional emergency departments where you had ER surgery, ER pediatrics. That's one form of fragmentation. So or even fragmentation when you bring a patient into the ED and there is no room inside pediatrics. What do? You make them wait, or you put them in the urgent care and see them there. So we need to have people, snap people out of the concept of this is not my patient or this is my patient. So you don't want people to say this is my patient, don't touch it. This is wrong. But you also don't want to say this is my room, don't go in. So fragmentation is when you compromise proper patient care in the name of my turf. This is my turf. I'm under my authority. No one else does it. That's one form.
Thank you very much. I'm totally agree with this procedure because in the past we had such system in Turkey, especially in the government hospital, state hospital. In emergency department, it includes different rooms. This is the pediatric, for orthopedic and for neurosurgeon and for even eyes. So we remove all them from the emergency department. Now the emergency department just depends to the emergency physician now.
Of course,
But we still have some.
It's no longer the trauma room; it's the resuscitation room. You need to go into the it's a procedure room, not the casting room. You know, we have to start thinking differently. Thank you.
Thanks, everyone.
Okay. About information resource for poison centers. I think every presentation is 20 minutes, not 10, like Mark.
It's probably going to be closer to 10
okay,
room
perfect.
for questions. But
okay.
Yeah, so it's all right. Yeah, it's all for short. So good morning. It's good to see you all again this morning. I'm Lucy Scheffelbein, so I'm from the New Zealand National Poison Centre. And I just want to talk a bit about information resources that are available to poison centres and that we consider to be essential and ones that are probably not quite so useful. Can I have a... Thank you. Okay, let's see. So basically we're looking at, does Dr. Google know everything? Who uses Google here to search for information? We all do. So first of all, just disclosure. I'm the manager for the Toxins Poisons Information Database and a member of the Toxins Advisory Group. And Toxins is a sponsor of this meeting. But here this morning, I'm speaking to you in my capacity as Managing Director of the National Poison Centre. So the primary aim of a poison centre is to reduce the morbidity and mortality due to poisonings. And the primary role is to perform risk assessment and provide management and treatment advice. But in order to meet that aim, to reduce morbidity and mortality, early treatment and management advice is essential. So you don't want to be thumbing through pages and pages of information and taking forever to find the information you need. So we obviously need information on chemicals, hazardous materials, household products, therapeutic medicines, plants, fungi and venomous creatures. But again, it needs to be readily accessible and it needs to be reliable. So who here can tell me what is the best resource that a poison centre has? Anybody want to guess? Your senior colleagues and clinicians, they are a wealth of information and they're a great go-to source. So what resources should a poison centre have? Well, I guess you need to look at what are the activities of the poison centre. Are you just a poison control centre? Do you provide drug information service? What about pregnancy and lactation service? Or veterinary information? So considering all those services will help form what resources you need to have on hand. So things like conference abstracts are a great source of information, and internal treatment guidelines and protocols. You heard Dr. Lopez say yesterday that they had some internal protocols that they refer to. A lot of poison centres will have protocols on the most common poisons or the most serious, or the top sort of 30 toxidromes, and they're written and developed in-house, and they're quite a useful source of information. Journal articles. People often have interesting cases they write up. It's another great source of information. And then there's electronic databases and textbooks. So WHO actually has a recommended list of texts, probably slightly out of date in terms of this was written in the day, well, a few years ago when internet accessibility wasn't quite as good as it is now. It was expensive and not everybody had access to the internet. So they have a list of textbooks, and you've probably all seen these, and hopefully you all have them. Some of the editions may have changed, but they have a list on their website if anybody wants to look at that. So let's talk a bit about electronic databases. First up, there's ones that are accessible by paid subscription only. So there's Toxins, which is the poisons information database developed by the New Zealand National Poison Centre. Poisondex by Micromedics, that was originally developed by the Rocky Mountain Poison Centre quite some years ago, and it's now commercial. And again, it's by paid access. And the third key electronic database is ToxBase, and that's produced by the UK Poison Centres. So there's also access to a lot of information, and one of those databases through Hinari, which is free to developing countries. If anybody needs information on how to sign up to access these resources, I'm more than happy to show you how to do that. So some of the free online databases that you don't need to pay for, some of the chemical ones, you've got the IPCS InChem program, and that's got information on exposures like environmental, food and occupational exposures. Then we've got the PubChem, and that's free. All of these databases used to be under ToxNet, but then ToxNet was kind of retired and all of these databases were rearranged. And I'm happy to share the slides that have got the links in them if anybody wants them. So again, that's another chemistry type database. Searching PubMed for toxicology literature is quite easy. They have a little, you can define it so that it searches only toxicology information or toxicology literature, so you're not searching the entire PubMed database, which makes it a lot faster to access. Pregnancy, breastfeeding, lactation information, so there's breastfeeding and drugs, which again is free, so that's the LactMed database. Another chemical one, which is the ChemID+. It's got 400,000 chemicals on it. And then there's the developmental toxicology literature, again, searching through PubMed, but putting a refined search in, so it's only searching for the DART information. Drug-induced liver injury, which is liver tox. It's free online. And household product safety. So if you've got someone who's swallowed a new cosmetic that's new on the market and you're not sure what the constituents are, you can search for it and it'll bring up the ingredients. And then there's the occupational exposures, the HAZMAP database. And then last of all, there's the EPA risk assessment IRIS program. Okay, so let's talk about Dr. Google. Let's have a go. Let's ask Dr. Google to find the intervention criteria for a diltiazem overdose. So what is the problem with using Dr. Google? Well, where does the information come from? Who wrote it? Are they even qualified to write it? Basically, I could write a data sheet on anything and stick it on the internet and say that it's credible, but how do you know? When was it last updated or reviewed? What search terms do you need to use to find the information you're looking for? When you ask Google a question, it's going to answer what you ask. So if you don't ask the right question, you're not going to get the right answer. And how many results do you have to troll through to find what you're looking for? You know, sometimes you can scroll through pages and pages of information, and it's sort of hit or miss to get the right result. So here we are, we'll look for information on a diltiazem overdose. First thing that comes up is the pet poisons line. I'm not entirely sure that it's going to be useful in this situation. So if you scroll down the search results, you'll find a lot of PDFs and a lot of blogs, and a lot of information. Which one, do you have to open every one to find what you're looking for? So you see there at the top we can find, it's brought up to date, but again that requires paid access. Now if I scroll right down to the bottom of the page, you can see there that I've got Medscape, which is free, and I can access that easily. So let's have a look at that. So that's got some really interesting treatment information. It's got some, what have we got there? Some treatment approaches, some therapies. But what's missing? It's telling me here that I should admit all patients with a calcium channel blocker ingestion to ICU. That's quite a broad statement. What if my patient's only taken one tablet? So what's missing here? The intervention. How much is too much? It's fine telling you how to treat the patient, but you have to be aware of what are you treating and why are you treating. Also too, look for things like who was it written by, when was it updated. So that gives a piece of information some credibility. So you can usually click on those links and it'll tell you a bit about the authors and when it was updated and where they're from. So just to recap, poison centres need to have access to both print and electronic resources. All information resources need to be credible, reliable and up to date. And access to information needs to be rapid. The information should be clear and concise. Shouldn't have any guesswork in it.
Please.
About language, availability of resources in different languages. I know we collaborated with Toxins in Kazakhstan, for example, and Kazakhstan, you know, the language is difficult for them a little bit in terms of English. They prefer to have something in Russian. Are there any solutions, there's no easy solution, but are there any potential solutions for translating some of these references, or is it impossible?
But given the nature, we've looked at making the database localised, obviously in different languages, but given that there's hundreds of thousands of substances on there to translate it, it would be quite difficult. So we are exploring different models whereby we could have the database and somebody in that region would be responsible for updating the content and translating it. So you'd have different languages for different regions. And again, that's still, we're still exploring that. We definitely acknowledge that language is an issue.
Are there any other languages other than English? I mean, are there any resources in Spanish or Portuguese or?
So again, other than Google Translate.
Yeah.
What do you do in Italy as well?
Actually, we use the English-based information, and I was curious to ask you, what about plants? Because it's really difficult, in my opinion, to find something about some database about plants, mainly because of the different geographic distribution.
So on toxins, we do have images, so you can verify a plant.
Yeah.
And because toxins is an international database, we try and have as many sort of international themed plants, venomous creatures, and the likes, which also have images that are, for that region.
Yeah, okay, thank you. Yeah, please.
Thank you for the presentation. We almost 26 years experience in poison center in our department and in Turkey, in 9 Eylül University. From the beginning to now, we use PoisonDex database, and this database is very user-friendly and simple English, and it's easy to find the data. What do you think about what are the difference between the PoisonDex and toxins? I don't know. I didn't know this database up to now.
Yep. So, I'll just quickly say, if anybody
That's
wants...
a great question. Dr. Yasin Tunçuk is also the president of the Turkish Society of Pharmacology, so thank you.
Okay. Good to meet you. So toxins, I'm happy to give anybody free access so you can actually have a look and decide for yourself whether it's a good resource. One of the key differences with toxins and PoisonDex is when you search on toxins, straight away it brings up summary information. So very clear, succinct summary treatment advice, so you don't have to scroll through and look for it. It's right there. Products that have multiple constituents with PoisonDex, I know that you have to search for each ingredient separately, so that's potentially 3 different searches. Toxins will bring up all of the ingredients in the same monograph, and it will have the adult and paediatric intervention criteria for each ingredient listed one below each other, so you don't have to search and flip between pages. So that's quite another handy feature as well. Other than that, they're very similar databases.
I would add also, from my experience, is that in some developing countries or other settings, the cost is a problem. You know, I think toxins is, so first of all, with the Hinari database that she mentioned, did you mention that in
Yes,
detail?
yes, a Hinari.
So that you can get access to it for free.
If you're on the developing country list.
Yeah, if you're on the specific list, low-income country, I think. And
unfortunately, Turkey is considered too rich to qualify.
Even if you are in the not eligible for the free, the cost, what is the cost for a subscription?
So in US dollars, it is $2,500 for a single user license for a year. So it's about 15,000 lira for one user for 12 months. So it's quite affordable.
Yeah.
Any other questions? Azura?
Yeah. So let's continue with Dr. Eva Karakilik. Curious about the answer.
Okay, thank you. Good morning, everybody. I'm Eva Karakılıç. I'm from Turkey. I'm working in Eskişehir. Also, I'm an emergency physician and pharmaceutical toxicologist in Turkey. So, this is the different question. Does the emergency physician need to call poison control services? So, we have a lot of poisoning patients in our department, intentional or unintentional. The percentage you can see, it is little size, but it's important for poisoned patients, because if you don't treat these patients, it can be mortal and it is not good for us. So we have to need good data, because we don't know everything about poisoned patients. When we are managing these patients, we have a lot of initial things, initial evaluation, stabilization, toxidromes, a lot of things we have to need, okay? When we are managing these patients, what is the diagnosis and what can we do treat these patients? So we need reliable reference sources. Okay, a lot of reliable reference source information about toxicology. So we can find everything in our department, and we can ask somebody else, or we can call the poison control services. So textbook we can use, databases, applications, but the poison control centers, it is important for us. What is the telemedicine? The first time a grandma calls the doctor for their child. And the doctor hold the receiver close to the child's head to hear cawing, and then doctor says that the child did not have Krupps cause, and the matter could be postponed till morning. This is the first telemedicine in the world. Yeah, this is the original paper in the Lancet. I wondered what is the first telemedicine in the world. That was good, and it is a good idea to write this conversation. It is another thing for me. For example, I can do this, but I couldn't. I want to write this. It is important. It is a good idea for this doctor. Okay, so we have complicated telemedicine now, poison control centers. These centers, special information set up, inform people about how to respond to potential poisoning and maintaining databases, poisoning and appropriate emergency treatment for healthcare providers. So these are reliable sources for us. It is important for us. Okay. Poison control centers provide direct services to the public and emergency healthcare professional and public health agencies. There are a lot of data, but I don't know how many people use the poison control centers. For example, in 2018, Poison Control Center says 2 billion people called the poison control centers. So it is a huge number. It is important. For example, in USA, more call from public, but in the Turkey, not this not a I couldn't find a paper how many doctors calls the emergency poison control service, but more of them healthcare professionals. So PCC what is the poison control center's activities? What they do? So, first of all, they are gathering data regarding exposure and information about hazardous location and types of injury. The second activities is data collection. Reporting are the clinical activities, poison control centers. Another activities is poison control centers provide public education about poisoning and healthcare profession. For a healthcare professional, they can do educations because they have good information about your region and your country. Okay, so poison control centers working 7 days, 24 hours, and they give information from pediatric exposure to the include adult exposure. So they give me or they give healthcare professionals guidance related to poison identifications, anticipated toxins effect, initial intervention, differential diagnosis and appropriate treatment, information about transferring high-level center, etc. A lot of things they can say to physician. Okay. So, what kind of database they use? So, first of all, they use a lot of things, micromedex, toxicology website, a lot of things they can use. But these database reliable for us. It is important. Okay. Working a lot of persons, a lot of kind of persons, for example, specially trained nurses, pharmacists, physicians, and clinical toxicologists, for example. So they give a lot of information for us. Okay. Poison control centers and emergency physicians, what kind of data use? In emergency physician, textbooks, database, websites, and our colleagues we can use how to manage our patients. So it is more important than the other. We, emergency physician have clinical experiences about poisoned patients. It is important. This is the different role for treatments. This is a question. Do the specialists in the poison control centers can be manage our poisoned patients? This is the important question for us. They don't see our patients. They don't close to our patients. So we say some things and they give information about the patients. So we can differentiate these conditions so we can do an important role in emergency departments. The role of poison control centers, what is the role, can we say? Maintaining and interpreting database for xenobiotics and reducing healthcare costs related to poisoning, especially information and advice to health professionals to improve their diagnosis and care of patients. Other role, collecting epidemiological data and incidence and severity of poisoning, integrating epidemiologic data as a part of the public health surveillance system, and educating and contributing science of toxicology. Poison control centers advanced database acts as a protective screen for poisoning outbreaks across your country, across your region. So methodologically searching and analyzing potential poisoning trends and ranging from contaminated peanut butter to biologic warfare. So at the end of this knowledge, we can say that poison control centers providing information and advice to the healthcare professionals to improve the diagnosis and care of patients who present to the healthcare. And it is important we can access reliable data in our departments. At the end of this presentation, so emergency physicians need to call poison control centers. We can say that emergency physicians can be managed poisoned patients themselves. You can use your books, database application, etc. And they need reliable data about poisoning patients. And we have no more times for investigate all data. But we need to contribute data collection and data for education in toxicology. So, in my opinion, we have to need to call poison control centers. Perhaps not everything, but we can manage a lot of patients ourselves in emergency departments. But we have to need to call poison control centers for contributing data collection and for education in toxicology. Okay, thanks a lot. Thanks for your listening. Okay.
Yeah, please.
Thank you. I agree that, poison centers, calling the poison center helps with education as well as surveillance, but I disagree with you. I think when I work as a bedside consultant or at the poison center, I would say more frequently than not, I make a difference in the care of the patient, and the clinician who's calling me, I would say, needs what I have to say. You're right, not every case. If you have a simple case like somebody who overdoses on fluoxetine or a simple drug, but many times we diagnose serotonin syndrome, we diagnose neuroleptic malignant syndrome, we talk about the EKG changes with tricyclic antidepressants, triaging to telemetry versus regular bed, use of the antidote, stopping the antidote, the dose of the therapy. So I wouldn't say that, emergency physicians are able to manage all cases. I would say maybe, the simple cases, that's my opinion at least, because I feel like I make a difference.
Okay.
Please.
I feel like they change their plan.
Okay.
Yeah.
I completely agree with Dr. Ziad, although I come from a country where actually we don't have an active poison control, but I'm the clinical toxicologist in the service and I get called as a poison control for my own institutions. And for sure, we make huge difference. I mean, probably it's related to the setup of their poison control. I'm not sure how many toxicologists backup you have. Is it a specialist informations only, or you have a lot of toxicologists? Because the country setup also make difference, like whom you are staffing your poison control with and how many toxicologists they can access to if they needed to consult for specific patients. So that probably can make the difference. The other thing, yes, I know. And then the other thing I think, which Dr. Ziad already mentioned, is the cost effectiveness. And I think probably that's something that you can study in your own country. Like, what difference will it make in terms of length of admission, number of investigations, doses? Yes, so basically how many pitfalls happen, which actually already, like for me, I start observing it at my own setting, and I'm sure in US they already have published studies about the cost effectiveness of their poison control because they have plenty, they have many toxicologists. In your country, probably it's going to be something that you need to look at. Is it really worth it in terms of cost? And I'm sure you are going to have a difference.
Okay, thank you.
Please, yeah.
You made a controversial statement, now you're going to have
Yeah. Thank you. Thank you for your presentation. This is Yeşim Tunçok. And I also agree, Ziad and other colleague about the Poison Control Center consultation is really needed. And emergency medicine physician can take the responsibility of the patient, but with the poison center consultation, because the emergency room is very busy, crowded, and lots of patients are waiting for your care.
Short time.
And you have no time to explore all the things, and maybe you can miss something for the patient care. That's why Poison Control Center is very important, and I think you require, you need to call Poison Control Center. Another thing I would like to say, you are right, in United States, Poison Control Center are called by the public health. But in Turkey, healthcare physicians, physicians are calling this center. You can find this type of evidence in our annual report. We have numbers about that. You said that you cannot find any evidence. But evidence is in our annual report. We have but I think it's old, but in 2007 we have an annual report, and in other paper we also gave the numbers of the PCC consultations by healthcare providers.
Okay,
Thank you.
Look at. Okay. And I want to add something, because I'm totally agree, and I think that you said a really important thing, because I think that the physician of the Poison Control Center can totally share the responsibility of the patient, and I think it depends also on the education that the emergency physician receive on clinical toxicology. And I don't know in your country, but in Italy, it's not every emergency medicine physician receive an education on clinical toxicology.
Okay, it's important, yes, yeah.
Okay, please, quickly.
So just was interesting to see that more healthcare professionals are calling them members of the public. Do you have a sense of why that is? Is that because members of the public aren't aware that they can call, or they're using their phones to get the information, or are they just simply turning up to the hospital? And that's what, as poison control, we're trying to avoid. So have you got a good understanding as to why people don't phone from the public?
Yeah, it's a different way. In Turkey, you can easily can go to the hospital if you have a problem about everything. So it is important role for calling PCC. Because if some patients have a problem, they can go to the hospital easily, and they can access very short time to see the doctor. So it is I think it is the important role for calling PCC.
Okay.
We're kind of having a discussion. Is that okay? We have time.
Yeah. It's perfect.
So I want to ask, in Turkey, is there a medical legal burden? So do people make a lawsuit to the doctor if there was maybe a bad outcome or something? Do they sue? Do they sue doctors in Turkey or no? Was I clear? Like,
do you have?
I think.
Okay.
I don't know if any legal things to call. You must call the poison center for this.
Do they get sued? Doctors here, do they get sued?
In general, yeah.
Okay.
No.
Yeah, in Italy,
many doctors will call the poison center and say on the chart, I called the poison center and they recommended. And I think Gaylord can comment on this.
Okay.
For me, and I appreciate your lecture, one of the key components for us is the use of our poison specialist, right? And for us, it's a matter of training, because many of the cases that you're talking about in the hospital are only managed not by the doctors, but by the poison specialist. The most difficult cases, we consult with the doctors, mainly because of medical legal reasons. If it's really difficult, our poison specialists do consult the medical toxicologist. But I will tell you, in our area where we get 80,000 exposure calls per year, the poison specialist probably handles over, I would say, over 97% of the calls. So a very small percentage are handled by emergency room physicians. Imagine the workload burden if they had to handle all these cases. So for us, it's a matter of training, and as you look at developing your systems here, whether you follow the Western model or not, we rely in the Western model on the nurses, pharmacists, and poison specialists to do the majority of the work. The more difficult cases go to a Dr. Kazi or Dr. Morgan or myself. So we're involved in very few cases. The poison specialists take care of most of them.
Okay. Now we pass to the next talk from Dr. Lopez from Georgia about occupational chemical exposure, the role of the Poison Control Center.
Welcome everyone to the last session of the day. Finally, we made it. So far, we are, I think, only learning 10 minutes behind schedule. So without much ado, I'll start with the session. I'm Ashish Bhalla. I am Professor of Medicine at PGI Chandigarh, and I'll be moderating this session. The first speaker for the session is Dr. Paul Wax, and since he's been speaking since morning, this is probably his 6th lecture, so I don't think he needs any introduction. He is the Executive Director of ACMT and Professor of Toxicology, a teacher of teachers, and he's going to talk about his experience with environmental mercury poisoning. Over to Paul.
Greetings once again, and thank you for the very kind introduction. Dr. Kazi has had me talk on a number of different subjects over the conference, but they're all kind of passions of mine, and each topic is really a fascinating story. And I have a story to tell you in terms of this mercury toxicity, but just by a show of hands, how many have actually taken care of a patient with mercury toxicity? Has anyone had that experience? So a couple of the more senior folks have had that experience, and perhaps not as much among some of the junior folks. But mercury is a heavy metal which is ubiquitous both in... okay, thank you. So mercury is a heavy metal which is ubiquitous in society, and it accumulates both in the West as well as in the East. And I'm going to share an experience that I had with mercury poisoning where I practiced in Dallas, Texas at UT Southwestern. And it involved a mercury incident that involved a family and a school and the public health community. And the purpose of this talk is to kind of weave together both the clinical and the public health aspects of mercury poisoning case. So this involved a 14-year-old who presented to the emergency department with a fever for one day and a rash for a few hours, had a past medical history of asthma, and was given some ibuprofen, thought to have a viral syndrome, and sent home. And the following day, he returned back to the emergency department with a fever and ongoing rash, and he developed some other symptoms, dry cough, malaise, sore throat, and generalized headache. Again, very consistent with a viral syndrome. And physical exam, his blood pressure was perhaps a touch high for 14-year-old, 125/74. He had some injective conjunctiva, erythema of his oral pharynx. His neck was supple. Chest exam, he had some coarse breath sounds. Neuro exam, there was no evidence of a tremor. He had a normal exam. But on the skin exam, he had this rash, this kind of erythematous confluent rash involving both his face and also his extremities. So at the same time that he came to the emergency department, his younger sibling, his sister, came as well. She was 9 and had relatively similar symptoms, fever, a rash, also had a history of asthma. They had both been in the emergency department on the first day, and they went home and they weren't better, so they came back on the second day. And her exam was also consistent with just the rash, really no other positive physical finding. And here are some pictures of her rash on her trunk, and of interest, she did not really have much of a rash on the hand itself, but she did have some rash on the leg and the trunk. And as it turns out, the next day, the other sibling, the third sibling, in between, an 11-year-old, also came into the emergency department with similar symptoms: rash, fever, cough, and a physical exam, which was consistent with the other two presentations just discussed. So what diagnosis should be considered in children who present with a rash and a fever? Well, the topic is mercury poisoning, so clearly we're moving in that direction, but you don't really think too much about mercury when some child comes into the emergency department or into the office or the clinic with a fever and a rash. So this was certainly a very unusual presentation. So these are some of the entities you think about with fever and rash. Obviously, infectious etiologies, viral is most common, occasionally some bacterial, and some other less common presentations as well. All can cause fever and rash. But what tipped us off here, and this was not a challenge in terms of suspecting what might be the diagnosis. The challenge here was how to manage the case, as we'll discuss. But fortuitously, on the second visit to the emergency department, the 14-year-old brought in a bottle which was labeled as elemental mercury. So if we didn't have that information, I'm not sure whether we would have ever been consulted as a toxicologist. We were consulted to come down to the emergency department to see these patients once the emergency physician suspected it may or may not have something to do with this mercury. But as it turns out, the 14-year-old had been playing with this mercury at home. He found it along a railroad track, and when he came back the second time, he brought the bottle with him because he actually started reading on the internet. A curious kid, he started reading on the internet about mercury, and that could be potentially toxic. So he brought it into the emergency department. Of course, most emergency doctors don't see mercury poisoning very often. Very, very unusual. Not sure whether this was consistent with the fever and the rash, and that's why they called the toxicologist, myself and my fellows, to come evaluate the patient. So what are some key components of an exposure history? And in this case, we wanted to figure out exactly what was going on. We wanted to establish the route of exposure. Would they have been exposed to a burden of mercury that was large enough to potentially cause some symptomatology, and also to start to investigate exactly who else might have been exposed to the mercury. So there were a lot of different factors here, and I have to say, having evaluated a number of mercury cases over the years, most of these cases I evaluate are patients that come in with high mercury levels. Someone's measured mercury in the urine or the blood, and the level is high, but they're not symptomatic. So in this case, we don't have a blood level or a urine level at this point. What we have is a bottle of mercury, and we have 3 children with a fever and a rash. So when you investigate what are the symptoms of elemental mercury poisoning, you can sometimes see a fever and a rash. As it turns out, the rash is often described as being on the palms and the soles. In this case, it was neither on the palms or soles. It was more on the trunk and the more proximal extremities. But still, it was kind of curious. All 3 kids were sick, and they definitely had been playing with this mercury. So in terms of the exposure history, we learned that the child found this mercury along a railroad track, which at the time I had a hard time piecing that together. But as it turns out, some of the switches that are used in a railroad have traditionally used mercury in some of the instrumentation. And so this was probably a bottle of discarded mercury that someone just kind of left along the railroad track, and the child picked it up and brought it home. Now, mercury, if you've ever seen elemental mercury or played with elemental mercury, which is not very advisable, is a very unusual substance. It's extraordinarily dense. It's about 3 times the specific gravity of water. So it's kind of fun to kind of play with just because it's so heavy. And in fact, this bottle, I showed the picture on a few slides before, was very, very heavy. And it kind of moves in funny ways. It's really different than most substances one encounters. So the kids were quite curious about it. What they did is they opened up the bottle, they took it out. In fact, one of the kids tried to light it on fire, which is the worst possible thing you'd want to do with mercury, as we'll talk about it in a minute. And as it turns out, although we did not know this on the initial evaluation, but on our subsequent evaluation with some further questions, we asked if they had brought this mercury anyplace. And in fact, they were so fascinated with the mercury that the child brought the mercury to the school, which led to all sorts of red flags. So what public health resources are available to aid in this investigation? So typically, as clinicians, we usually deal with a patient, or occasionally there's a couple patients. Now, with an infectious disease, it's more likely that you'd have multiple people present with the same sort of presentation. With a chemical etiology, if there's a common source exposure, obviously it could affect multiple people. And in this case, playing with the mercury, there were the children, they were sick. We didn't have any levels, but we had some suspicion now that it may be due to mercury, and we wanted to investigate this further. And we were also concerned about who else might have been exposed to the mercury, because these kids didn't live by themselves. They lived with family. There were other family members. And also, if they had indeed brought the mercury to the school, and the child said that he had, could other children have been exposed to the mercury in the school? So there are a lot of different issues that came up. So through experience gained over a number of years, I learned about some of the public health resources that we could call into play here, because clearly this went beyond what we usually do in our clinical evaluation within a hospital setting. In the U.S., there is some public health infrastructure in place, although it's mainly designed for infectious disease outbreaks. And in fact, the health department that I worked with almost exclusively had been involved with infectious disease outbreaks in the past, and for them to start to investigate a chemical multi-source, multi-person exposure was definitely outside of their usual comfort zone. But nonetheless, this was potentially a public health problem, maybe even a public health emergency, and so it required some investigation. And I briefly mentioned at an earlier talk today that the CDC has this agency that works with them called the Agency for Toxic Substances and Disease Registry. And it was founded specifically to look into the public health aspects of toxic chemicals, and specifically some of these toxic chemical dumps, factories and other sorts of groups that have kind of dumped toxic chemicals into the land. We hope to, clean it up. The EPA is the regulatory agency that's involved with the cleanup, but from a public health concern, there wasn't any governmental entity responsible for that until the development of this ATSQR group. And so knowing this group, I contacted them, and the first thing they did is contacted the EPA. So the EPA, Environmental Protective Agency, is a group that's typically responsible for chemical cleanups. At least they know what to do, and they use a series of contractors. And so these pictures you see on the screen is the EPA folks actually going out to the school, because the concern about the school being contaminated was quite worrisome, because potentially this could have affected many, many children. And there were 3 children that were sick that we actually admitted to the hospital because of our concern about their illness and the fact that it might be from the mercury, and if it was from the mercury, they might have needed some sort of treatment. And moreover, if they were exposed to the mercury in their home, maybe their home was contaminated with the mercury, and it would be a very unsafe environment for them to go back to their home. So there were multiple issues here. They weren't super sick. They had a fever, they had a rash, they had a little bit of a cough, but we decided to admit them to the hospital and do this further evaluation. So where and what environmental samplings should be measured, and what are the recommended actions levels for mercury in the residential setting? So as medical toxicologists and physicians, we're more accustomed to look at testing in blood or in urine, testing of chemicals or drugs or other sorts of chemical testing that we do as routine medical evaluations. But in this setting, we were also concerned about some sort of exposure, and the exposure might be in the air, and is the air contaminated with the mercury? And that's some of the issues that we were confronting, because in terms of the route of exposure, the children denied ingesting any of the mercury. And in fact, with elemental mercury, if you ingest it, you tend not to absorb it, and you tend not to get sick from ingesting elemental mercury. Now, that's not true with other forms of mercury, such as mercuric chloride or a salt of mercury. That can be very toxic and corrosive if it's ingested. But elemental mercury tends not to be absorbed through an intact GI tract, but it can be absorbed through inhalation, and mercury tends to be quite volatile. In fact, if you heat up mercury, it tends to even be much more volatile. And that's why when I heard that the kid took a lighter to try to heat up the mercury, that's the worst possible thing. And one of the reasons we don't recommend cleaning up mercury with a vacuum cleaner is just because it may heat up the mercury and present more of a potential air burden of the mercury that might be absorbed. And so there are special devices that can actually measure mercury in the air. These are rather expensive devices, and many health authorities do not have access to these devices, unfortunately. But since I was able to contact the EPA, I knew that they had such a device, and they could take it out to the home, and that's the first place I wanted them to investigate, to see whether there were high levels of mercury in the home. Because if there were, then there were other people at risk. The children were hospitalized, but how about the parents or other relatives that lived in this actually relatively small home? So one of the meters that we use is called the Jerome meter or the Lumex meter, and these are rather expensive devices. So they actually went out to the home. Now this was a rather poor family. They did not have a lot of money, and they didn't even live really in a regular house. They lived in the garage adjoining a house. And in modern day home construction, there's a lot of ventilation. There's plans for air moving into a home and air moving out of a home, and they're designed carefully to have air turnover within a home. But in this case, it wasn't even a home. It was just a garage meant for a car, but the family was actually living in this garage. And so the EPA went out to this home. You see the pictures there, and they sniffed, we call it a mercury sniffer. They sniffed for the mercury, and they found very elevated levels. I mean, above 50 micrograms per cubic meter, which is extraordinarily high. I mean, the recommended safe level is below 1 microgram per cubic meter. So this was like 50 times above the safe level. So thinking about these kids who were in the hospital now, we did not have a blood level or urine level back, but we had an exposure assessment suggesting that they'd been living in this home with very, very high levels of mercury, and that they probably had become poisoned because they had these symptoms, which, although weren't the typical textbook symptoms of mercury poisoning, were certainly consistent with elemental mercury poisoning. So what are recommended action levels for mercury in a school setting? So this brought up a number of other issues because according to the child, they brought the mercury to the school. So we had to have the EPA go out to the school, use the same meter to see if there was any evidence of any mercury that had been spilled. And indeed, there was evidence that mercury had been spilled in the school. The levels were elevated. They weren't nearly as elevated as they were in the home, but nonetheless, there should have been no mercury in in the air in the school, and there was mercury in the air in the school. And so the range in terms of what's tolerated, what's acceptable for mercury in the school is different than mercury in the home. The reason being is in a home you might be there 24 hours a day or 16 hours a day, but in a school you're only there 6 hours or 7 or 8 hours a day. So in terms of what's an acceptable level, it's a little bit higher in a school than it is in a home. And it has ramifications because when you clean up the environment, you have to clean it up until you get below a certain level. And so these levels are used as thresholds in terms of the cleanup, and it differs between the school and the home. So what additional procedures need to be followed when the environmental mercury testing at the school came back elevated? Well, we needed to try to assess whether all these children in the school were exposed to the mercury or not. And one way to assess it might be to get blood levels or urine levels, but that tends to be quite invasive. And the level in the air in the school was elevated, but it was not nearly as high as it was in the home where these 3 kids lived. So we weren't, and there were no kids from the school other than these 3 kids that were ill. So we were certainly less concerned that they had a very elevated level of mercury, but we wanted to ascertain that it wasn't even above what was considered a safe threshold. So as a surrogate to evaluate whether they were exposed to the mercury, we decided to test their shoes. Not uncommonly, if someone walks through a contaminated area where they've spilled mercury, it may get onto their shoes. And if it gets onto their shoes, then they may track the mercury to wherever they go, like back to their home. And so worst case scenario was the several hundred kids who lived in the school were all contaminated with the mercury on their shoes, and they would have brought the mercury back to these 200 homes, and we would have really had a mass toxic exposure. And so what we did is we ended up testing the mercury in the shoes. And you can see in these pictures that there's some plastic bags. And what we recommended was all the children to bring their shoes into the school, and then we put them in the plastic bags. And the plastic bags were left on the field for several hours, and it was a warm day, so it could heat up whatever might be in the bag that had clung to the shoe. So if there indeed had been mercury that had attached to the shoe, and then we heated it up in the bag, and then you use the environmental meter to assess the mercury. If it's elevated, then that would certainly be a concern. So they tested several hundred shoes, and fortunately only 2 of the shoes were elevated. But those 2 shoes that were elevated, they then had to go out to those homes, or those children that had shoes that had been contaminated with the mercury, just to make sure that those homes were safe. And they went out to the homes, and in neither home was there any sort of consequential mercury level. So that was the result of the shoe testing. Now, how do we manage this public health problem? Because typically when you're dealing with one patient or maybe 2 patients, the doctor and the patients have this relationship, and it's confined to the doctor and the patients, and we make sure that communication is compliant with typical doctor-patient relationships. But now there was this concern about all these people that were being exposed, and we were asking children to bring their shoes into the school to be tested, and certainly a lot of parents might be concerned, and the teachers might be concerned as well. So the communication here is critically important. So we called for a public meeting. And a public meeting basically is a meeting that you invite various groups that have some sort of stake in the issue, and you be very transparent, and you discuss the problem with them. And that's exactly what we did. We called for a meeting in the evening. It was just a couple days after this initial event. We invited the parents and the teachers to come to the meeting, and then both the physicians, including myself and some of my EPA colleagues and school officials, then addressed the parents to try to alleviate their concerns. I mean, there were parents who were pregnant and had other sick children at home, and a lot of worried issues about this mercury. And so fortunately, we were I think satisfactory in alleviating their concerns. And we told them that, yes, we found a little bit of mercury in the school, but the levels were relatively low. We tested the shoes, and only 2 cases were the shoes elevated. So for all these other people, we tried to alleviate their concerns and tell them that there really wasn't anything to worry about, but also we were available for questions and further concerns. And
Paul,
we didn't
you
want
have
to
just
block
1 minute.
anything off.
You have just last minute.
Yep. So in the end, because this was part of a much longer presentation. So the levels in the kids came back elevated. And as you can see on this slide, the blood level and the urine levels were in the hundreds. And typically what is a normal level is below 1. So in the end, these children were significantly exposed to mercury. They became poisoned with the mercury. They had symptoms consistent with the mercury poisoning, and we treated them with chelation, and they gradually got better and left the hospital. But we all learned a tremendous amount about this sort of presentation, because not only did it involve the children themselves, but it involved all the public health implications of such a mercury exposure. And I'll end it on that note.
Thank you, Paul, for I'm sorry, it was very interesting, but since we're running
yes,
short on time, so
okay,
I thought
I'll be available for questions later on.
any
in case you have any questions.
one question? So if I'm allowed one, if nobody else is asking, how did you actually end up treating these?
Yeah, so we treated them with Chemet, which is DMSA, which is traditionally used for lead poisoning. There's not a ton of literature about the use of it in mercury, but there's some scattered literature about it. It's a relatively safe chelator. It's administered orally. We also added on N-acetylcysteine. There was some literature to suggest that N-acetylcysteine may also be beneficial. So while they were in the hospital, they got IV N-acetylcysteine, and we started the oral DMSA, and then they went home still on the DMSA for several weeks, and then we would follow their levels, and their levels started sky high. So after their first round of treatment, we retest them, and the levels remained high, and we gave them, I think, about 3 rounds of treatment over the course of several months, and we followed them very closely in the clinic, and ultimately they all got better and didn't have any residual symptoms.
I think that was a wonderful, wonderful talk. Let's give him a big round of applause. It's difficult to diagnose and difficult to treat cases in the absence of any definitive levels when you have so many patients. Now for the next talk, let me invite Dr. Charles McKay. He's been here. He is the immediate past president of ACMT and is still the associate director of the Poison Control Center at Connecticut. And he's going to talk about arsenic poisoning. Chuck, you have 20 minutes, so over to you. Yeah.
I'll use that extra 2 that's
Sure.
sitting on the screen now.
Yeah.
All right. So I have another story to tell you, sort of like Paul did. I wanted to take you through a little description of how we go from something like this, which is a form of mercury in the environment, arsenic in the environment, cover the mercury already, and how we go to a symptomatic individual. And the central diagram here is really the interplay of both the hazard, the substance that we're concerned about, and the patient, and the role that environment, or in this case the route of exposure, the setting of exposure, that kind of thing plays. And the importance of this is that it goes past, just these somewhat esoteric metals that we're talking about. This is really something that has an interplay for every patient we see where we are considering a toxicology diagnosis. Also, I'd just mention, since we're going to be kind of pushing through these cases fairly quickly, there was a symposium that we held down with the CDC in 2013 on chelation issues related to heavy metals, because in the United States, this has become a very significant issue with a lot of practitioners preying on the fear of the public regarding chemical exposure and using laboratory testing inappropriately to kind of support treatment that is not indicated for diseases the patient doesn't have. So much as with mercury, arsenic poisoning is a fairly uncommon event, but the diagnosis or misdiagnosis is actually fairly common in certain practices. Actually, the first patient I was consulted on as a medical toxicologist was an arsenic poison patient. I'll mention some of those features while we're going through this. And I think we'll go through this. Okay, so what I'd like to, at the end of this, is to have you guys be familiar or comfortable with the idea that you're going from the existence of a substance that could be a hazard, a substance itself is a hazard or not, depending on the characteristics of the substance, to a risk to whether the person may or may not be injured by this hazard. And the importance of dose, route, and timing, which is the kind of the tenets of medical toxicology, and then a difference between individual health risk and a public health concern, because with all of the environmental issues that we're talking about, that becomes the real crux of the communication that then needs to happen with the public or with responsible officials if that's the venue you're working in. So arsenic it's an element. It's found in ores. It contaminates a large number of ores. Those that contain iron often contain a fair amount of arsenic as well. When it's more present as just the sulfide, it has these pretty crystalline shapes to it, but it is not present in nature as a pure substance. It's extracted from these ores and then used for a variety of different things. And these are just some of the lists of over the years, the centuries really, where arsenic has been used. So it's been used as a medicinal. It kills organisms. It's been used both to treat skin conditions, so topically. It's been used as a cosmetic, not necessarily for good reasons. It's been used intravenously, and you think about old uses where it was a treatment for syphilis back 100 years ago, but now it's also being used in pediatric facilities predominantly for the treatment of promyelocytic leukemia. So arsenic trioxide, the same form of arsenic that is the most dangerous in terms of its environmental exposure, is also used intentionally, therapeutically, to treat children with a leukemia. It is also present, since it's leached out of those sources in the ores into water. It's present in groundwater, and it is then taken from wherever that water source is on out to the sea, and you end up with contamination or incorporation into organisms and therefore seafood as well. Arsenic is not just it doesn't just stay inorganic. However, it's incorporated into organic compounds such as arsenic sugars or arsenobetane, which is one common form that's present with seafood. And those two forms, in contrast to, say, with mercury, where organic mercury is a very, very, very potent toxin, are fairly non-toxic. So organic arsenic, in contrast to organic mercury, is fairly non-toxic. It's used in industrial purposes for a number of different reasons, and because of its toxicity, it's also used to kill things. So it's used as a rodenticide, it's used as for homicide. This was the inheritance powder from the Medici families and others, where that would be used as a way of ensuring that you got your parents' stuff because you killed them and you were the only one left. So these are just a few uses. Some of these solutions were used. Fowler's solution was used right up and through the 1960s, I think, over about a period of 200 years. The pigment, the Paris green, was used as a rodenticide in the Paris sewers, but it was also used as a pigment in wallpaper back in the mid-1800s, and would leach out of that, and actually because of the process of both the moisture and the mold growth, as well as heating the area with flames, fire, they would convert that into a gaseous form of arsenic called arsine, which is also used in industry currently, causes a completely different set of symptoms, but all of these are forms of arsenic that were very commonly present in the environment over a period of time. So we have a number of mass poisonings that occurred over the years. Some of these are back in the mid 1800s, but if you look at this adulterated donuts in the 1980s, this was actually an individual who has a fairly extensive history in the medical toxicology area, which is Michael Swango, who's a physician who felt that he really needed to poison people, felt that that was what his skill set should be used for, and killed a number of people. Was convicted of killing 4, but is thought to have killed scores of people in Zimbabwe, as well as a number of people in the U.S. When he was in Illinois waiting for his licensure, during a period of time when he'd already been convicted of or sent away from some other facilities where he was thought to have had a role in patient deaths, used arsenic to poison his fellow paramedics, and that's where that issue came up. In Maine, just a few years ago, we were peripherally involved. It's a state near where I practice, where a custodian of a church had poisoned the communal coffee urn in New Sweden, Maine, and killed a couple of individuals, sickened about half a dozen of his fellow churchgoers. This was a very, very small town, and as you might imagine, this fellow who was found criminally responsible committed suicide shortly after being arrested, but tended to implicate in a letter that he wrote some other unnamed individual, and that's completely changed the whole manner of living in this small town, and people are still to this day, uncertain and fearful of their neighbors, and they lock their doors, and they never used to do it, that kind of thing. So arsenic has a long history, and the question is, how would you ever recognize it? And the clinical presentation of arsenic poisoning is very much different whether people are getting a large dose, a small dose repetitively, or even lower dose over a long period of time. So clinical acute arsenic poisoning would be only present from what would be called high-dose arsenic exposure. But high dose, we're talking about a couple hundred milligrams. So this is a fraction of a sugar packet, for example, of arsenic would be enough to cause this spectrum of toxicity. And usually very early onset of very, very bad GI symptoms with very prominent diarrhea and dehydration in that setting. You can end up with other organ systems affected as noted there, but those tend to be fairly significant doses. It's much more common for people to have what's called a subacute arsenic toxicity, and this would be often following a attempt at murder, where people will show up having reported an acute GI illness a couple of weeks earlier, and now complaining of some numbness and tingling, kind of a stocking glove paresthesia, as well as just noting that their hair was falling out, funny looking lines on their nails, although not pathognomonic for arsenic poisoning, can occur with selenium and with thallium and a few other things, but you'll notice these transverse white lines, picture in the next slide coming up, and those tend to be a little bit more delayed. And so people have a GI symptom as a prodrome followed by a neurologic and hair, nail kind of group of symptoms. And if you hear that, that should really raise in your mind the possibility of a heavy metal poisoning. In this case, arsenic or antimony would be suspects, but you will be hearing just shortly about yet another metal where that it can be the presentation as well. And a lot of dermatologic changes that occur with this as well. So here, although it's not a clinical finding, once you start looking at their blood smear, for example, you'll notice that there's some fragmentation of the nucleus within the white cells, which suggests a part of the problem that this element can cause. You also notice these Mies or transverse white lines that are across the nails, and that'll actually be useful to date the period of time of exposure, because the nails grow about a millimeter a week, and so you can kind of date from the time that they clear the perinechial fold when the exposure might have occurred. And this is actually the first patient that I was consulted on, was somebody who was referred out for an oncology evaluation because of the abnormal white blood cells that had been observed, and they thought the person had leukemia. They did a bone marrow evaluation, which was actually normal in terms of any leukemia, but they had these MES lines present, and they sent off an arsenic measurement in the urine. It came back in the thousands of micrograms per liter, where it normally should be maybe 20 or 50, and we were consulted on that patient. A much more problematic issue for large swaths of the population, though, is chronic arsenic poisoning, and this is a real problem because it causes an increased risk for a lot of chronic health conditions, diabetes, cardiovascular disease, as well as a number of cancers, both lung, liver, bladder, and skin cancers, where these hyperkeratotic pigmentation will progress on towards squamous cell cancer. And this is an issue that is affecting, more than 40 million people in East India and Bangladesh at this point. Talk about that in just a minute. And I'm not going to get into it here, but the idea is that the trivalent arsenic, which is this arsenic trioxide, for example, form, has an effect on potentially a couple hundred enzymes are inhibited or altered in their function by exposure to arsenic. Pentavalent arsenic, which is what's commonly present in foods that are grown in soil that has a heavy arsenic contamination, will not be as toxic, but in the body it can be converted to trivalent arsenic and therefore presents a potential risk for further toxicity. I mentioned that the issue is most prominent here in this area of the world, and perhaps Ashish could even mention a little about this a little bit later. But this is a real concern with millions of people who are exposed in what was initially a public health attempt to decrease acute disease. By the drilling of tube wells, they go down deep, sample from the aquifers. The aquifers unfortunately contaminated with arsenic as they leached out of the normal and natural occurring ores there. But in trying to avoid a parasitic disease, now millions of people are confronted with this issue relating to arsenic. And I'm not sure you can read it up here, but this map shows you the likelihood of having an arsenic level above, and the units translate to 50 micrograms per liter. And as you can see, most of those areas are actually likely to have a greater than 50 micrograms per liter. And that contrasts with the United States' current level for EPA for drinking water, which is 10 micrograms per liter. So, it is several fold higher than that. And the highest concentrations are actually up in the 2,000 micrograms per liter, a couple as high as, say, 3,000. So these are very, very large concentrations of arsenic. It isn't only in that area of the world, though. This is a picture of the northeast United States. Actually, I live right there. And this is the state of Maine. And a large areas of the water sources off of the mountains in these areas have also what is considered high, by U.S. standards, arsenic levels. But again, these are now 5 microgram per liter, so completely different scale than what we're used to. But we do see arsenic poisoning in the United States, and this is a woman who one of my fellows saw when he was practicing up in Maine, who had noticed that she was getting more and more freckled, as she thought it was, although it was an itchy rash that she was having on her legs and the soles as well. And she was complaining of increasing numbness. This was increasing over a period of about 10 years. And it was attributed to the fact that they were using a private well, which is not regulated in our country. You're responsible for your own water condition there if you have a private well. And they didn't really stumble on this as a concern until a neighbor dug a well and had it tested and found that it had 2,500 micrograms per liter of arsenic, and this is the same water that the neighbors had been drinking for 17 years. So they needed to get a new water system in place. So real arsenic poisoning, this is what's being experienced in Bangladesh and East Bengal. If you think about it, people are consuming large quantities of water with very contaminated sources, and they are ending up with this chronic health issues. In the United States, and this is kind of to focus on the public health aspect of this, when we went from 50 parts per billion to 10 parts per billion, suddenly large numbers of water systems were out of compliance. And this is one, Exeter, New Hampshire, which on that map is just a little bit west of where I was showing you. They found some measurements that were 11. 11's higher than 10. It was less than 50. It wasn't a problem. And suddenly now they're in violation, and these whole communities have to put in very expensive systems to try and filter the water. It's gone on further, and from our point of view, they're maybe going a little too far. This is copper chromate arsenic treated wood, which is a preservative, is used in a large number of building issues for playscapes and decks, put outside the back of your house, that kind of thing. And now the concern is that this is going to leach into the soil, or people might get exposed if the kids are playing on the playscape for too long. Large number of studies coming out about the degree of contamination that that's causing. And what it basically led to was the EPA saying that no more can you use CCA-treated wood, and everybody should take apart and demolish everything that they've used. Don't burn it, because actually that is a good way of getting very exposed. But the data that they were using for that was along the lines of if you were 3 years old all your life, and ate a sandwich on the deck every day of your life, and then had a lot of hand-to-mouth behavior, you might get too much arsenic to be safe. Now, first off, you can't be 3 your whole life, and even if you were, you might vary your diet from a sandwich, and you don't have to eat on your deck every day. But that's the kind of thought process that went into some of our safety regulations. So there's a lot of data that we're not going to take time to go through here, but I'd be happy to point you to some of those. Some of the epidemiology studies that started talking about the risk for a lot of chronic health effects that drove now our safe level were based on statistically significant changes, but they were using the population in Bangladesh, where the concentrations of arsenic in the water were orders of magnitude above most of what we were having to deal with in the United States anyways, and also above where their safe levels are now. And then there were some bad studies that are out there, which is always something I want you to remember to pay attention to when you're trying to look at the literature. This was just a study where they took people who had diabetes and then measured arsenic in their urine, and there was an association with diabetes. But if you think about it, if you have diabetes and you're not in great control, you're having an osmotic diuresis, and therefore you're drinking more water. So if you have arsenic in your water and you drink more water, you're going to have higher arsenic levels. So it's reverse causation. The arsenic comes because you have diabetes, not causing your diabetes.
Last 10 seconds.
So laboratory diagnosis, we use urine as the method. Nails and hair can be done if you're doing a forensic investigation for potential criminal activity. Treatment is really supportive care, getting people out of the situation where they're continuing to be exposed. And if you have acute toxicity, as Paul was mentioning, for mercury, for elemental mercury, we do have chelators that will work. DMPS has been used and was used in that main case. Suxamer or DMSA is our ready go-to, and BAL, or British anti-leucite, is the older agent. And I'll just leave you with this, these are just some things to keep in mind when you're going through the literature. Be careful about people who extrapolate from cell culture data to humans without really taking care with the steps in between. We have to be careful when we're using regulatory language because, and this could go either way, if you say, well, it's safe for somebody working in that environment, but now you're applying it to an infant who's in that environment 24 hours a day, kind of like the difference between the mercury levels of home versus school. You want to be careful you don't misapply a regulatory framework to an individual exposure. And you can't extrapolate from low level to high level exposure just because you're ignoring a lot of reparative mechanisms as well as differences between experimental animals and humans. This has continued to be an issue. We have TV people who provide advice that people like to follow. I don't know if you catch our shows or if you have a similar issue here, but one of our guys is Dr. Oz, who's out there. And now, although he was a cardiac surgeon, he now is a toxicologist and a laboratorian. This talks about him running tests on apple juice, looking at contamination with arsenic. And actually, he's never been in a lab, so it was other people that ran the tests. But the things you need to remember is, you know, is this a setting that's got any similarity to the concern? So they were applying the levels found in juice to water consumption, and we never could suggest that people drink a liter or two of juice a day. Water is got multiple safety factors on its regulatory limit, and it's inorganic arsenic, not organic arsenic. So I mentioned the organic arsenic issue, and those are things to keep in mind, because if you take somebody and you measure their urine and they have been eating seafood or shellfish, they will have high arsenic measurements, but it's almost all organic arsenic, which is non-toxic. So you have to speciate the arsenic, which is a completely different test. It means running it through a liquid chromatograph and an ICP-MS, which is a difficult set of tests to perform. So why don't you just take away that it is possible. If you have a private well, it should always be checked for a number of different substances. If you have a very high measurement, then it should be mediated or remediated. If it's just above a regulatory limit slightly, probably doesn't mean anything for your individual health. There's a lot of different sources of exposure to arsenic, including smoking. And try to not take all the media reports as verbatim. And I'll leave it with that. Thank you.
Thank you. Chuck, you took 3 minutes extra, but then it was very interesting to listen to you. Since we are running short of time, so I won't allow any questions for this talk, because I want to listen to the next speaker, who is Dr. Abdul Qadir. He's professor and head of emergency medicine at Kansas Technical University, and he's an expert on mad honey poisoning. So who best to talk to you about mad honey than the expert himself?
Well, I'm not sure what I am doing in the poison control track, but I think it's related to public health somehow. And you must be wondering what is my topic is about. So let's start. So my name is Dr. Saad Labri. I'm actually a clinical toxicologist and an emergency physician consultant at Sultan Qaboos University Hospital in Oman. And I hope you know where my country is. It's nearby you. It is a beautiful country. So what I'm going to be talking about, you must be wondering, is it going to be about your cup of coffee that you take in the morning? Extra cup of coffee, extra caffeine? No, I'm not going to be talking about that. So I'm going to start with 2 cases which actually I had during my clinical practice, and as a toxicologist, I was involved somehow. So the first case is a 27-year-old man who was previously well, healthy, was brought in cardiac arrest, and the only positive history, he's working in a gym, and he started using supplements just 6 months back. The second case is a 29-year-old male who is a bodybuilder, came with a shortness of breath. He had been diagnosed recently to have cardiomyopathy with ejection fraction of around 20%, and he was on anti-failure medication. And he was not looking well, basically. So what is common factors between two cases? So they were both young. They are previously healthy. They are taking some sort of supplements. And one more thing, apart from the fact both of them had very bad outcome, they were looking like this. Actually very huge and muscular. So the outline of my talk is going to be about what is actually performance-enhancing drugs, what is the epidemiology all over, and what is the common misperception about them, what is the reported cardiotoxicity, and at the end, summary. And I think the right side of the screen can tell you about the whole topic. So actually, the performance-enhancing are pharmacologically produced agents. They are not supplements. They are not nutrient. They are not natural by any way, despite what the manufacturers and the company said. And the the common use for them are by athletes and non-athletes were weightlifters to enhance a performance. And that's even a misperception. Why then we should be concerned if it is an athletes or sport-related thing? Unfortunately, it's not. Well, to start with, it started with athletes, but because of the common belief, they can actually give an enhanced performance in terms of gaining more muscles, becoming more strong in weightlifting. People start using them in the public, specifically the young age group. And there have been a lot of fight initially by the ethicists, like, why not? Isn't it like we are supposed to go for physical excellence, and the more good we look, it's actually the better? But unfortunately, it's not true. So actually in US, at least 3 million performance-enhancing drug users alone, and this is just based on one studies, and it ranks on top of type 1 diabetes and HIV infection prevalence, which is really serious, which make it #1 health threat. Specifically, across all the studies that reported it, it's a very common thing in young age group. It's between 22 to 24, so the young generation are the most commonly using these drugs. And I actually have abstracts in this conference about just a pilot study that we did in the country, and it was randomly selected 120 gym only in the capital itself. It's not even all the country, which is I'm planning to do next. And the age group, almost 64% were also young age group, 80 to 40, 75% of these people are actually using supplement. And they are gym members, and again, reminding you, they're not athletes. They are actually regular people who are going to the gym. And unfortunately, 53%, they don't even know any side effects. So lack of awareness completely about side effects, and they don't even have a proper trainer or proper medical checkup, which was really shocking. So what is the misperception then? Why the young age group go for these supplements? They don't know what they are. They're just using them. Actually, it's because of the media influence. So a lot of them, they just get the peer effect, the pressure effect. Okay, I want to look better, I want to have more muscular, and what is actually the best and fast way of doing it? And unfortunately, the media is not helping, because previously the attention used to be regarding the athletes that use it just to gain competitions, and then a lot of illegal action have been done for these sport people, but then no real educations or awareness or even banning or bringing to the attention about the health risks. So most of what happened is, okay, so this sport competitor was actually rewarded because he was using illegal supplements, but nothing really beyond that. So public attention is not there. And the vast majority now, it's not athletes, are actually the normal public. They are the normal people who are going to the gym. And it is greatly underperceived. And it's not even performance enhancing anymore. Actually, now the terminology itself is changing. It's either a body image enhancing drugs or appearance enhancing drugs. They are not performance. Actually, most of the people that use them now, they are not behind performance. They are more behind looking more muscular and lean. And then there are lots of kind of reports coming out of a very famous bodybuilders who are having actually stunning, shocking death at the young age group. Despite that, still the problem continue. And this is one of the very common famous case that went to the court in US that have DMAA, which is diethylamylene, which is one of the stimulants, and unfortunately the disease was a soldier man who ended up having lawsuits by his family against the GNC websites, which is actually was really kind of advertising this product very heavily as an ultra-intense muscle gorging strength, energy power, and endurance. And now it became a banned product after a lot of deaths, including acute MI and sudden cardiac arrest. But it used to be really publicly used by the bodybuilders. So what are the cardiovascular effects that have been reported with these performance enhancers? So cardiomyopathy, myocardial infarction, you just name it, cardiovascular accidents, conduction abnormality, coagulation abnormality, and then each one of these compounds have its own kind of risk factors, because when we say body enhanced drugs or these supplements come in different shape and format and compositions. They are not only one type. If you can see, there are multiple. So you have oxygen carrying modulators that have erythrobiotin, and then you have the anabolic agents. You have also adrenergic receptors antagonists, and you have also the receptor modulators. So it comes in multiple things, and the cardiovascular risks that are reported here are mainly the direct cardiovascular risk. There are also other indirect cardiovascular risks. And if you can see, the majority of these reports come from the anabolic agents or androgenous anabolic steroids. So we'll move on to the anabolic steroids, since they are the commonly reported cardiotoxicity literature actually come from those agents. And the mortality among athletes using these supplements is almost 6 to 20 folds more than the clean athletes. This is only athletes report. And 1/3, as I mentioned before, one third of these deaths are actually related to cardiovascular. So what is the direct? As you see in the previous slides, it's either dyslipidemia, so they can have decreased HDL, increased LDL, and then this is more pronounced if they are having oral intake of these anabolic steroids. You know that they come in injectable format, and unfortunately in my study, it was very hard for us to get this information out, because injectable anabolic steroids are illegal there. So it's kind of going to be very hard to convince people to disclose this information for even a study purpose. But I know it exists, and I know people actually getting it illegally from other sources. And the other sad part of this story, actually, performance-enhancing drugs, and this also reported in the literature, it's the door to start using even other illicit drugs. So usually it starts with supplements, and then they move on to any other kind of drugs. And in my country, I actually noticed this in my clinical practice, like most of the drug abusers actually are commonly going to the gym and getting their drugs even from the gym. I'm not saying you guys don't go to the gym, but it's a common factor. So what is the evidence also existing for their cardiovascular toxicity? You have also postmortem. Most of the evidence existing are by case report and case series. As everything in toxicology, it's very hard to have ethically approved study to compare the effect between these supplements. But then postmortem and experimental, there are actually recent conduction studies that showed decreased cardiac electrical stability. Autonomic cardiac regulation is also affected. You have abnormal ventricular reboalization, and as a result, you definitely have more risk of arrhythmia. And this specific finding was also tested in rats, and it was proven to be also correct. There was also other study looking at 87 diseased men, and which were tested positive for anabolic steroids. And what they found, they had great cardiac mass comparing to other kind of men if they adjusted all other factors. And also there is ventricular hypertrophy, fibrosis, and myocyte lysis in cardiac death in anabolic steroids. What about radiological studies? So this is in living people who are actually using anabolic steroids compared to those non-users. There is definitely decreased ventricular ejection fractions, reduced diastolic tissue velocities, and one study is demonstrated specifically decreased aortic elasticity, and I'm going to discuss this later on. Again, there is also coronary artery calcium scores higher based on the also radiological studies compared to men at a comparable age, which again put them at risk of atherosclerosis and MIs compared to normal populations. What about human growth factors? Isn't it that if you grow bigger, it's going to be better? I don't think so. So it's actually little known specifically about the cardiovascular effects, but if you see the acromegaly patients who have actually excess, like if you just extrapolate the results of acromegaly patients, they have hypertension, congestive cardiac failure, and cardiomyopathy. So you can guess if they have excess growth hormone, definitely risk of cardiovascular is there. Beta-alanine supplements is one of the commonly used now between athletes and non-athletes due to the illegality of anabolic steroids. Actually, it's found in 60% of sport codes, because now it's self-reported, because it's actually not a ban product. And what do we know about the supplement itself? Is it really toxic? Studies of adverse effects itself is not really there because we need time in order to see the long-term health effects with these supplements, but neurotoxicity, respiratory distress, myotonia is all seen in humans who have excess beta-alanine in metabolic cases specifically. So again, if you extrapolate the results, you could expect some effect to be there. And this is also one study done in Tour de France cyclist events, which is a common cyclist event done. Actually, the first cardiac death happened in this event. It was back in the 1960s, but this study specifically checked between 2 years, like 1995, the blue one, and then 1999, and they were checking their ejection fraction and cardiac mass by echo, and they noted that their heart is becoming bigger as the year go, and they're actually their function or ejection fraction is becoming less. And at this specific year, the use of performance-enhancing supplement was becoming very popular. So that's one thing to be put in mind. Animal studies also have demonstrated some bad effects of clenbuterol. So there was increased atrial and ventricular size and increased aortic root again, and kind of a decrease in the elasticity, and they noticed actually sudden death in horses. So this is experimental study done in horses, and the poor horses end up dying from aortic rupture. There are other modulators or androgen receptor modulator, and the reason why these substances came in because androgen steroids were becoming illegal, so they were trying to bypass detection, so they brought these receptor modulator. Common example is thiomycin beta 4, and they dissociate the androgen and anabolic effects, making them undetectable. Still, very little is known about their cardiovascular risk, but if you just think about it, if they are going to be acting on the same receptors, probably effect is going to be there. We just need to wait and see the effect. And the end results for some of these people, so if they did not die, some of them, they may end up having really very bad cardiomyopathy. And the example is the patient I saw. He was huge, young, but cannot even walk without assistance. He will probably need eventually a heart transplant. His heart is big and not working well. And some of these people walk around with their external ventricular device, assessing them in their daily lives. So in summary, it's actually a very common use in young, and this is even in my country, leave alone other countries, and even in US it have been reported. There are many types, and unfortunately the young generation, they don't even know what they are using. They just want the quickest way to look fit, big, and lean, regardless of what will happen next, and this is really striking and frightening. And there is no awareness of adverse effects, and there is no even increase kind of public educations regarding this, because it's having lots of opposed action from the companies who are making them. Actually, what I came to know, that trainers in the gym, they get some sort of commission and advantage the more they sell these products. So it's a kind of a revenue and big business. So it's going to be hard to actually oppose business. And lack of regulation and proper control. A lot of these are regulated in the sport activity scenes, but in public there is no proper actually control. People can access whatever they want, and there is no shop, no place now where they don't have the supplements displayed there without a proper warning. And definitely cardiac toxicity does exist, including sudden death or long-term cardiac diseases. That's all about my presentation. These are my list of references, and keep calm and call toxicologists. Thank you.
Thank you. We have time for 2 questions, I think.
Any questions? Yes.
Please.
Yes. That's striking?
Maybe not. Supplements, is it like multivitamins? Is it on?
So supplements, no, so supplements, what we specifically meant, supplements in the gym. So it's not, they were not talking about vitamins. And even majority of them, they don't even know. They are just buying supplements to enhance their performance and gaining more muscles, but they have no idea what supplements they use. Some of them, they were actually not kind of keen to give us the informations because they were afraid that some illegal actions will be taken about. But I knew, like from my own sources in the gym, they are injectable, like some of these supplements come injectable, and most probably they are steroids.
Is it the time now that there should be some regulations for any gym to be open?
Absolutely.
To have a specific recommendation,
Absolutely.
to be assigned to a physician, a doctor, and maybe not to leave it like this?
Absolutely, and this is what I'm trying to do, because the first thing you need to prove that problem exists, and you have to submit the data. So what I did only a pilot study in Muscat. Now I'm planning to extend my study to include all the country and just to screen what's going on there. And I'm trying to get more information to actually submit it. Huh? Oh, great. And the thing is, the problem is, what I noticed, lots of opposition from the gym themselves to participate in the studies, because again, it's a money-making revenue for them. Like the more they provide supplements, the more they get money, and they try to convince people who are there to actually, and you know what's striking, which I did not mention, many of these actually users are undergrad. They're too young even to be knowledgeable to know or decide. They're undergrad. They are not even like, they just either finished their secondary school, they're just in college, so they don't even have the full potential to understand the consequences. They just want to look good, no matter how they will end up.
I have one question. In your country, is it easy to buy on internet, or there is?
Yeah, this is another thing which in US probably it's very easy to get things through the internet.
Yeah.
Well, we don't need to bring it through the internet.
Exactly.
A lot of people smuggle things through the borders, and it can get access easily. So they don't need to order it through the internet, so they can get it delivered to them in the gym. And as a toxicologist, I'm telling you, most of what I see as overdoses cases, when I ask them where are the sources you get your drugs, it's the gym. Like they have a connection, they can get things easily.
It's the same on Italy.
Yeah.
Okay, thank you.
There are a lot of shopping centers.
Yeah. Vitamin shop called.
Like there are so many gym there, but probably only 2 are certified for selling specific products. The rest are just on their own, unfortunately. Yes.
Please.
So I'm curious, with these drug users, are they doing injections?
Yeah,
IV
this is what I try to get. So even when we went to the questions, is it orally or injectable? Nobody want to answer the injectable ones, because the moment you say injectable, it's actually most probably anabolic steroids. So I had hard time getting any of these answers, but they were answering we were taking supplements. So I have to go again and review my data with the members who were with me, and then actually when they question, without them, they said, we are not going to write, we are taking injections, because they are so scared to actually declare this information.
So my question for injection drug users, does Oman have resources for harm reduction to prevent transmission of diseases?
Actually illegal, so injectable supplements are illegal in the country. They are not supposed to come there. But again, we are talking about getting it in a legal way, and still they are using it the way they use IV drug. It's illegal. I mean, IV drug abusers, they use IV, right? It's illegal, but still people can get access to.
Sure,
so you are talking about infection risk the same way that it's existing. But how to monitor it, how to report it, that's the challenge.
Understood. But are there practices in Oman to provide people clean needles and teach them how to prevent?
Oh, no, they are so meticulous now about actually getting their own needles for injections. So risk of infection probably is less. So they get a one-time loaded syringe, I guess.
Thank you.
Thank you.
So thank you. I think we can go to the coffee break.
Okay, thank you.
Thank you. Thank you all the speakers.
Audience to join us. So we're going to start this afternoon session on clinical research in emergency medicine. Our first speaker is a regular Manitox presenter and well-loved. Dr. Lisa Marina Walton is a professor of EM at Louisiana State University, president of the American Academy of Emergency Medicine. Besides having an MD, she also has a master's in clinical research. Lisa has numerous research grants, over 350 national and international research presentations, and now she's going to speak to us about emergency medicine research.
Thank you. Okay, I don't have a microphone, but I don't think you'll have trouble hearing me. It's kind of a small room, and I've got a big mouth from the South Bronx. So I'm going to talk to you a little bit about how to conduct research in the emergency department with somewhat of a focus on toxicology. The clicker is not working. Can you plug it in? Give me something that works. This doesn't work. Okay, good. All right, so we're going to talk about what research is. So I like to use the NIH definition of research. It is a systematic investigation designed to develop or contribute to generalizable knowledge. So there's a little bit of a problem sometimes with generalizable knowledge, as we saw with the panel discussion last time. Generalizable, it doesn't always work, especially in toxicology, right? Snakes are not the same in every country. I think they can hear me, thanks. Envenomations are different. Poisons are different. You see a lot of organophosphate poisoning in Eastern countries. You don't see it as much in the US and Canada. So generalizable knowledge can be a problem, but certainly doing a systematic investigation that is well designed and develops knowledge is critically important. So how does good research start? Good research, I always like to say, starts with a good doctor. So you're a good doctor, you're in the emergency department, you're doing your toxicology consults, and you start to think about why do we do things the way we do them, why do diagnoses present with certain symptoms, what resources do we need to give better patient care, especially important in toxicology with antidotes and antivenoms, and can teaching be enhanced? I notice that patients do better when I do X. So all of these things can help you to develop your research question, and then you have to pass certain tests, right? Now there are a whole lot of tests that people use to say, is this going to be a publishable project? Is this going to be something that I can do? And I'm going to go through these one by one. These are the ones that I use. So who cares? So a common question is, you may be passionate about something, but other people might not. But everybody is passionate about teaching. But there is a certain problem that I see all of the time with junior investigators, and that is people who are teaching in a clinical setting devise some sort of a teaching tool that they use and that's very effective, and then they want to publish it. So they say, well, we're going to find out whether people know more after they use my curriculum and whether they're more comfortable doing this procedure or engaging in this particular patients with this particular diagnosis. So I'm going to steal a quote from Michelle Byros, and Professor Byros was the editor of Academic Emergency Medicine for a number of years, and she said, look, medical students and residents are intelligent people. If you teach them something, they'll learn. And if you let somebody do something, they're going to be more comfortable with it. So this is not the kind of a thing that anybody cares about. This is an example of something that somebody's going to say, we know the conclusion before you did the study. So what else can you do? What can you do instead? There are plenty of venues, online and otherwise, in which you can actually publish in a teaching journal your curriculum. And then what are the kinds of things that people do care about? Can you put a certain twist on it? For example, instead of using faculty, can you have senior residents teaching juniors or residents teaching medical students? Do you use simulation in a way that's never been used before, such as disaster? Instead of doing a tabletop exercise, can you do a simulation exercise? Think about what's important in learning. Right now, we're focusing on retention. There have been a lot of studies in this. know. So if you have a pre-verbal child, you can't necessarily know why that child is screaming and yelling when you take them to CAT scan. There are other things that you simply can't do because you just don't have the data available, or you don't have an electronic medical record. Because we can query an electronic medical record and say, I want to look at every single patient who came in with an organophosphate poisoning in the past 10 years. I can look through my EMR and look at my ICD-10 code and find that out. But what if you can't do that? What can you do instead? Well, you can try a questionnaire asking patients if they would share information that you don't think is available. If things are not recorded in the chart, do a prospective model, right? So if you can't query the chart for all the ICD-10 codes, say, let's start a prospective study. Let's look at all the people who come in with organophosphate poisoning or a oral snake contamination. Enlist your colleagues and make sure that you're getting all those patients. You can have a student or a resident who every single day goes back and hand checks every single patient that registered in the emergency department and what they registered for. The things that we may do retrospectively in countries where we have a vigorous electronic medical record system, you can do prospectively in your country by having vigorous medical students who are willing to check for those things. You can get a team together to extract data from a paper chart, or consider using a shorter study period or 2 study periods, right? If you want to take, for example, winter and summer. So in my country, winter and summer will affect what kind of examinations big silo things. Think of a disease with high stakes. What do you notice about patients who do well and patients who don't? And study that variable. Talk to your basic science colleagues. They have access to some of these tests that you don't have access to in ED. And instead of writing a grant and trying to get money so that you can run the test, talk to a colleague in basic science who also wants to publish and likely has the assays and can run those tests with you. Can you devise an intervention that can fix a problem? look at what is going on. All right, I have a few minutes left. Okay, so think about the practice of evidence-based medicine. If you need me to convince you why you need to do work in your part of the world. A lot of the surviving sepsis data came out of the West. How many people are familiar with the FEAST study? I'm going to tell you, the FEAST study was a study that was funded by the British, done in Africa. They did it conscionably. They actually involved African doctors as authors and primary investigators. But what they found when they applied the sepsis bundle to African children, they found that they were killing black children by applying the sepsis bundle. They were giving them abundant fluid and they were dying. And the safety monitoring board of that study shut the study down after there were 18,000 kids in the study, but they shut the study down. And why? Because they realized that what happens in countries that are not first world is very different than what happens in countries that are first world. 80% of the published medical literature comes from
1 minute.
and those 20 countries are not these, right? I just gave you the list. Other than Brazil, China, and India, there are no countries outside of predominantly white Christian nations that are putting out research. You need to put out research because what happens in this part of the world is not what happens in other parts of the world. The way that first world countries respond to interventions is not the way that developing countries do. So I hope I've convinced you that it is important for you to do research. And I hope I've given you some ideas as to how you can more effectively do research on a budget with the resources that you have. Menotox is leading the challenge. You have a lot of people here that are willing to help you. I'm one of them. So use your resources and let's see a whole lot of research come out of this area. And we want to be publishing it in MedJet and presenting it at AAM. Thank you.
Thank you.
First of all, I have, okay, this is not working.
Okay. So that was published in The Lancet in 1878. This image that you see here is basically the first documentation of the term telemedicine. So they talked about how they have telephotography, so now they need to have telemedicine. This was in 1927. Obviously, at that time, everyone thought this guy was crazy, but now it's actually happening. After that, we started having satellites, and with satellites came remote monitoring. NASA started using the satellite technology to monitor the physiological measures of astronauts in space. Now, that same technology, the image you see here, that's the ATS satellite in NASA. This was in the late 60s. They started using the same technology they used for the astronauts. The image you see there is a 1985 earthquake in Mexico. That technology was combined with the 1985 earthquake in Mexico to help people with telecommunication and aid in the relief support during that earthquake. And that was the first time that telehealth or telemedicine at that point in time was used in a mass casualty incident. Present day, this is present day, the image you see here. This is our Incident Command Center in the Ministry of Health. As you can see, there are tons of screens. All these screens are part of a completely integrated telehealth system. They're connected to all the hospital incident command systems and to the ambulances. So you can see exactly what's going on just by sitting in one room. I'll talk about that a little bit later. So why am I talking about telehealth? Because the current management of any disaster scenario or a mass casualty incident, it has holes. What telehealth does is fill in the cracks. The cracks that we currently have in our management, telehealth fixes them. So this is the systems that we currently have in Kuwait. It kind of matches the majority of international systems. You call 112. 112, the call is dispatched to the EOC, which is the Emergency Operations Command. Then they will activate the HICS, which is the Hospital Incident Command System, which then activates the ICS, or they can directly activate the ICS, and the ICS can activate the HICS according to the scenario. So, sit, close your eyes for like 20 seconds, a little medical meditation. Imagine that you're receiving multiple calls in a metro station, and they're telling you there are tons of patients, they all have shortness of breath, they're all vomiting. What do we do? Most of these patients seem like they're going to be tagged red. What happens currently without telehealth? Imagine that scenario, and I'll go through the scenario with what happens with telehealth. This image is basically the sarin attacks that happened in the metro station in Tokyo. So this scenario that I'm running through is similar to those. What's going to happen? Step one, you're going to get a dispatch of ambulances. These are ICU ambulances. All the monitors you have here are also integrated in the telehealth system. You can get ultrasounds that can be integrated in the telehealth system. So basically it's complete. You can re-triage, you can manage your patient through the ambulance. This is another option that you have in case it's needed. This is the HEMS, so the Hospital Emergency Medical Services or the Air Medical Services. They can also be activated as necessary. So this is basically dispatch. Now, what happens on scene? This is on scene. This was a triage scenario that we did, an MCI scenario that we did. You're going to see patients. They're going to be attached to monitors. So they're going to be tagged according to the start triage system. Now, in telehealth, what changes? This is what changes. On site, your paper triage tag is going to be changed to a PDA, which is basically a handheld first responder device. The handheld first responder device, you just scan, and it triages your patient. When you triage that patient, that information automatically goes into, it becomes data. How does that help me? Number one, it makes everything faster. Number two, I automatically have data. I don't have to have a paper and collect paper, and the paper gets lost. This is not going to happen. This also helps me with research, which you'll see how it later on affects preparedness. En route. En route, what happens? So you have the EOC, which is the image you see on the right, and you have the image on the left, which is the Hospital Incident Command Center or the telehealth center in hospitals. If you see at the EOC, you have two screens. One screen where you can have a video of the patient, and the other screen where you get the vitals. You can get full ICU set through that screen. So why is it relevant to toxicology? If you have a patient with a toxidrome, what you see on those screens is basically all you need to make your diagnosis, give your patient the antidote en route, and then re-triage them. If necessary, they might start red, you give them the antidote, they become green. What does this help with? you're decreasing, when you're re-triaging your patient or you're treating your patient en route, you're decreasing ED flow. You're decreasing the flow to specialty centers. You're helping out the EMS, which are overrun and overwhelmed at that point in time. So this is basically what happens. Studies have shown that if you use telehealth, the number of deaths that occur during transfer from scene to a specialty center decreases. Total transfers decrease. Total number of ED beds used decrease. That increases your medical surge capacity. And ED waiting times also decrease. So it's a win-win situation. It's a lot of technology. It may be new to people, but actually putting this into our practice helps us out a lot in many, many ways. So if you think of telehealth and you think of the phases of the disaster response, it affects every single phase of the disaster response. So with preparedness and mitigation, we already talked about how what you are doing with telehealth is collecting data. Anything you get from your patient that is on your screen is automatically data. You use that, you can publish research. It's easy. You have an EHR system. You take the data from the telehealth, publish research. What does research do? It enhances our planning. It enhances our preparedness. We know what went wrong last time, and we can make sure it doesn't happen next time. What were we missing last time? We'll apply it next time. Response. We already talked about PDAs, assisting in field triage, electronic triage tags. Another point that we need to take account is virtual increase in medical surge capacity. So what is that? That's basically you're on field. You're lacking physicians, or you're lacking any healthcare providers to triage your patients. You can virtually have another physician on the site, and that physician is going to tell you, well, triage this guy red, triage this guy green, triage this guy yellow. That increases your surge capacity. Also with transport and treatment. Like, as we said, we can treat the patient en route, or we can retransport, or we can send home. Recovery. There are certain pandemics or MCIs that usually have a very prolonged recovery. Things like pandemic flus, earthquakes, tsunamis. You can assist with the recovery of the patient via telehealth. You can provide like doctors virtually to assist patients at home, to follow them up. You can follow the labs of your patients virtually, especially for psychotherapy services or family support after a disaster. That can also be all done virtually. Also, you have inter-hospital communications. So let's say you have an ED and you have a specialty center, and the specialty center wants to downgrade so they can provide more beds. Telehealth gives you that. It allows inter-hospital communication. Another thing that you can take into account is the EMS. Now, if the EMS is transporting one person to another place and you don't have a physician to assess that patient, you're going to overwhelm the EMS capacity. So basically, that inter-hospital communication really decreases all the weight on the EMS services. That is basically the telehealth. These are my sources. That's it. Thank you. Any questions?
Thank you very much. We'll take questions actually at the end of the session.
At the end. Okay. Thank you.
So this morning, I've been asked to talk about occupational chemical exposures and the role the Poison Center plays in managing these cases. And I have a unique perspective because we do have relationships with other agencies that allow us to work on these cases. So just a little bit of housekeeping, so I don't have any disclosures, but today what I want to do is make sure you understand the ways that poison centers can impact, the impact we can have when dealing with occupational chemical exposure events, understanding the importance of developing partnerships with other agencies. And then I want you to think about the last time there might have been a chemical event. I want you to assess in your mind what role your poison center or what role you played as a toxicologist in that event. So just a reminder for those of you who weren't at my talk yesterday, I am in Atlanta, Georgia. We are a population less than half of what it is here in Istanbul. We have a population of 10.5 million people, and we are housed in one of the largest teaching hospitals in the southeast. Dr. Kazi, is it an 800-bed hospital? So yeah, something like that. 800-bed hospital in our institution, and the Poison Center is a department in that institution. We're one of 55 in the United States, as you probably know, and we are quite busy. You know, around 300 or so calls every day handled by our Poison Center. Now, in order to handle these calls, we have fairly advanced call handling capabilities, and you could compare them to what you have in your area, but communication technology and making the connection is important for us to report these cases. So for us, we have a very feature-rich telecom system. And what do I mean by a feature-rich telecom system? Well, we have various ways we can affect the queuing of the calls that come in. We have in our system what is called skill-based routing. If you're unfamiliar with skill-based routing, is say, for example, we have someone who speaks the Turkish language calling in, and they only speak Turkish language. And many of us speak English. If there's one person in my department that could speak Turkish, we will give them a special designation. So even though they're still waiting for a call and they may be fourth in the queue to answer the call because they've waited a short amount of time, if you speak Turkish and you're looking for someone who speaks Turkey and they're available, the call will immediately go to them. And in our situation, we do get calls from Spanish-speaking people. Most of us speak English, but if I'm waiting for a call for English and I do speak Spanish, even though 3 of my colleagues are next to answer calls, the call will be routed to me first so the patient doesn't wait long. So it's called skill-based routing, and we're able to do fancy maneuvers with the way the calls are accepted. We also have the capability of working from home, and that's always a good benefit. In fact, some of our poison specialists work from home about 70% of their work. So 7 days out of 10, they may be working from home. They don't have to come into the hospital. They don't have to come into the office. We give them equipment. We give them a phone. We give them our resources, and they work from home as if they were in the office. One of the unique things about contacting us is that we were the first poison center in all of the United States to start accepting chat messages and email live. So these chat messages and these emails would go and mix with our phone calls. And so whether you're chatting, whether you're emailing, you could contact the poison center. Now, I don't know about some of you, I have older kids. They're in their late 20s. They don't use the phone anymore to call. They only use texting, and they only use messaging. So we have to adapt our practice so that we can attract some of these people who use alternative ways to contact us. One of the things that we're going to be adding in 2020 is accepting emergency calls by text messaging. So we have very elaborate equipment, so you can call us, you can chat with us, and you can email us, and the call or the encounter will be happening in real time. So that's what's important. Now, when you look at our technology in the Poison Center, not only do we have one phone system, we have a backup phone system. Whether that system goes down, we have to be able to provide 24-hour support to our service area. So we have 2 phone systems in the office, we have 2 phone systems in people's homes. So we're able, if in the event of an emergency, to be able to provide our services without interruption. We also have 2 different lines coming into the Poison Center. So if one of these lines get cut off, we still have backup lines to provide telephone services to the people and the public who use our phone system. So there's a lot of redundancy. And as you think about what you're doing in your centers, what you're doing in your poison service area, for us, we have a contract with public health, and we told public health, we will be available every minute of every hour of every day, regardless of the technological failures. Because all of us know things break. It's never always perfect to have communication lines open. So we have all these systems that allow us to have service. So when we have a chemical event, people will be able to call, even if one of our phone systems is not working. Now, I don't know about your capabilities, but because we're so busy, we can handle almost 70 calls simultaneously into our office. Now, the problem is I don't have 70 people working at the same time, but 70 people can simultaneously call into our area, into our phone system without getting a busy signal. Now, what happens in the event of a chemical event, a mass exposure? Will your phone system be able to handle the extra calls coming in, or will they always get busy signals? We invested our money in technology that allows us to increase the number of calls that come in to our center without a busy signal. We can handle almost, and you'll see shortly, we could handle almost 10 times the amount of calls without someone getting a busy signal. Because there's nothing more frustrating if you're calling emergency and it's busy. So we have the capability to turn on the programs that allow us to increase capacity. And I'll talk about the technology here. So it's called the SUFER phone system. I mentioned it the other day, I didn't really elaborate, but SUFER stands for Surge Public Health Emergency Response. This allows our system to increase and expand our capabilities, but it's a technology that we've had for almost 10 years now. And not only does it provide access to more people, it also has a unique feature of being able to put messaging as if you were choosing messages from a phone tree. Press 1 if you want to hear about the common signs and symptoms. Press 2 for treatment. Press 3 for should you leave your area because of chemical gas. So instead of talking to a human, you can listen to live messages that are built for that specific event. Instead of talking to a human, I may only have 12 or 13 people in the call center. But if there's a mass event, we have in place a way that we could give people messages. Now, if they want to call us, listen to the messages, and still want to talk to a human being, there's a way for the system to route that call to a live person. So, when you look at this hotline, if there's an emergency in the state that requires, messaging, we can handle up to 580, almost 600 calls at the same time without our phone system breaking. Because you've heard of crashing the internet, right? You've heard of crashing a website. Well, why does that happen? Too many people are accessing the website, and now you can't do it anymore. The same thing works in phone systems. So in the event of an emergency where you have many more calls, your capabilities have to be increased or they will break your phone system. So we have the ability to handle almost 600 calls. And the reason why the state wanted us to have this technology is they wanted us to be prepared in the event of chemical exposures, chemical emergencies, mass exposures, for the public to be able to access us. Now, the beauty about the messaging in chemical events is it's all text to speech. So if a message is developed, we type it, we type the message, and then the translator for the computer converts it to words. And so we can put many messages, as you could see here, you could put many messages into the system and many options for someone to listen to various messages. You can, when we are asked to do special messaging, it probably takes us 30 minutes to 1 hour to fully configure the system. The one thing that we ask our partners in the health department to do is write the messages for us. We'll load it into our system, we'll type it in, we'll load the program, and then automatically the messages start talking in computer voice. So it's a great system to have in the event you're looking at developing messages in the event of a mass emergency. Now, when someone's calling in, if there's a fire in Istanbul, and you want to just let the people in Istanbul know, as opposed to if you're in Cappadocia, if the fire's only here, then you will hear specific information about the fire here that has toxic fumes. So what you need to do is call the special number, put in the designated area number that you want to hear messages for, and then you choose the message that you want, and then choose the options if you want to listen to all the messages or you want to talk to a live human being. So that's what's that's the beauty of this system, is you could listen to the computer messages as well as listen to the live voice. Now, the whole purpose of this talk is to talk about chemical occupational exposures, and we have a unique perspective in that we actually published a paper not too long ago, I think in 2017, about the relationship that we have with a governmental agency to enhance and to recognize those exposures that happen while someone is in the workplace. So these are occupational chemical exposures, and we are working with a government agency called OSHA. I don't know if they have a similar organization here in Turkey, but who is OSHA? If you're unfamiliar, back in the 1970s, the US government and the Congress passed legislation that called for a law that requires safety in the workplace. And the name of that organization they called the Occupational Safety and Health Administration, or OSHA. And what this was to promote and enforce standards for safety in the workplace. And so we have this government agency that really tries to enforce safety regulation, because when you look at the incidence of injury, there are millions of people who suffer, in the workplace. In fact, reported on a yearly basis, over 4 million workers suffer some kind of serious job-related injury or illness. And that's a lot of exposures. And so in 2014, we started doing exposures in the workplace, and we started not only tracking them, we were getting the calls already, but we were starting to report the calls to the government agency. They never asked for those calls before, but we had the database. So we would collect information about the patients, the poison specialists and the doctors would give advice
on how to treat these patients. Now, the one thing that was different is when you call into our poison center, every call is kept confidential and private. We don't release the information to anybody, even the government. So we ask the patient, if you were having a problem in the workplace, will you give us the permission to notify the government that you had an injury at work? Some people, they were worried about retaliation, and so they don't want to give any information. Other folks said, yes, I want the government to investigate. So I'll give you my name, I'll give you my number, I'll give you the company that I work for. So we have to ask everybody for the permission to release their name.
But what about if they tell you, yes, let them know, but don't tell my name?
Yes, that's the first thing we do, is we release the information to the government, but what we do is we blind all the cases. So the government doesn't even know the patient. We are just trying to get permission to release the fact that an incident occurred. We don't ever release the name, but we do identify the company so that there's the possibility of investigation. Now, with OSHA, every week we collect data from the workplace, and every week we submit them all the cases. In 2018, we had over 800 cases from the workplace that were reported to us. Of the 810 cases, only about 25% allowed us to release information. So not everybody, because they may be worried about job security. Now, one of the things that you have to do when you're having a program like this is you have to educate your staff. As I was talking earlier, Doctor, about the poison specialist, all our cases are documented. Now, the beauty of our specific EMR is that if someone has a workplace exposure, once they code and they use the code that the exposure happened in their place of business, automatically a reminder comes up. So if you tell the computer this happened at work, a reminder comes up that says, hey, what kind of occupation is this person? Will they allow us to pass their information to the government, so that our intakers of the calls will be reminded, so they don't forget that this is a unique case. So we have unique tools that allow us to remind us that we must ask more questions, okay? So I'm going to give you a couple of examples of cases where they called into the poison center and then we released the information to the government. For example, in this case, you have a 23-year-old who went to the emergency room after they were exposed at work to chemicals in their eye and their skin. They suffered burns to the cornea. The patient allowed us to give this case to the government, and when OSHA came in to investigate, they found some interesting things about this company. This company is an oil change company, and they failed to provide eye wash stations and other decontamination stations at work. They did not have the proper documentation at home, and after the government investigated, they fined and gave serious citations to the business of around $21,000. So the government said, you're not making your workplace safe. You have to fix the issues here before you can open your work again. In this case, case number 2, there was a 50-year-old who was exposed to chemicals for swimming pools. These chemicals fell onto his head, face, and chest. He was washed at the scene. He went into the emergency room with respiratory distress and altered mental status. OSHA came in and investigated, and here's what they found. When they investigated the company did not even report to the government that one of their workers was injured. There's a requirement for the government, in these kind of businesses to report when a patient goes to the hospital. So failure number one, they did not report the incident. Number two, they did not provide a place that had that was free from hazards. They did not have body washing or eye exposure capabilities. They did not have the proper documentation in place for the chemicals, and they too were also cited and given tickets, and they were fined almost $30,000 for their issues. So there are many work-related exposures that get called into our poison center. We were able to collaborate with our government organizations to make the workplace safer by being able to report these cases to the government. And it's important for us that we had this relationship to forge with OSHA. So in summary, if you're looking at starting with a good communication lane for your patients to call, make sure you have a robust communication strategy. Do your job well, but once you've done your job well, look for other ways you can impact your community. And for us, it was a matter of recognizing that there were exposures happening in the workplace, that safety was being neglected, so we formed a partnership with the organization that looks for safety in the workplace, and we wanted to make, at least in Georgia, the patients that much more safer. Thank you.
Thank you. I think we have time for one question. Okay.
Replaced by the PCC specialist. Is it any risk?
So the question is there, because of technology and the explosion of technology, will there ever be a point where we'll replace human beings and only have a technology?
Yeah.
I don't think there's any risk for that.
No.
Because you could write a document, you could have an algorithm, but you need someone to interpret it. You need someone to understand it. And so I don't see technology being the only answer. You have to rely on experience.
Yeah.
You have to have bedside consultations. So technology
I agree with you. Thank
will,
you.
will never.
Thank you, Yellow. I'm totally agree
And
with
Andy,
you.
I could talk to you, Andy, afterwards. I could talk to you, Andy, afterwards.
Okay, so next speaker is Dr. Suad Alabri from Oman, and she's talking about cardiovascular complication of performance-enhancing drugs. Please.
I had a question for Dr. Sultan. First, I wanted to ask what happened to the camel, but you already answered that question. Secondly is you talked about how grammar has changed from one research to the other. What is your opinion on using websites like Grammarly, which automatically changes the grammar for you in whatever whatever you have?
Yeah, I use Grammarly sometimes. There are many softwares you can use, but sometimes you have, even after you use the software, you have to read it to make sure that it makes sense or not. You can ask sometimes a colleague, because even if you hire native English speakers, sometimes when they change things, the meaning would be changed. So you have to follow up after them. Was this the answer for you? Yeah, regarding the camel, usually they slaughter the camel quickly so they can get benefit of the meat. Yeah, but mostly he was killed instantaneously.
For the most question, I kind of request you to ask your question and break, because the time is over. We have to run to catch the time. Thank you very much. We are going to finish this section. Dr. Kasi, one time we have to be here again.
Yeah, so the next session starts in just 6 minutes. Thank you.
Thank you very much. Thank you very much.
As I would like to present the next speakers, Dr. Sultan Al-Waji. He is an epidemiologist and independent researcher working in Jeddah, Saudi Arabia. Graduated from Al-Qurra University in Mecca with Bachelor of Medicine, Master of Public Health from Johns Hopkins School of Public Health. Dr. Sultan, you are welcome. You have 25 minutes, please.
Although case report is underestimated sometimes, for one reason, because many people read it, but few people cite case report, because usually case report about rare things or atypical presentation. It's not about something common. That's why it's not very widely cited. That's why the editor of the journals sometimes do not like case report. But if you want to write a case report, you have to make sure that you are submitting the case report to a journal that is interested in case report, or they are publishing case report, because you don't want to go through a lengthy process, then you figure out the answer from the editor that actually we do not publish a case report, which it happens sometimes. So at the beginning, what's case report? Can you report anything, or it has to have specific like feature or criteria? What do you think? Can you hear me now? Or do I have to go back to my so case report, it's not necessary to be very rare. Sometimes when you want to report a case and you ask a friend or a colleague, and they would ask you that, you want to put the time? They will ask you, okay, that's fine. They will ask you, this case has already been written. So why you are writing this case? So somebody published it already. Why you are writing this case? It's not necessary to be atypical or very rare. Sometimes for educational purpose, let's say sometimes to increase awareness about specific disease that's not common in specific area. Because the main idea is to communicate with your colleague, to communicate with the other healthcare providers that we start to see these things. For example, in Saudi Arabia, let's say that I remember a friend of mine said that female, she was a back passenger and she asked the driver to drive. He refused, but she insisted, and she was coming out of a party and she was drunk. This is new. So she drove, and she was involved in road traffic injuries. The driver was in the ICU. So it was critical. We are not used to see these things, but start to happen. So you want to increase the awareness of law enforcement people and the clinician that driving under influence start to happen in this geographical area. I said the journal editor usually do not like it because it's not cited, but sometimes because it's at the bottom of the evidence-based pyramid. We usually start from expert opinion, then we go up, and the case report usually it's down. It's not like randomized controlled clinical trial. But for rare things, you cannot actually do randomized controlled clinical trials. So sometimes the case report is the start of, let's say, a systematic review meta-analysis. Most of the bigger research started with observational study or even case report. Like Dr. Lisa, when she mentioned about the HIV in the 1981, it was a case reported in the CDC, the weekly morbidity and mortality report. Then another case came from San Francisco. A third case came from New York. Then it became as a case series. Then somebody started to do official research to figure out what's going on. Sometimes atypical presentation of common disease. Challenging sometimes case. So the main thing is a learning opportunity or like highlighting a message of this case. What's usually it's not reported a lot, failure story. we need people to write about their failure. Let's say that you used something new, but you missed it miserably. We need to report about this because that's fine. Because if you do something and you fail at it, and you report it or you communicated with other physician, you are increasing the awareness that this technique does not work. So I mentioned all these, not necessary to be the first case. This was the Kaposi sarcoma in the 1981, published in the Mortality and Morbidity Weekly Report. Case series is 3 or more. Some of the people said it's 4 or more of the cases. You can call it case series. But if it's 1, 2, up to 3, you can report it as a case report. So what's the structure of the case report? Generally speaking, in research, we have specific form. We call it IMRAD, which is introduction, method, result, and discussion. And you put conclusion. So this is the main structure we usually put it for any research. But for the case report, it's a little bit different. And the good thing that case report mimic your clinical documentation. So you put an introduction, why you are writing this case, brief sentences about the disease you are describing, then case presentation, clinical history of the patient and the significant things, the management or the outcome, then discussion, what do you think about this, compare it with previous case, and then you conclude. So it's very easy, you can write it in one day. But you have to know how to write the citation, the references, and usually it's preferred to use a software. So you make sure that you put the citation in the proper style because each journal asks for specific style. Sometimes you submit it and they said this is Vancouver, we need Harvard or we need the AMA style. So usually when you want to publish something, you have to know which journal you are submitting your paper to. Take the author instruction, look at the instruction and try to commit all the things, all the changes based on what they are looking for. So this is the structure of the case report. Title, abstract. Usually abstract is less than 100 or 200 words. And for the case report, they usually ask less than 1,500, 1,500, sometimes less than this. And this is all through the journal. You go to the journal and check what they are looking for. Introduction or background, then the case presentation, discussion, and conclusion. I will go through every one and talk briefly about the structure of case report. There is like a guidelines for any research design. For randomized controlled clinical trials, they have specific guideline. There is a guideline for case report, although not all the journal ask you to go with this guideline. The best thing, you go to the website of the journal and you see what are the requirements, what are the author instruction. If you don't find it, then you can go with the guideline. Title should be brief, informative, descriptive of a case report. Some journal ask you to write case report, like saying this is a case report of rare or atypical presentation. Other journals say no, do not mention this. So you have to make sure what they are asking for. Are they asking for this or not? Because you don't want to spend weeks, then they ask you to remove the word case report. Target MISH terms, if you go to PubMed, there is a specific characters called medical subject heading. They classify, they meet twice yearly, and they classify each disease on specific name just to make sure when you put key terms for a specific disease, you find all the variation. For example, if I publish a paper about road traffic injuries and you type motor vehicle collisions, you're going to get my research because they understand these terms mean different things and they collected in a specific place. If you go to PubMed, there is something called MISH database. You go and type the keywords there and you try to figure out what are the MISH terms you are looking for. Some of them ask to write a rare case or atypical case. If you want to try writing first case, make sure it's first case. Because sometimes you say first, but if I do literature review, I'm going to find more cases of this. So as I mentioned, some say avoid, some say no. You can write a rare case or case report. Keywords, this is important. Usually choose 2 to 5. If you succeed at choosing the proper keywords, this would help other researchers when they go and do the Google Scholar search or PubMed through Medline to find your topic. And if the journal is indexed in PubMed, it's more likely that people will find your paper. Abstract brief, we said less than 200 words. Total case report, less than 2,000 or 1,500. Structure or unstructured. Sometimes they ask you for abstract, like in paragraph, mention everything, but in chronological order, introduction and methods, result. Sometimes they said, no, write objectives or aim, then you put like 1 or 2 sentences, then write methods, then write. So this is the structure and this is the unstructured. Check the journal instruction. Usually check the journal instruction. Actually, it takes a lot of time to change from journal to journal. So if you get rejected or you want to change the journal, you have to change things in the paper, and usually take times because you change the style, you change the reference sometimes, how you put the reference, you change the grammar or punctuation from American to British or Australian. Key elements in abstract, try to mention these key important things. Sometimes you write a paper and after 3 months or 6 months, when you want to publish it, they ask you for abstract. Then you write the abstract without going back to the paper. Then you figure out there is discrepancy. The things in the abstract a little bit different than the original paper. And usually do not believe any abstract, especially if you are trying to make a decision on this. You have to go and read the methods of the paper because sometimes they mention something a little bit different than what the paper mentioned. And sometimes even things are the opposite. It shouldn't be like this, but you have to make sure you read the whole paper if you want to depend on that paper. Because sometimes you do not have access to the literature, so you just depend on the abstract. But this is not usually a good tactic. The introduction mentioned briefly things about the topic. Landmark papers, you can mention them in the introduction. Also, case presentation. This is mimicking what you have seen in the hospital. You just mentioned that we have this patient present with this disease and we did this. 2 or 3 paragraphs. Do not be obliged that you have to write everything about the patient because you have only 2,000 words. You cannot write everything. You have to make it very short because in communication you want to be clear and concise. Finish the story, even if you wait for follow-up. If you write the case and you don't know what happened to the patient, wait for a couple of days or weeks to say that patient didn't survive or went back home or deceased or something. Because it's like story. You're communicating with the clinician or other provider and you want to end it. You don't want to cut it in the middle, especially when the outcome is very important. Discussion, do brief literature review and emphasize on the learning point. Why you are reporting such case. Usually mention this. We are reporting the first case of this in this geographical area. Or we are reporting this because we started seeing these cases in our geographical area. Focus literature. When you come to the discussion, do not just report a case as if it's in solo. No, try to make a correlation between previous cases that have been reported in the literature and try to compare what's different from these previous, because discussion is like group discussion. We talk to each other. It has to be like kind of interactive. You mentioned X says, Y says, we noticed this. So do not make it like just a paragraph and you are mentioning, you are repeating the result. It has to be different than the result. It's interpretation of the result based on the other papers. Compare and contrast, finish with what your case add to the literature. In conclusion, should include evidence-based recommendation. Usually when you recommend something, especially with the case report, you have to base it on evidence because usually this is a rare things. We do not have a lot of published recommendation about this disease. So try as much as you can support your decision in recommending specific things. Emphasize on the applicability of the practice. This is the main idea. If you want to change practice, if you want to increase awareness, you have to convince people that we did this with this case and the result was, for example, satisfactory or not satisfactory. Example of not very rare or first case. So I mentioned it doesn't have to be the first case. This is one of the case report I'm submitting now. It's a road traffic injuries in the middle of the city, in the highway, between 2 cities, but it was still in the same city. The car didn't leave. And the road wasn't lit very well. There was no light, and a camel came. It was an SUV, hit the camel. The car swerved twice, flipped over twice. The driver was putting seat belt, the baby in the back with the seat belt. The woman, the front passenger, wasn't seat belted. She was ejected and died on scene. So it's, if we report this, somebody would say, yeah, but this is a camel with the car, so what's the point? There is a point here. There is a point that although this is, it shouldn't happening, especially in a city, but it happened. We don't know what's the behavior of the accident. We usually, when we talk about accident, we talk about people who are texting and driving or people who are overspeeding, but we are not talking about uncommon things like animals. And we figure out that camels, accident with camels in the Middle East mainly, sometimes in Australia. In Australia, they have the kangaroo and other animals, but it happens, and it can increase the mortality of road traffic injuries. Then we spoke about the intervention that should have been implemented on the street, probably, or on the animals. Sometimes they put stripe with the light on these animals. Other thing, we saw a couple of cases with elderly people when Dr. Lisa talked about diabetes. I remember I was working with the Ministry of Health in health policy, and some of them, they did a research survey, and they mentioned that diabetes in Saudi Arabia, they said 8%, some of them said 10%. The problem, we are a young population. Diabetes usually happens in middle age and elderly. But when they did the subgroup analysis of that survey, people in Saudi Arabia who are 65 and above, 50% of them diabetic. Can you imagine this? So if you are 50 years old or 40, you're gonna be diabetic, it's 50%. And this is previous research. We don't know if we continue on this, maybe it's going to be 60%. So one of the cases I saw in the hospital, I was taking history from the patient, and he was having a chest pain. He was 50 something. Then during the encounter with the patient, he said, this is after that pills, and he started cursing the pills. I was like, which pills? Then I figured out that he was using Viagra. At the same time, he was having angina and taking medication. So due to the interaction, he had a myocardial infarction. And the problem, they take it from the pharmacy over the counter. They do not have prescription. And the pharmacists even do not give instruction that if you are taking medication for the heart, you have to make sure you are not taking them at the same times. So although maybe this is not a very rare, but at least you are increasing awareness and mentioning some recommendation that need to be implemented not on the physician only, but on the pharmacist or on the patient. Graphic and image, this is good. If you mention something, if you put illustration, it makes your paper looks nicer. It's kind of like entertaining. If you entertain the readers, people would read your articles. They probably would cite it. The journal would like it. But usually follow the instruction. Sometimes they don't want more than 3 table or 3 image. Be creative. Feel free to be creative. You can create something. You can draw something or hire a video animator. Like now I'm trying to hire a video animator. I contacted one of them because I figure out when there is an accident, sedan car with a camel, usually because the camel is 2-meter height and the sedan is a little bit lower. The weight of the camel is more than 500 kilograms. So if they hit the camel, usually the camel fell on the passenger and they get killed. But it's SUV or family car, usually the camel will be ejected. So this might indicate the fatality of the accident. And I think the speed has another factor. If you are driving at high speed, more likely the camel will fall on the car. But if you hit a camel on a low speed, it will fall in the front side of the car. So you can add some information, especially the mechanism of the accident. Practical tips to write and publish a case report. Consent the patient. This is the first thing you do. If you see interesting things in the hospital, consent the patient before he goes. Because if you tell me after 2 weeks, I want you to help me in writing case report, if the patient left and we do not have a consent, that's an issue. Put a deadline. If you agree with your consultant to write a case report, let's write this in 2 weeks. Or I will give you my final case report and then you review it in 1 week. Agree on authorship. Sometimes conflict happens, especially between 2 different departments. We are the emergency medicine. We saw interesting case, admitted the patient, then the radiologist, they published the paper, but we published at the same times. So try to, if it's different perspective, they are publishing from radiological perspective, that's fine. But if it's the same case, it doesn't look nice when you have a conflict of authorship on a case report. Plan to succeed at the third trial. I'm a researcher, so I usually see clinicians, they are frustrated because they tried once, twice, or 3 times to publish something, but they weren't successful at this. Let me ask you a question. Do you think your first intubation will be successful? I don't think so. Do you think your first physical examination will be presented, or people would say that this is the best physical examination? So in research, it's the same thing. You do the research, you failed first time, you get rejected second time, third time rejected, then you resubmit again. You might succeed after 4th time, but that's fine. It's a learning opportunity. The more you try, especially with the supervisor, the more you learn. Authorship, make sure you do not have a conflict. Single author usually responsible for the load of the work. Sometimes a single author may be the senior, but the senior need to have the load of the work. Being a clinician, or if the patient is admitted under your name, doesn't give you the authorship. You can publish a case report while the treating surgeon or clinician was not involved in the case in the writing or intellectual process.
1 minute.
Okay. Avoid double publication, ethics and ethical approval. You need to have the informed consent from the patient, okay? If you want to show the picture of the patient, there is another form. In some institution, they ask you for IRB, institutional review board. It's not the usual practice, but some hospital ask for this. And avoid plagiarism. You can check the journal. Sometimes they mention topics that they accept. For example, they said we take case report in trauma or injury, stuff like that. Drawback of case report, we said it's at the bottom of the evidence-based medicine. Due to the high volume, journal usually accept very few number, limited number. And some journals do not accept case report. Avoid making firm judgment because it's one observation. Do not say that this treatment is for this disease. Before claiming rarity, make sure it's rare. Few grammar mistakes is acceptable. Typos are not acceptable. Even if you are non-native speaker, typos usually means that you were in a hurry or you do not have time to review your paper. Example of non-case report, we said the AIDS, the thalidomide, it started with the case report, with the congenital anomaly, the fenfluramine, which is the appetite suppressant with the pulmonary hypertension, and the Zika virus. This is the guideline for the case report. Some journal ask for this. Yeah, so this is just a video. I was showing how when I write, usually try to use a dictionary, especially if English is not your first language, to be very handy for you. Because you need the thesaurus, you need to check for words, you need to check for spelling. If it takes you a long time, you will get bored and you wouldn't go and check the dictionary every now and then. But usually writing is not like speaking. It doesn't come from the first time. Even native speakers, sometimes they write things, and when they read it again, they do not maybe understand it, or it's not very clear. And this is the last video. You can hire somebody to check your writing, check your English, and you can pay them per page as a native speaker. That's all.
Okay, thank you very much. Thanks. We'll take questions at the end of the session. Okay. Our next speaker, Dr. Razan Rahimi. She completed a residency from the Kuwait Board of Emergency Medicine. She's currently a staff physician in the emergency department at a hospital in Kuwait City. She's going to talk about one of her interests, which is telemedicine.
No experience of any mad honey, so I can't. If any one of you has ever seen any cases of mad honey? Okay, good.
Thank you very much to Menetox and EPAT for inviting me. I'm proud to collaborate this assembly. My presentation topic is mud honey. Mud honey poisoning, not also this presentation, my presentation topic, also my scientific life main topics. I will explain some my expert. I declare to no conflict of interest. First, let's see some chronologic old writing and ancient writing about Madhani. In ancient and old writings, we first seen Xenophon. Xenophon has a book called Anabasis. In this book, he mentioned about the Madhani. He told that his soldiers who ate Madhani looked like drunk people. This is first used Madhani word in the past. First we seen Madhani word in this book. Second, we seen Strabo. He is also an historian in ancient time. Strabo also told this book, his book, Pompey's army was destroyed by feeding Madhani. This war Strabo's mentioned about is near the Trabzon, like Xenophon mentioned about this war, his war. Centuries after these ancient history writers, Mr. Coleman said that he gave medical attention about, explain some case, 14 case, which 3 of them died. This is important for us because this mortality is first described these books, these letters. The distribution rhododendrons and methanopoisoning cases in Turkey. Grantosin comes from the rhododendron flowers, and this makes the honey poisoning in Turkey. Plants belong genus rhododendron have wide distribution area in Black Sea region, which extends from the Marmara region to Caucasia. We see. This area is rhododendron ponticum area. This area is rhododendron luteum area. There are remarkable harmony between the distribution areas of plants genus rhododendron and the areas where poisoning cases. Worldwide, when Madhani poisoning cases are analyzed according to countries, it is seen that the most cases of Madhani poisoning occur in Turkey. Nepal is second country. South Korea comes third. As we see, Turkey is first one, Nepal and South Korea is second and third case we see. Madhani poisoning produced in this country can export Europe, Asia, and others countries. Because of this, some poison case can be appears in this area. Out of the Turkey, Nepal, and South Korea, we can see Madhani poisoning cases. For what we use, people use Madhani. Madhani generally consumed but accidentally in Black Sea region. People don't know how it contains grantoxin or not. Madhani can also consumed as alternative therapy for health problems such as digestive system, hypertension, sexual dysfunction, wound healing. Madhani also used to diabetic patient for blood sugar regulation. when they use it as an alternative therapy, it can be poisoning this person. The poison effect of methanol originates from toxic compound called grantoxin. Based on the literature, so far we 60 grantoxin types, and their glycosid have been isolated from the various ecosia plants. Primary toxic compounds are grantoxin 1 and 3. Primary toxic 1 and 3. Physical symptoms from methanol poisoning appear after dose-dependent latent period of several minutes, approximately 3 hours. Patients exposed to low-dose grantoxin typically recover within few hours. In more severe cases, symptoms may persist 24 hours or longer, may be required medical treatment. Grantoxin are capable of binding the group 2 receptor regional voltage gated sodium channels. Grantoxin only binds the activated conformation of sodium channels. After binding of the receptor, grantoxin prevents inactivation of sodium channel. This activated conformation allows the influx of sodium, and this is stop the membrane activation and neural activity. The main symptoms believed to caused by continued sodium channel activation, cell deposition, and enhanced stimulation of the vagal nerve system. Depending on this, various cardiac conduction disorders may develop, such as varying degree of heart block, nodal rhythm, complete atrioventricular block, and second degree heart block we can see. The main common symptom in methanol poisoning, main cardiac symptom methanol poisoning patient is sinusal bradycardia. Also, clinical characteristic. What is the main clinical characteristic of methanol poisoning patients? We can see in emergency department this patient. Main symptom is hypertension, bradycardia, nausea or vomiting, sweating, dizziness, impaired consciousness, fainting, blurred vision, or diplopia. We can see. Diagnosis based on patient history and clinical finding. SMSMS system need diagnostic tools, not used in Turkey now. Maybe in the future we can use this diagnostic tool. There are similarities in clinical status between methanol poisoning and cholinergic poisoning. It is important to efficiently differentiate between the two types of poisoning, emergency department, to initiate appropriate and effective therapy. Biochemical data which was obtained in this study do not support the hypothesis that methanol poisoning should regard as cholinergic poisoning. It's different. Only the same is atropine treatment is useful, methanol poisoning and cholinergic poisoning. Clinical characteristic. We seen one patient methanol poisoning related asystole. This is first case and only one case. To after the poisoning, we seen asystole. After after this published published, after we published this case report, we seen a film, famous film, Sherlock Holmes, named Sherlock Holmes, mentioned about our case report. One of my colleagues said me that people made films your study. Did you see the Sherlock Holmes film? I said no. They said me that you should you have to watch Sherlock Holmes film. Let's watch this part of film. This one. In this film, they said that as we wrote on my our case report, they said that in this film, methane poisoning, very well-known poison, which can temporarily block heart rate. They said also this film, this fragment. But we can't hear it. No. Okay. Ne diyorsun ki?
Bir sonraki saatte devam ediyorsun.
What's the treatment in this poisoning? We only two tools, atropine and IV fluids we use. Standard ACLS protocol if bradycardias appear. Supportive treatment, atropine and IV fluid we use for treatment. There is no specific antidote for gram toxin. Although symptoms and signs can be alarming and sometimes life-threatening, useful supportive care with electrocardiographic monitoring. Normal saline infusion, as I said, we used if complete heart broke and appear, we can use cardiac pacemaker. A lot of research has been done on mud honey poisoning in Karadeniz Technical University Medical Faculty, Department of Emergency Service, Emergency Medicine. The high incidence of, let's look at some of it. One of them, dose-dependent effect of grantoxin in cardiovascular system. Second one is the analgesic effect of mud honey poisoning, and is grantoxin directly responsible mud honey poisoning associated seizure? Does mud honey poisoning require hospital admission? Clinical review of mud honey poisoning with flower mud honey, and also maybe 5 or 6 more example. The honey, the poison, and the weapon the topics presentation was we have. Are there any new project about mud honey in this our department? Yes, we have new projects. We are doing some new studies. The most important one is project developed to diagnostic kit for mud honey poisoning. I think the last one, this project, the last project is the best one for mud honey poisoning disease. Thank you very much.
Thank you. Thank you.
The front flower is Rhododendron ponticum. The back is Rhododendron luteum. This view is Black Sea Mountains. Thank you.
Thank you. Are there any questions? Yeah.
Because actually, because we are facing with this patient. Actually, we have a patient with same symptoms after injection of honey.
Can you just keep the mic near your mouth?
My question is how we can differentiate. This is hypotensive bradycardia. This from the honey itself, or it is contaminated honey, because we know that a lot of honey is contaminated with other substance, which can cause bradycardia and hypotensive. How we can differentiate between this?
I think you mean old honey don't poison. You mean?
No.
How can we differentiate what?
I mean, many manufacturers, they are producing honey. They are contaminated with other substances, which can cause bradycardia and hypotensive. How we can
like what other symptoms you mean?
Because what I want to say, because what I remember that when I'm talking about that, what the case was, I'm showing that the honey was definitely contaminated with something. I'm not sure what was that one, but definitely was contaminated.
His question is, can there be any other contaminant which can cause the similar kind of?
As we case, we don't have any contamination.
You don't
honey,
think that there is any such?
Or contamination is only grantoxin.
Okay. Okay. I think it's better that you can maybe discuss your problem with him at later. So thank you so much. It was a wonderful talk. Let's give him. So I thought we were kindly done with the presentations, but we have Dr. Hussain, who's from Iraq, and he's going to present on thallium poisoning, his experience.
Yes, our next speaker, Dr. Hannah Bergbauer. She's a nurse midwife and nurse practitioner. Nurse midwife and nurse practitioner who focuses on international health programming. She's a consultant with Integral Global and currently stationed in Bangladesh, focusing on expanding access to care and quality improvement within the Rohingya and host communities, incorporating telehealth platforms into low-resource settings.
everyone for being here. That was a great talk, giving sort of the history of telehealth, and I'm going to talk a little bit more about telehealth, but in a different capacity. The telehealth work that I've been involved in has been in low resource and vulnerable settings, so slightly different from the EMS perspective. So just sort of a broad definition of what is telemedicine. It's technology-enabled health and care management and delivery systems that extend capacity and access. So what does that mean? It just means that basically we're utilizing technology to expand the reach of providers and care access to patients in settings that they wouldn't normally have it. So we saw in the previous presentation, that the telemedicine was used in the field. I'm talking about actually taking it to rural settings or places that maybe are conflict zones or other things like that, where a person in the US or maybe couldn't even go, or providers can't get to. So why telehealth? These options provide sustainable medical expertise to those with the most vulnerability. So the quality of care increases, they have greater access and lower or no cost, because oftentimes when it comes to telehealth, the person on the other end of the camera is doing it for free, or it's a part of a package. So it's low to no cost, which is nice. So 50% of the world's population lacks adequate health care. And that's, we see typically in the global south, but also telehealth is being mobilized throughout the United States in rural areas as well, and in other countries that are considered high income due to lack of access. So I always like these world mappers. I don't know if anyone else uses them, but I think they do a good job of showing distribution, specifically in regards to the health workforce. So this is sort of an example of the distribution of physicians globally. So you can see, right, that higher income countries tend to have more physicians, which means that patients are generally going to have better access. It doesn't always guarantee that, right, because we know that oftentimes in countries like Bangladesh is a high-income country, but for example, in Bangladesh, 70% of the physicians are actually working in urban areas, while 60% of the population in the country lives in the rural areas, right? So it's disproportionate. But this is what, we see the continent of Africa becomes very, very small. Southeast Asia, like India, looks large in Bangladesh, but the distribution isn't even. And then we look at nurses, which also, are now being moved into telehealth platforms to do consulting as well. And you can see that the distribution isn't quite equal. And the same for midwives. So sort of background on how telehealth, that what I've been involved in is working is devices are provided. So the organization that I've worked closely with has been called InTouch. That's the platform. And there's some pictures of the devices throughout the PowerPoint. And then the World Telehealth Initiative. So World Telehealth Initiative is a partner of InTouch. And basically, InTouch created this technology, and the World Telehealth Initiative has then linked them up with providers who will see the patients, from the other side of the world, which is pretty cool. Then extensive training on the use is conducted, and then the expertise based on what the service utilization is going to be will then be provided. So I'll talk about more like the utilization of the telehealth in a few slides, because there's a lot of different ways. It's not just providing clinical care or consultations. It's now being used in low resource settings in a variety of other ways as well. And then these devices that I've been working with specifically they're trying to use internet as much as possible because it's more cost effective, but they're also using satellites, as was mentioned in the previous presentation. Sure. Hello. Okay. So these are a few ways that we are currently utilizing or uptaking the telehealth models. So direct clinical, well, I say direct clinical care, it's a little bit more indirect, right? But for clinical care, scheduled expertise consultations, emergent high acuity cases. So for example, we might have somebody on call that you can ring into or that you can call into with a video capacity as well. Education and training is something that we're utilizing these models for pretty extensively, especially in settings that are unstable where someone who's a trainer can't actually go into. Technical assistance, so I'll tell some stories about some technical trainings that have been done. And then disaster preparedness and management, real-time response, and then a lot of mentoring. So this is actually a picture of students who were utilizing telehealth resources out in a village. You can't, they kind of cut it off, I'm sorry, but there actually was a telehealth device. This is in Tanzania, and they're out doing trainings with a local community, sort of training of trainer models. So it's actually, that device was using satellites. And this is what's called a mother's club. So it's a place where mothers can come and gather in these rural communities in Bangladesh. And they've got telehealth devices that actually allow someone to provide them a consultation for different things that they might be experiencing. So they might have a day where there's a dermatologist that can provide a consultation with one of the devices. This is an example of, you can see one of the devices down at the bottom here. And so not only was the training recorded, but this was really important for these midwives because they actually practice on an island. So it's an island that takes about 45 minutes by boat to get to the mainland from, and there's no emergency transport service. So there's not like an emergency boat or anything like that. Basically, if there's an emergency, that person has to get on what's called a sampan and make their way. So these midwives, there's 6 of them that basically run this labor and delivery ward, and they need to be able to do everything, and that's a challenge for them. So what we were able to do is do extensive trainings and mentorship, and also they have a telehealth device where they can call in to somebody who's on the mainland at any time for backup, which is different than they ever had access to before. And actually there's been a documented decrease in some more severe morbidities, and then mortality hasn't changed, but that's a result of other factors. And so this is, you can see a nice graph representing fistula clinic and the mentoring sessions, and looking at, they were doing the same amount of surgeries throughout the entire period, but they were able to do more independently after trainings, and less mentoring sessions were then required. And then this was reported on yesterday using the telephone consultation service at the tertiary care hospitals in Lebanon for the toxicology exposures and the impacts of the reach of, having access to those services to help patients get specialized expert care. And then one of the projects that I've been working on has also been in the Rohingya refugee camp. And so when the Rohingya, I don't know if everyone is aware of that crisis, but basically in 2017 in August, there are about 1 million people who made their way from Myanmar to Cox's Bazar, Bangladesh, as a result of genocide in Myanmar. And so, of course, at that point, there was no infrastructure, there was no healthcare services available to them, and the influx of providers from Dhaka and other cities throughout the country, they weren't specialized providers. So they may have been physicians or other trained healthcare personnel, but they weren't specialized. And so telehealth devices were able to be moved in pretty quickly, and satellites were used so that there could be access to things like a dermatologist, which oftentimes people say, why do they need a dermatologist? You know, acne is not an emergency. Well, when you have a skin condition that is life-threatening, it is an emergency, and so having the access to the dermatology, for example, was actually pretty important. And then in relation to more of a toxicology or sort of perspective, I don't know if anyone's ever heard of YABA, but YABA is a drug that there's been a big issue with the import of it through the camps, and there's been a lot of overdoses. And so it was actually, when that first started to happen, you know, they looked at it from an epidemiology standpoint and figured out what was going on, and then employed telemedicine actually to consult and help treat some of these patients, because there's only 4 tertiary level hospitals throughout all of the camps serving about 1 million people. And so those providers didn't have access to emergency or response resources, so they were calling into experts actually in the US who could help them through that. And then there's the option of clinical consultation, so specialized expert care. This is I mean, the picture doesn't tell you what this patient has, but this guy actually has MDR-TB, and no, he's not wearing a mask. But this patient was waiting for his call to actually talk to a specialist in the US, and he continues to come back and get his treatment. And the device, actually, he can see him, and, you know, it's this young lady in the picture, they've hired a telemedicine implementing physician. So she basically just runs the telemedicine device. She does the assessment. She helps move and maneuver everything in collaboration with the provider who is on the screen. And this is just an interesting picture because it's a dermatologist looking at a patient who is following up. So it actually has created continuity of care, whereas like many times before, maybe a provider had flown in from wherever, saw the patient, and then would never be back again. But what this also does is creates the option of seeing that patient again and again, and the patients, they do come back. So this is important in terms of these low resource settings and the provision of healthcare, because the idea is that there's the possibility of preventing about 8.6 million deaths a year, which is a lot, by providing access to specialized care and resources. So the idea also is that with everyone that is interested in telehealth coming together and, you know, providing these expertise and consultations, that you can actually transform healthcare that is currently being provided in low resource, low income settings where the options to see providers or receive trainings and other specialized services aren't available. It's really impactful, and it has the ability to offer patients things that they wouldn't normally have. And so, like I said, I'm working with Integral Global, and then in partnership with In Touch Health and World Telehealth Initiative. So thank you. If anyone has questions, I'd be happy to answer.
Yeah, we can take questions from all the speakers now. Yes, do we have a microphone?
Dr. Hussain, you have 20 minutes. Please stick to the time.
Yeah. Where is my presentation, please? Okay. Yeah. Thank you, Doctor. It's my appreciation to be here. I am Dr. Hussain Hammoudi, the Director of Baghdad Poisoning Control Center. In fact, from 2008 up to 2015, we have many cases presented, about 60 cases presented to our center. Sometimes might ask, this is the most likely presentation. Alopecia is one of the presentation of thallium poisoning in chronic cases. Sometimes skin hyperpigmentation also occur, but it is not usually start like that. Usually thallium starts in acute stage with after entering to the GIT symptoms, presented with GIT symptoms in acute. Then in second day, after 48 hours, usually presented with painful ascending peripheral neuropathy. With the time, with the course, after a few days, the painful ascending peripheral neuropathy change slightly and slow progressive into motor neuropathy. So the patient after 1 week or 2 weeks might have numbness and paresthesia and usually end with paralysis. This is the effect on the lower limb, which is the most likely affected by thallium. Of course, the mechanism of thallium is usually attributed to its analog to potassium ion. I mean, it enters and deceives the cellular membrane instead of potassium because of similar charge and similar size. It entered to the ATPase system, and that illustrates why it is usually affect the hair follicle, because ATPase is responsible for energy production, and this is due to lack of this energy production. Usually the hair is fall, and the epilation usually starts at the 10th up to 3 weeks. 10th days after exposure up to 3 weeks. Sometimes when the amount ingested is so large, it might cross the blood-brain barrier, and the most likely affected oculomotor nerve, the third cranial nerve, and the patient presented with the dropping of upper eyelid. Here, there is 2 case study. One of them, the most common, a famous case report that is published all over the world. It is about Al Jawiya Sport Club. When they ingest thallium, which is contaminated with the piece of cake usually introduced to them during the celebration day of that club. Those 2 families, in fact, admitted to the emergency departments of Al-Kindi hospitals. Their complaint was GIT symptoms, but it was fruitless. They didn't manage well. In the 4 days, they admitted to another hospital within the medical city complex, to the Baghdad hospitals. At that time, they asked me to see and examine the patients. On examination, this is a good example of acute thallium poisoning. All of the patients looked terrified, exhausted, diaphoretic, and the child was admitted to the intensive care unit. The member was 6 at that time. Bilateral painful ascending peripheral neuropathy on all of them. They have severe burn, describe their burn as if they are walking on a pen or a hot coal. Yeah, of course, the tendon reflexes was normal. Babinski reflexes and other reflexes was normal at that time. Abdominal reflexes, normal. Ptosis in 2 persons. Yeah, pleuritic chest pain in 1 person, and all of the patient, of course, there's ECG normal and other examination is normal. In fact, this is the questionnaire that I have asked at the time. How many days they were suffering? The answer was 4 days. This is the day 4. What type of food they were shared? Yeah, they said to me, and a cake introduced to them. Who had ingested the largest quantity? because I want to compare the quantity that had ingested with the clinical presentation. The answer was that one have severe painful ascending neuropathy and ptosis. That means he had ingested a large amount of thallium which crossed the blood-brain barrier. So, differential diagnosis at that time was arsenical compounds and thallium. Botulism also, we sent for a stool culture and bacteriological study to exclude the Clostridium botulinum and Guillain-Barré syndrome. In the second day, we arranged for laboratory workshop. 6 samples were withdrawn from these 5 samples, and another 2 negative samples. All of them were positive, as you see. This is the name, Zainab and Muhammad Rasool. He is the big boss of Al Jawiya Sport Club. This is the thallium test were done in my lab. If it is clear, a pink color test usually appear, which indicate the positive results. Of course, we use dithiazide and sodium potassium tartarate cyanide reagent in this test. Okay. After we finished the diagnosis, the absence of a Prussian blue at that time, and unfortunately, we sent them to another Jordanian hospital. And the guideline management were prescribed at that time. A Prussian blue should be given orally. Hemodialysis should be done for them. Potassium infusion, it is controversial. Some of them said that it might exacerbate the neurological symptoms, and some of them mentioned that it might shorten the bedridden of the patients. This is the Prussian blue potassium ferric hexacyanoferrate. This is a case. The another case, please. Yeah. Mustafa Latif, 13 years old male. In fact, presented to the Mansour Pediatric Hospitals. The relevant gave history that he eat hamburger and sweet, and his daughter were died the day after ingestion. Of course, the Ministry of Health and other pediatricians asked for my help at that time. This is the Ministry of Health. This is the examination. All things were normal except sinus tachycardia. The patient looked hallucinated, terrified. Of course, he has painful ascending peripheral neuropathy, but no alopecia. And with dark hyperpigmentation of both hand and face. This is an abnormal, but it rarely happened with thallium. In more than 80 cases, just we have 2 patients presented with such dark hyperpigmentation. Of course, the patient treated with thallium, with the Prussian blue, and also we add, this is laboratory finding. All biochemical tests were normal, except thallium. The patient has hypertensive, which were treated by captopril, in addition to Prussian blue, or IV fluid, or potassium, of course, given IV infusion, but then it replaced by fruit juice in order to replace the thallium. Usually the patient have hypokalemia during the course of illness. On 7 days, another test were done, which was negative, but the patient kept on the same treatment for at least 3 days. This patient presented 1 month after exposure. We add on discharge neurobin, multivitamins, and zinc sulfate. After 1 month, the patient completely returned to normal, but he still has some pain in the lower limb. But usually, according to the literature, it might disappear after 1 year at least, 9 months up to 1 year. Thank you.
Thank you.
If there's any question, please.
Yeah, they're very interesting cases. I just have one question for you.
Yeah.
How did they get, all the cases got thallium in food? What was the intention and how did they get that?
Most likely criminal.
Criminal?
Criminal, yeah. Because during the wartime, and ISIS, some members, some families, some of their family members belong to ISIS, they might to kill other, which belong to policemen or governments.
And is thallium available?
Yeah, it is not available on the markets, but it is used as a rodenticide in the neighboring countries, in Syria and Iran.
Okay.
So it was used by intelligences during the time before war, before 2003, by Saddam regime to assassinate the others.
Okay, so that's very interesting because I personally have no experience. I would have maybe thought of ascending paralysis, neuropathy, arsenic, which you mentioned, but the alopecia...
arsenic was negative in our test, in my lab test.
Any other questions?
Any other question, please?
If there are none, thank you very much, Professor Hussain, and I must give him a big round of applause. I must thank all the speakers, Paul, Chuck, Hussain, and Dr. Abdul Qadir for a wonderful session. With that, we conclude today's day, and we meet again tomorrow morning at 7:30. Thank you very much.
The commonest source of CO poisoning in Turkey?
In Turkey, there is furnaces and heat stoves, most of the common cause. We don't have that much suicidal carbon monoxide poisonings. Big majority of the cases are accidental poisonings because of like I said, furnaces or heat stoves. But we don't have the exact data. So it's anecdotal data.
Any problem with using the hyperbaric oxygen therapy? Is it easy to send the patient there?
Yeah, we have several centers in Istanbul, and I'm speaking for Istanbul. So if you had a patient with carbon monoxide poisoning and you think that he or she needed hyperbaric oxygen treatment, you can connect with hyperbaric chamber doctors, and they gladly accept it. But in some outbreaks, we have some delays for treatment because of the patient overload.
Any other question?
Yes. She will talk about caustic injection. Dr. Betül Başaran, she graduated from Hacettepe University Faculty of Medicine and certified as an anesthesiologist from the same faculty, Department of Anesthesiology and Reanimation. Dr. Başaran is an associated professor of anesthesiology and currently working in Konya Training and Research Hospital. She is interested in critical care and toxicology. Yes, please.
Good afternoon, my colleagues. It's my pleasure to be with you as an anesthesiologist. And I come from Konya, the city of Rumi, that's located at the center of the Anatolia. Okay, pardon. You see? I declare that I have no conflict of interest about my speech. My topic is corrosive ingestion. As you know, it is rare and potentially devastating event, and there is limited experience, personal experience about it. Uncertainty persists about the best clinical practice, and wide range of cases can be seen from the mild to severe, and the CT scan is accepted as a best methodology for the management of the cases according to worldwide scientific literature. And esophageal stricture, as you may know, is the main common consequence. During the management of these cases, multidisciplinary approach is accepted. And you may see what clinicians must be participate to manage these cases. I am the anesthesiologist, the second one, and the first one always is the emergency care physicians. And pardon. As you may know, two age groups are most risky group. First one is children aged between the 2 and 6 years. I think about 80% of the cases are children between 2 and 6 years, and 20% of cases are adult. They are aged between the 30 and 40 years. And two main agents responsible for the caustic ingestion strictures, caustic ingestion burns. And the first one is the strong acid. Strong acid may cause coagulative necrosis, esophageal scar formation, and also strong acid can cause prolonged gastric contact. The second one is alkali. And the alkali can cause the cofactive necrosis, but the difference from the acid is the alkalis can cause in all the GI tracts, can affect all the GI tracts. It's the difference from the strong acids. Major determinant of the outcome, as you may guess, is the quantity. Early contact of the poison control center is must. Why must? Systemic effects of the corrosive agents can affect the medical situation of the patient. As you may see, hypocalcemia, hyponatremia, hypokalemia, and acidosis are seen in these patients. And as you may guess, the pathological changes seen in all the gastrointestinal tract, especially in the esophagus. If we mention about the management strategies, primary aim of this management strategy should be the survival, and secondary aims are to prevent early complications, to prevent late sequelae, also to provide nutritional anatomy and quality of life. Pardon. And I want to mention about the initial approach because I know that especially in the initial approach times you are the emergency physicians include these cases. Identification of the corrosive agent is most important. Time from the ingestion must be questioned, and the evaluation of the context must be asked to patient, whether it is accident or intentional. Co-ingestion of the drugs must be questioned, and additional risk factors related to patients must be asked to the patients or the nearest. We should make some maneuvers according to increase the esophageal passage, but we should not make to attempt neutralize the pH of the caustic ingestion. The effectiveness of nasogastric tubes controversial. Some scientific data try to use it, but some not. Some of them not. Evaluation of gastrointestinal injuries in case of evaluation, distinguishment is most important. And unluckily, signs of the digestive perforation are rare, and according to it, symptoms are not correlate with the signs. So it shows us signs and symptoms. Signs plus symptoms do not show the full necrosis. Some of the patients may be admitted to emergency department with a better condition, but in these patients we can also see the full necrosis of the esophagus or the stomach. In these patients, some of the blood-related parameters can be changed. You may see here. And the second blue one is important for the anesthesiologist because during the perioperative period, we must deal with severe acidosis and renal failure with management of fluids. And esophagogastrostomy means state of emergency management, but it should be done between the 3 and 48 hours. Later, it's not important at the later cases. Zargar classification used during the flexible gastroendoscopy. You see here the Zargar classification. Endoscopic grading can predict systemic complications, respiratory failure, emergency mortality, also provide nutritional anatomy, but endoscopic grading have two major drawbacks. One of them is inability to predict accurately depth of necrosis, as I said before. The second one is endoscopic grading is mostly observer dependent. And after the 24 and 48 hours, potential disadvantages of misinterpretation can be seen. I want to mostly talk about the computed tomography. It is new data for me, I think. I know before this speech presentation, I know only the endoscopic grading, but during my search about this speech, I learned about the computed tomography, and I learned about that the World Society of Emergency Surgery support application of CT. It surprises to me too much, I think. There are some conflicted data. Some of them related endoscopic grading is the best. Some of them related to computed tomography grading is the best. But the Lancet supports both of them. The last data from the Lancet also supports, firstly, the computed tomography if needed. If the computed tomography shows us the full thickness necrosis, then the gastroendoscopy should be done. Management algorithms, nearly scientific data supports management algorithms based on computed tomography, as I said before. In all the cases, the computed tomography should be done. After the computed tomography, the related data should be added to gastroendoscopy related data. But computed tomography also has two disadvantages. One of them is renal failure, and the second one is the allergy to contrast agents, as you may know. I want to mention about little information about the emergency surgery. Emergency surgery, as you may guess, has high mortality rate, has high morbidity rate. Also, the bad factors that affect patients related to surgery are advanced stage tracheobronchial injuries, emergency esophageal resection, extended resections, and severe derangement of laboratory test results, as I mentioned before. If you look at the surgical procedures, we mostly see in the operating theater the esophagogastrectomy. It is accepted as the most common emergency procedure. The second one is the damage control surgery. In the caustic ingestion, patients can be accepted as a major trauma patients. As you may know, major trauma patients should be dealt as a damage control surgery, not only one-sided surgery. The caustic ingestion patients can be accepted as there.
Please take the sentence.
Efendim?
Take the presentation, finish, please.
Okay. Partial gastric resection is not recommended, and concomitant necrosis of organs can cause extended resections. Non-surgical management, as I mentioned before, from the non-surgical management, early nutritional support is very important, and total parenteral nutrition must be inserted to non-surgical management. Delayed sequelae, as you know, hemorrhage, fistula formation, and malignancy are delayed sequelae. In low resource settings, limited access to medical expertise is seen and poor follow-up seen. In low resource settings, primary aim should be prevention of malnutrition and gastrostomy. And future directions are there: optimal management of corrosive ingestion, quality of life after caustic ingestion, and preventive measures. Thank you.
Thank you, Dr. Bambasharan. Do you have any question or contribution? Please.
I guess I have a question and a comment. The question is, did you come across any use of steroids and antibiotics in such cases?
Yes, I have read about the steroids and antibiotics, but they have no place during the routine management of cases.
Okay, then
it should be think case by case. In the routine practical cases, they have no place for the steroids or the antibiotics.
So, and then the comment basically is a majority of these injuries that have been related to caustics will have a very bad outcome despite the measures that you are doing initially. And so preventive measures, probably the standard of care, and increase the awareness about how difficult these cases should be addressed in a very confirmative way.
Yes,
you are right. Thank you. Other question?
Thank you for your presentation. I want to ask you, I met with lots of causative ingestions in my clinic, and most of the time pediatric surgeons are stopping the oral intake and waiting for 24 hours. So what's your emergency surgery rates for caustic congestion
in your cases?
Yes. In your hospital?
I have 1 year training period in the pediatric surgery department before the anesthesiology training. And the pediatric surgeons mostly deal with cases with waiting, not the operating. They wait. Not operate. In the Konya Training and Research Hospital, we did not take any pediatric patients for the emergency resection.
Thank you. Other question? Any other question? Thank you very much.
It's going to talk about the colchicine poisoning. Please welcome Dr. Azura Shiki. I'm not sure, I'm sorry if I pronounce it incorrectly.
Azura Shiki.
Shiki,
yes.
Okay. Please welcome Dr. Kiki.
Thank you. Thank you, Chairman.
Dr. Kiki is a medical toxicologist working at the Pavia Poison Control Center in Italy.
Thank you for the presentation. And thank you to the organization to invite me to talk about colchicine poisoning. So let's start talking about colchicine. It's a drug derived from the alkaloid component of the plant Colchicum autumnale. Colchicine binds the tubulin dimer and inhibiting the formation and function of microtubules.
So, with consequent anti-inflammatory and antimitotic properties commonly used in therapy for the gouty arthritis or familial Mediterranean fever or other rheumatic disease. It's a poisoning with high mortality rate, and it can occur after intentional overdose, therapeutic errors, or ingestion of plant containing colchicine that are often confused with edible plants. The most widespread in Italy is Colchicum autumnale, often collected instead of wild garlic or Allium ursinum. So, to my knowledge, different species of colchicum are present on the MENA region with a huge variability, and all plants are poisonous with the high concentration of colchicine in bulb, corn, and seeds. And this is an example, the species of colchicum present in Turkey with difference to autumn and spring. So in order to understand the basis of colchicine poisoning treatment, it is important to point out some toxicokinetic characteristics of colchicine. And the first one, because of the antimitotic action of tubulin, because on the microtubules, because of the presence ubiquitary of the microtubules in cells, of course, colchicine has a really narrow therapeutic index. Is a variable bioavailability between 25 and 50%, a volume of distribution of up to 21 liter per kilo, plasma protein binding between 10 and 50%, is metabolized by liver with biliary secretion and enterohepatic cycle, and with a renal elimination of 20% and elimination half-life variable on renal elimination rate from 10 to 37 hours. So, evaluate reliable prognosticator is important to early identify patients at risk of death who should benefit from aggressive treatments. It's therefore important to evaluate the ingested dose because it is known that if patient ingested less than 0.5 milligram per kilo of colchicine, death rate is less than 5%. But if patient ingested more than 0.8 milligram per kilo of colchicine, death rate increased to 90%. Of course, this does not apply with plant ingestion, but only with drugs. So other known prognosticators in colchicine poisoning are prothrombin index less than 20% or white blood cell count more than 80 gram per liter in the first 24 hours, or the onset of cardiogenic shock of ARDS in the first 72 hours. And the exact prognostic value of plasma colchicine concentration is still unknown and I think is not currently available in emergency practice. So, drug-drug interaction may cause clinical picture more severe than predicted when, in example, colchicine is co-ingested with the cytochrome inhibitors 3A4 or PGP inhibitors. And clinical picture of colchicine poisoning is characterized by three phases. The first one is called gastroenteric phase, from 2 to 24 hours from ingestion, and is characterized by abdominal pain, vomitus, and diarrhea with consequent volume depletion and peripheral leukocytosis. The phase 2, that is the most dangerous for the patient, and is the one in which patient could die because of the onset of cardiovascular shock, respiratory distress, myelosuppression, thrombocytopenia, rhabdomyolysis, and multi-organ failure. If patients survive from this phase, we observe the third phase, that is the recovery phase, with rebound leukocytosis and alopecia. So, based on this information, it is important to identify the key points of the management, especially in the first hour from ED presentation, and I want to start by discussing a case that I consider explicative to this objective. This is the case of a 42-year-old woman for which Pavia Poison Control Center was called from extra-hospital emergency setting, and because the patient had taken 30 minutes before, a dose of 0.85 milligram per kilo of colchicine, so of course a potential lethal dose. So the first indication was perform gastric lavage in the first emergency room available. 1 hour later, the patient arrived in a near emergent hospital, a little hospital of Italy. So the potential severity of the evolution was explained and the importance of the decontamination was underlined, but what happened was that because of the discovery of a pregnancy test positive, the patient was transferred to a bigger hospital with an OB-GYN service, but gastrointestinal decontamination was still not performed. So unfortunately, the patient died on day 5 of hospitalization. Yes, so sad. But I think it's really important because starting from this, I want to focus your attention on the first hour management of colchicine poisoning, in which is important history evaluation, of course, suspect colchicine poisoning, calculate ingested dose, consider drug-drug interaction, start laboratory test monitoring, but mainly is important to perform gastrointestinal decontamination. And as soon as possible after ingestion and after emergency room admission. Gastrointestinal decontamination should be considered even some hours after ingestion, and even if many hours after ingestion if patients co-ingested opioids or other peristalsis inhibitor. So gastrointestinal decontamination should be based on gastric lavage, oral administration of activated charcoal, multiple dose of charcoal because of the enterohepatic cycle, and whole bowel irrigation. So, I made the photo. So the rest of the treatment is mainly based on the phase of the poisoning, is based on is supportive treatment, so fluids in case of vomitus and diarrhea, vasopressor in case of cardiogenic shock, mechanical ventilation in case of ARDS, hemodialysis that is ineffective because of the large volume of distribution, but should be considered if the patient has acute kidney injury, and of course colonial growth factor or transfusions in case of myelosuppression. So other considerations should be made on exceptional treatment like ECMO. There are reported some cases with favorable outcome, but colchicine poisoning results in multi-organ failure independently from cardiac failure, so actually evidence is still lacking. And the anticorpal fragments anti-colchicine that are still unavailable. So in conclusions, colchicine poisoning is characterized by high mortality rate, should be considered if patients came to emergency room with the gastrointestinal symptom after ingestion of self-collected plants. It's important to evaluate early known prognosticator to early identify patients at risk of death. And gastrointestinal decontamination must not be delayed and should be considered also late decontamination if co-ingestion, as I said, of opioids or other peristalsis inhibitor. Consider drug-drug interaction if you see a clinical picture severe more than prognosticated, and treatment is mainly supportive and needs to be aggressive. Thank you.
Any question? Have you had any experience with the ECMO?
Yes and not. Not in Italy. I have experience in France, but unfortunately was a patient with amphora who died, because actually, as I said, ECMO acts on the cardiac failure, but not on acute kidney injury, rhabdomyolysis, and the multi-organ failure. So unfortunately, no. But was a patient with late arrival at hospital. Actually, is the most important thing. If patient absorb all colchicine that had taken, the mortality rate is really high.
Okay. Thank you for your presentation.
Thank you.
Chairman of Emergency Department at Hamad Medical Corporation, Qatar. Please welcome.
Thank you very much. Good evening, everybody. I know it's late, and I hope everybody still have some power. So it is basic, so it will not be a lot of information there, but let's see if we can get some benefit from it. So first of all, let me ask anyone from the audience, how many cases of methemoglobin you diagnosed in the last year? So anybody diagnosed methemoglobin in the last 1 year? By rising hand? So nobody. So that means it's rare disease. That's making my life easy. Okay. So I'm talking now about methemoglobinemia. I don't have anything to disclose. We'll talk about what is methemoglobinemia and what is the most common agent that induce methemoglobin in the blood and information. And if there is any doubt, how we treat it, how the presentation, we'll go through that in very brief. So let's start with the case. This is a real case, came to us in Qatar. It's a 27 years old man who has ingested some chemicals for intentional, for suicidal attempt. He brought by ambulance with complaint of dizziness and drowsiness. And the things he ingested was this chemical. It calls indoxacarb. It is non-organophosphate insecticide. It was used there widely for agricultural issues, and he ingested quite a large amount of it for suicidal attempt. So this is the first physical examination of it. He is not tachycardic, blood pressure was fine. Saturation, which was significantly low to 82 to 87% in 100% room air. And he was severely cyanosed, but he was GCS is still okay. So ECG done for him, it was normal. There was no ECG changes. But we found in the lab investigation that his methemoglobin level was 79, which is very, very high. Okay, one of the highest level that diagnosed in our region. Maybe there is one in UK with Dr. Kamor, 91 you got? 90.3. So this is the maximum was diagnosed. Anyway, so this patient is having a very high level of methemoglobin, and he is already symptomatic. He is cyanotic, and he has a dizziness, some headache, tiredness, and he was actually not in the main tertiary hospital. He was in a peripheral hospital. And they started do intubation for him. Then they call a poison center for such case. And we told him, okay, this is a case already you diagnosed. So you start treatment. Okay, so let's have some basics about physiology. This is the hemoglobin, deoxygenated hemoglobin when there is no oxygen. And when there is a binding of oxygen, it binds to it and change it to oxyhemoglobin. With extra oxygen, the bond of oxygen become more tight. Okay, what happens in methemoglobinemia is that there is oxidant that oxidize the iron from ferrous to ferric, and that oxidant form cannot bind the oxygen, it bind the water. And then there will be a formation of functional anemia, where there is enough hemoglobin, enough oxygen, but it's not delivered to the tissue because of this problem. Okay? So the clinical manifestation, as we mentioned, it actually depends on what stage or what is the percentage of methemoglobin. It can come with chocolate cyanosis, chocolate colored. Patient may present with headache, CNS manifestation, sometimes GI upset, dyspnea. It may reach in a high level to a CNS seizure or coma, or sometimes, if not treated well, it may go to a death. Okay, so it depends, as we mentioned, is to the level. Usually the level below 20, no symptoms or very mild cyanosis, and up to 20%, you can see the cyanosis clearly, and patient may have mild symptoms of nausea, some dizziness is there, If it reaches to 50, the cyanosis will become more profound, and the symptoms become more headache, more dizziness, nausea, vomiting, dyspnea, and in severe cases up to 70, it has become with CNS manifestation of seizure, coma, and the cyanosis become more severe, more clear, and more than 70 usually is lethal. So it is a significant problem. So that leads to death. So we need to recognize it. And we need to do some investigation. So usually the color of blood, it is chocolate color. This due to the presence of methemoglobin level very high, and it's actually correlate also with the percentage of methemoglobin in the blood. Okay, ABG usually it has a normal partial oxygen pressure, but the saturation is very low because the saturation machine, it is actually reading the wavelengths of the oxygen in the blood. That's caused something called saturation gap, and that helps us also in diagnosing the methemoglobin. Okay, so then you do for either ABG or VBG, whereas usually in new machines have a methemoglobin level, which is the diagnostic. So basically, usually the patient with an exposure to the forming agent of methemoglobin, plus the clinical presentation, that will give you a clear clue what is going on. Methemoglobin causes usually either a congenital, like this cytochrome B deficiency or reductase deficiency, whereas actually the reduction of methemoglobin to the normal hemoglobin, and this is usually the mechanism of action, because in the body there is a usual up to 1% production of methemoglobin on normal basis, and this mechanism will reduce the methemoglobin level in the blood if there is no agent that increase the dose of methemoglobin. Okay, so acquired is a very long list of medications, chemicals, and a lot of things. And you can see dapsone is one of the most common anti-malaria. We treated methemoglobin with amyl nitrate, and amyl nitrate can cause methemoglobinemia also. And there is, which is a well-known nitrate, which we are using for chest pain and other things. It can cause, and anything with nitrogen and nitrate can cause methemoglobinemia, like a fire, smoke inhalation. So not only CO poisoning, but it can also comes with methemoglobinemia. So as we mentioned, the treatment is simple and is gold standard, methylene blue. Methylene blue is antidote of methemoglobinemia. And it can use for other uses also, and we put the methemoglobinemia in the, down in the list. Okay, so the pharmacokinetics, the mechanism, maximum effect is up to 30 minutes. If we use it in small doses, we get our reflex of oxidizing agent to hemoglobin again, but if we are using it in high concentration, we actually producing methemoglobin again. So elimination by bile, feces, and urine. So what is the dosage? And when we use it usually in very high concentration, more than 20, and in the patient is symptomatic. So we give it in a dose 1 to 2 milligram per kg over 5 minutes, slow infusion. Okay, and till the cyanosis is resolved, usually within 30 minutes. But this is not the final point we are looking for. It's actually we repeat the level, okay, and we see it's actually dropping down, okay. So caution in G6PD, because methemoglobinemia in G6PD patient can cause hemolysis. So if there is a need, real need, then we need to use it with caution, with very small dose of 1 milligram per kg only. And we keep rechecking methemoglobin and hemolysis pictures, okay? And the side effects, as I mentioned, is according to the dose, how much we are giving. Okay, back to our cases. Our cases, we give 2 milligram per kg for him, and the cyanosis and the clinical improvement was so fast, within 20 minutes. Patient was intubated in the second day, and he was admitted to a psychiatric hospital because of his suicidal attempt. By this, I conclude my lecture, and happy to receive any question.
Any question? No? Because we are running out of time, so thank you so much.
Thank you.
Next presenter, medical toxicologist and also board certified in emergency medicine. He also obtained postgraduate diploma in medical toxicology from Cardiff University in the United Kingdom. Please welcome Dr. Walid. I'm sorry, Dr. Awad.
Thank you very much. Assalamu alaikum. We're gonna go within the coming 10 minutes fast through this subject, which is the aluminum phosphate. I think they put it, the moderators and the organizer, they put it in this session because they know the severity of this substance. I don't have anything to disclose. We're gonna go in this lecture through the background, the epidemiology, the toxodynamic, the clinical presentation, the diagnostic workup, and the management. First of all, aluminum phosphate is one of the fumigants, which is non-specific pesticides applied to kill and control rodents, insects, weed seeds, and fungi anywhere in the soil, structures, crops, and grains. And it have different chemicals, physicals, and mechanism of toxicity. Aluminum phosphate is the most common one. It have different metals. It's, the most common is the aluminum, but there is zinc, magnesium, and calcium. It is, as we said, used for protect grains held in soils, ships, and during the transportation. Because of it is low cost and high effectiveness, freedom from toxic residues, and lack of adverse effect on the seed's viability. That's why they use it widely. In the last 35 years, the cases of aluminum phosphate increase dramatically, and this is mainly because of the advanced transportation and manufacturing of this substance, as well as start to be used as a suicidal substance for suicidal purpose. It is very common in agricultural society, India, Sri Lanka, Iran, Jordan, and Morocco in the region. And that's obviously because it is available in that society, and it is less and rare in Europe and North America. Aluminum phosphates, the first picture, it is the most widely available. It is, as it there in the picture, the greenish tablet with the garlic order, and each tablet has 3 grams of aluminum phosphates. And it contains also some ammonium carbamates and urea. The zinc phosphides, as in the second picture, look like dark gray powder or crystal. The odor is like rotten fish. Calcium phosphates, as in the third picture, look like reddish brown powder. Aluminum phosphate, actually, when it is mixed with the moisture, ambient moistures, it will give the phosphine gas, which is the main cause of the toxicity, the cytotoxicity, and which is going to lead to the death later. If it is mixed with water, this will lead to rapid release of the phosphine. And this is significant because mainly in the suicidal attempts, they intend to take water on top of these tablets, and this makes the condition faster and make the severity worse. The mechanism of toxicity it will be through blocking the electron chain transport by inhibiting the cytochrome oxidase and formation of reactive free hydroxyl radicals and reduce the glutathione. This will result into lipid peroxidations, protein denaturations of the cell's membrane, and interfere with the enzymatic function and synthesis of protein. It also causes acute respiratory distress syndrome through direct injury to the alveolar capillary membranes and by producing oxidative injury. It also have effect and inhibit the cholinesterase activities, but this not to the clinical significant level. The toxic dose for the zinc metals, it's around 1 gram, and the death can happen if there is around 4 gram ingestion. For the aluminum phosphates, 500 milligram can be fatal. The smell, the garlic smell, it is very common with aluminum phosphate. So if you smell it in your department, you have to think about aluminum phosphates. The clinical manifestation, it depends on the dose, the route of entry, if it is ingested or inhalated, the time to exposure, how long, especially for the inhalation. And the aluminum phosphate, it have rapid effect than the zinc phosphate. So the zinc phosphate, the symptoms can happen even after 40 minutes. The clinical manifestation, if it is mild, then it will be GI symptoms. It will be around, mainly about the GI symptoms: nausea, vomiting, diarrhea, discomfort of the abdomen, epigastric, and tachycardia as a result. Moderate to severe symptoms, it will involve multiple systems, the GI, and this even can reach to hepatic failure, cardiovascular, hypotension, palpitation, cardiovascular collapse, and dysarrhythmia. CNS, secondary to the hypoxia, there will be dizziness, confusion, convulsion, and coma. Respiratory, tachypneic, and ARDS. Renal failure, metabolic acidosis, airway irritation, especially in inhalation. The diagnostic test, what is in this slide is usually, actually it measures the complication of this substance into the body, the CBS and the coagulation profile to check for the intravascular hemolysis, methemoglobinemia, and DIC. The chemistry, looking for the hypokalemia, hypo and hypermagnesemia, hyper and hypoglycemia, acid-base balance, metabolic acidosis, the main, and there will be also respiratory acidosis and lactic acidosis. Acute kidney injury, we expected in these cases, chest X-ray to check for the ARDS. ECG it is very common to see ECG change in these cases, but it is variable. Tachycardia is the most common and to start with. Then there will be T wave and ST change. Ventricular and atrial tachyarrhythmia is common. Echo to measure the effect on the heart. There will be a dysfunction, dilatation, hypokinesia, and akinesia of the left ventricles. As a toxicologist, we don't recommend to do a specific test for the physogene to measure the phosphine in the blood or in the urine because it is rapidly oxidized. But for some reasons, medico-legally, you may need to do that. The most specific and sensitive test is the gas chromatograph. Also, silver nitrate test can be done through the gastric contained and exhaled breath. Treatment start with decontamination. Inhalation, for inhalation cases, the best is to remove the patient from the source and supply oxygen as needed. For the cutaneous exposure, remove the clothes and try to decontaminate with water. Don't forget the eye. For ingested cases, the best to be done within the first 1 or 2 hours. There is a limited evidence about the activated charcoal, but if it happened within the first 1 hour, then no harm to do it. There is experimentals talk about oral administration of sodium bicarb to prevent the conversion of aluminum phosphate to phosphine. Also, there is a case report suggested using potassium permanganate as adjuvant to oxidize the phosphine to non-toxic phosphates. Vegetable oils and liquid paraffin in vitro suggested inhibit the conversion of aluminum phosphide to phosphine, and there is also single case report. Secondary contamination, definitely we are recommending everyone to have his precaution, but you have to keep in your mind that the particular mask will not prevent phosphine from reaching to you. And there is studies from India. It showed that the staff, the hospital staff there, although they didn't have using their specific precaution, but there is nothing, no positive effect on them. There is no specific antidote for treatment. The main treatment is conservative and supportive treatment till the toxin leave the body. Shouldn't be delayed to confirm the diagnosis. And according to the symptoms, the treatment, the arrhythmia using antiarrhythmic, shock, try to use to be guided by the CVB and wedge pressure. Use vasoactive sub-agent according to the need, pacemakers and mechanical support according to the need. The ARDS, ventilatory support. Metabolic acidosis, you can use the sodium bicarb, hemodialysis according to the need, and don't forget to correct the electrolytes. Some studied about use of NAC in acetylcysteine. There is experimental in animal, and then human studies show some beneficial. Brodoxime, both the phosphine and aluminum inhibit acetylcholinesterase, as we said earlier, but to a level not significant. Further study needed in this subject. Hyperbaric oxygen, experimental data show that it improves the survival time of rates and poisonous rates, and with no change in the mortality rate. Magnesium sulfates act as a cell membrane stabilizer factor and reduce the incidence of fatal dysarrhythmia. Antioxidant effect and combat with the free radicals, and this is controversial. Hemodialysis to help the effect of the renal failure cases and to clear the acidosis. Insulin and glucose, it is suggested by some investigator because of it, the effect of insulin promote the energy and produce production of carbohydrate and restore the calcium flux, which improve the myocardial contractility. Trimetazidine, this is helping approach the BVCs and by Geminis, this is in case report, and act as preserve oxidative metabolism, which need further investigation. Intra-aortic balloon pump to help the pressure, ECMO in circulatory failure, not formally evaluated, and thank you.
Thank you for your presentation. Any question? No. I have seen some country recommend using the coconut oil to lavage instead of using like fluid. Water.
Actually they do it from the local experience, but there is no proven study for that. If it will not help, it will not harm. Yeah.
I would think so, because oil can cause pneumonitis as well if the patient aspirates. Yeah. Right. Thank you so much.
Is currently working as emergency medicine consultant in Ankara University Faculty of Medicine, Department of Emergency Medicine. Yes, please.
Good afternoon, everyone. I will thank the organizing committee and scientific committee for the great conference. I will talk about methanol poisoning for the golden hour management in the ED. Methanol, also known as wood alcohol, is a commonly used solvent in various solutions. But in Turkey, we see methanol in imitated labeled alcohol. A commonly used organic solvent contains in perfumes, photocopic fluid, windshield washing fluid, and perfumes also. Methanol is a component of the many industrial solvents and poorly adulterated alcoholic beverages. Methanol poisoning is a common problem worldwide, especially in the lower socioeconomical countries, and methanol may cause outbreaks. Methanol is relatively low toxic, but metabolism is formic acid is a toxic. First, upon ingestion, methanol absorbed in the gastrointestinal tract rapidly, then metabolized in the liver. First, methanol transformed the formaldehyde with enzyme alcohol dehydrogenase is a slow reaction. Then formaldehyde transformed to formic acid with enzyme aldehyde dehydrogenase, and lastly, formic acid oxidized to carbon dioxide and hydrogen, presence of cofactor tetrahydrofolate. Last enzyme, formic acid to the carbon dioxide to the hydrogen, carbon dioxide and water, a very slow reaction. So in methanol toxicity, formic acid accumulates and causes metabolic acidosis. Who is at risk? Children. Accidentally overdoses of any solvents containing perfume, windshield washing fluid. Suicide attempts with methanol is uncommon. Methanol toxicity may be seen in alcoholic persons. Alcoholic persons consume methanol as a substitute for ethanol. And developing countries like ours, imitated, labeled alcohol or homemade alcohol may cause methanol poisoning. In a recently publication from our clinic, an ingestion is very, very high. But in this case report, we report a transdermal methanol intoxication. 58-year-old woman presented to emergency medicine with dizziness, diplopia, nausea, vomiting. She uses a methanol-containing solution for knee pain. In Turkey, we say that a ratio in fluid for food heater. We treated this patient with ethanol, sodium bicarbonate, and hemodialysis, and completely resoluted. No sequelae. Initial symptoms of methanol toxication generally occur after ingestion of 12 and 24 hours later. This latency is due to enzymatic reaction and may be affected with concomitant and ethanol ingestion and volume of methanol ingestion. Methanol blood peak levels 30 to 90 minutes after following ingestions. Initially, methanol toxicity manifests like ethanol toxicity, inebriation, ataxia, disinhibition. Following a latent period, patient may develop headache, nausea, vomiting, epigastric pain, and later stage, drowsiness to augmentation and coma may occur. Seizures may occur due to metabolic derangements and brain injury. Blindness is a very well-known complication of the methanol toxicity. Vision loss is due to formic acid. First, we see flashes of light and blurring, and then scotomata and complex loss of vision may be seen. When we think about methanol toxicity, any patient with any cause of altered mental status with acidosis, we think methanol toxicity, ethylene glycol intoxication, cocaine poisoning, inhalant poisoning, complex partial seizures, carbon monoxide poisoning, in keeping in mind these patients. Basic workup includes finger stick glucose, acetaminophen salicylate levels, electrocardiogram, pregnancy test. Electrocardiogram is important for the toxic alcohols. Ethylene glycol causes QT prolongation, and methanol does not. Specific workups are arterial blood gases, electrolytes and anion gap, BUN creatinine, serum ethanol level, serum osmolarity, methanol, ethylene glycol, and isopropyl alcohol levels, if available, and pancreatic enzyme. Methanol toxicity can cause hemorrhagic pancreatitis, a very common unreported cases. Serum osmolarity first increase, then decrease, accompanied with increase in anionic gap. Methanol toxicity affects the basal ganglia, primarily putamen. Bilateral putaminal necrosis and varying degree of hemorrhages can be seen in brain CT and brain MRI. This is not specific for the methanol toxicity, can be seen in stroke and Wilson disease. Prompt medical care is key to avoid complication of methanol toxicity. Also, antidote therapy and hemodialysis is key. Supportive care, airway, breathing, circulation is essential. Antidote therapy with either fomepizole or ethanol must be started as soon as possible, and hemodialysis is the definitive treatment of the methanol toxicity. Early consultation may be needed, especially in nephrology, neurology, ophthalmology, toxicology, and sodium bicarbonate. Sodium bicarbonate improves metabolic acidosis. Its effect formic acid to the format, conversion formic acid to the format. This may reverse the visual deficits. Format cannot easily damage the retina and optic nerve, but formic acid damages the optic nerve and retina. Dose of sodium bicarbonate is initially 1 to 2 equivalent per kilogram in intravenously bolus. Maintenance dose is 20 to 40 milliequivalent per hour. Antidotes, if available, we prefer fomepizole or ethanol. If unavailable, ethanol. Both of them emit the enzyme alcohol dehydrogenase. Fomepizole is superior to ethanol because easy to dose, easy to administer, rare side effects. Its disadvantages of the fomepizole is its high cost. Loading dose is 15 milligram per kilogram intravenously. Maintenance dose is 10 milligram per kilogram every 12 hours for 2 days. Ethanol difficult to dose. Frequent testing and infusion adjustment needing, and ethanol irritates veins. Its more limiting effect is sedative and behavioral effects because ethanol inebriates and aspiration risk is rises. Hemodialysis removes both methanol and formic acid. Indications are high anion gap, metabolic acidosis, evidence of organ damage, especially visual changes. Cofactor therapy may be outlined. Optimize the non-toxic metabolic pathway for the elimination. Doses is 15 milligram in every 6 hours. Thanks for your attention. Any question?
Thank you, Dr. Young. Any question or Eddie? That okay. We have seen recently in our country ethanol poisoning is an important issue. Ethanol is an important issue. Yeah. Any question?
Hi, thank you. Just on one of your slides, you suggested that the visual defects can be corrected by sodium bicarb. I'm not sure how accurate is this. And the second point, as far as I know, although formic acid being implicated in the visual sequelae of methanol poisoning, it's not fully understood, because formaldehyde, which is one of the metabolites of methanol, which end up leading to formic acid, when people get poisoned by formaldehyde, which was more common in the 70s and 80s, they did not get visual defects. So the notion that formic acid is the culprit is, as far as I know, it's not 100% accurate, and also that's applied to the sodium bicarb. I don't know what's, if everybody else has any other opinion about
it. Visual deficits is due to formic acid's effect on optic nerve and retina, and sodium bicarbonate transforms the formic acid to the formate. It did not readily diffuse the optic nerve and retina. I can think this may be reverse the visual symptoms. I don't know the mechanism. I don't know.
Okay, thank you. Any questions? We listened to important issue from very valuable speaker. Unfortunately, this section ends here. Thank you for listening. And
thank you for everyone. So next one is the break, and then we will come back in 15 minutes, okay?
Unfortunately, Dr. Tharwat El-Zahran is ill, and she have to be in her room. So we have the great pleasure to welcome Dr. Ritrak Ohong. Ritrak is the residency program director in the emergency medicine department of Vajira Hospital in Navaminokhadhiraj, sorry for the pronunciation, university in Bangkok, Thailand. He did his fellowship in the US in the MRA program with Ziad Kadzi, and he's specialist of QT measurement with all the methods and QT interpretation when they are influenced by drugs. And he's responsible for the AACT, ACMT, and EIPCCT work group that is in charge of recommendations to measure QT, and we are waiting for these recommendations soon. So he will present us his lecture dedicated to the diagnosis and management of drug-induced QT prolongation. Thank you, Ritrak.
Thank you so much, Mr. Chairman. With my pleasure to present my lecture today. I'm going to talk about diagnosis and management of drug-induced QT prolongation. I thought I had 30 minutes for these lectures, but I just realized that I only have 20 minutes, so I'm going to be fast. But if feel free to ask me after I finish the talk. I have no conflict of interest. And for the outline, I'm going to talk about the introduction, why QT prolongation is so important, QT measurement, how do we do it, and what is the definition of QT prolongation. And about the QT collection formulas, we have some doctors from Australia. They may say, hey, we don't do formula right now, we do QT nomogram. I'm going to talk about that a little bit as well. And I'm going to talk about the risk factors for QT prolongation and torsade de pois. I'm sorry, Dr. Bruno, I may not pronounce torsade de pois correctly because it's French. Maybe you can correct me later. And okay, and also I'm going to talk about the management of QT prolongation and torsade de pois. And I'm going to start with why we are so afraid of QT prolongation, right? So that is the reason. Sometimes, QT prolongation can deteriorate to the torsade de poids, which is some kind of polymorphic ventricular tachycardia. But most of the cases, torsade de poids can stop spontaneously, but sometimes it can degenerate to ventricular tachycardia and VF. And what is the incidence of torsade de poids? Is estimated to be between 1 to 10% of patients receiving QT prolonging drugs. That is from antiarrhythmic drugs, but it may be much lower for non-cardiovascular drugs, for example, SSRI. But we actually don't know exactly what is the incidence rate of the case from torsade de poids, because most of the sudden death cases occur at home. And from this study, we know that the rate of QT prolonging drug medication use is increasing over time from this US study, and it has a sharp rising of the QT prolonging drug use. So I think this may be very important for us. And also in medical toxicology, we have seen a lot of QT prolongation from drug overdose as well. And if you are wondering how can we know what medication can cause QT prolongation, you can go to the credibilmeds.org. If you are so lazy to write down the credibilmeds.org, you can take the picture of the QR code over there, and you can, go to the website by just, one click, okay? In this website, they will give you the categories of QT prolongation risk as a known risk, possible risk, conditional risk, and also drugs to avoid in congenital long QT syndrome. Okay, next one is about how to measure the QT, okay? I think everybody know what is the QT, right? The QT start from the beginning of the Q wave and the end of the T wave. If you have a very nice and very clean ECG like this, it is easy for you to measure, right? You can measure from the beginning of the Q wave, and you can identify the end of the T wave very clearly. But do you know how many types of T wave morphologies? Let's do a game. Who think there's 7 types of T wave? Raise your hand. 8? Raise your hand. 9? No? Okay, one bet. 10. What about the rest of you? Please help me.
12.
Bruno said 12. Okay.
I don't know.
All right, I'm going to give you the answer. So at least 10 morphologies that we know of. So if we have like something like biphasic T wave, how do you measure it? And what about the notch and bifid T wave? How do you measure the QT? And sometimes, you have like the inverted T with a little bit bumped after almost the end of the T wave. So how can you measure it? And I'm going to lead to the next question. How many accepted standard methods to measure the QT interval? 1, 2, 3. Who have no idea? Raise your hand. You have no idea? Okay, I'm going to give you some idea about how many methods. So we have 2 accepted methods, okay? I have a quote like accepted because, nobody say what is the standard right now, but most of the study, they only talk about these 2 methods, the tangent method and threshold method, okay? For the tangent method, you draw the tangent line on the steep slope, okay, on the terminal limb of the T wave, and you draw the isoelectric line. The end of the T wave is the intersection between the tangent line and the isoelectric line, okay? But for the threshold method, this pointer is not working on the LCD. I'm so sorry about that. For the threshold method, you just take a look at the end of the T wave, and when the T wave end at the isoelectric line. Okay. So, what about clinical differences about these two different methods? Are there any differences, do you think? So this study looked at the difference between the two methods, if they are clinically significant. So they had two groups of patients. One is the control group. Another group is those who had congenital long QT syndrome, who confirmed by the genetic test. And you can see the tangent method give the shorter QT interval when compared with the threshold method, and that is between 6 milliseconds to 12 milliseconds, and those of number were significant. And what about the diagnostic performances and validity between the two methods? You can see here, when they use the cutoff value of the QT best set by the QT best set as 480 milliseconds as the cutoff for the QT prolongation, you can see the threshold method provided the better sensitivity, almost double compared with the tangent method, while the specificity they are almost the same, and also with the inter-rater and intra-rater validity they are almost the same. It's really high, above 0.95. So the author concluded that the tangent provided a shorter QT interval compared with the threshold, but both methods have a high validity. And for the diagnostic performances, each method yields different results. So when you want to apply the cutoff value from whatever study you want to your patient, you just make sure you follow their method, okay? If they use tangent method or they use the threshold method, you cannot use interchangeably because it's gonna cause the wrong assumption. And what is the normal QT interval? This is defined by the normal population at the 99th percentile. In men, it's defined as at the 470 milliseconds. In women, 480 milliseconds. And the risk of arrhythmia is going to increase 2 to 3 times if the QTC is higher than 500 milliseconds. But we also have to think about, we know that the QT has dependency with the heart rate. So how can you correct the QT by the heart rate? This is going to be my question again. What formula do you use? Beset? Raise your hand. You don't raise your hand, but you not. Okay, good. At least I know that you are interacting with me. Beset again? Yes? Okay. Who is using Fidelia? No? No? Okay. Rota Haju formula? Never heard of it, right? Okay. Next one, another formula? No idea. Framingham, Hodges? No? All right. QT nomogram? Yes. Okay. He's from Australia, to be clear. Okay. And who is going to use the QT alone without any correction? I'm not going by book. I'm going by myself, using the QT alone, no correction. No? What about the last one? I would bet this is the largest number. Use whatever reported to you, right? Or whatever number you see on the ECG printout, right? Okay, you are normal. Because I'm going to show my study. This is a survey study among the medical toxicologists in the US, in Europe, and Asia Pacific region, including Australia and New Zealand. Yes, you're correct. The highest number is about half of the one that participated in my study would just use any number reported to them to the poison center or whatever number that were on the ECG printout. But for those who are going to measure the QT themselves, they still use Beset. Even though we know that the Beset formula received continuous criticism for this method, because at the fast heart rate, it can cause overcorrection, and at the slow heart rate, it can cause undercorrection. In 2015, a team of cardiologists from Canada, they review most of the existing formula for the QT collection. You can see there the green line, the green box. You can see the Beset is constructed from just 39 cases in 1920. The same year with the Fidelia, that is created from just 50 cases. But what about the newer formula by the Rotahaju, the yellow one, is created from 50,000 cases, and Dimitrenko created from 13,000 cases. So this group, they obtained 107 ECG from their hospital, and they plot the QT interval against the heart rate, and to see which formula would provide the best method that are not dependent on the heart rate. So the slope should be 0, okay? That would be the best one. So you can see all of these, Beset, Fidelia, Framingham, Hodges, they have a significant slope. Only 2 formula that is created from more than 10,000 cases. The Dimitrienko formula in the red box, and the blue box is from Rotahaju. Those provided almost 0 slope. And I did a study from these 2 formula compared with the Beset and Fidelia formula if they can predict Torsades better. And here you go. This called QT nomogram. Is widely used in Australia, and this the only tool, right? In Australia you use right now? Yeah, they don't use a formula at all. And this is my study just published last year in 2019 to look at the sensitivity, specificity, and accuracy of our tools. And we found that QT Rotahaju with the cutoff at 477 provided the same sensitivity, specificity, and accuracy with the QT nomogram, which is the highest one at 89% for the accuracy, with the highest sensitivity at 91.3%. This is the graph. The green one is those without Torsades de Pointes, and the red one are those with Torsades de Pointes. So the author conclusion, which is mine, I concluded that at the cutoff point at 477 milliseconds, it provided the best accuracy with the best sensitivity as same as QT nomogram as a risk prediction tool for drug-induced Torsades de Pointes, and that is the formula. And we know that those who had Torsades de Pointes doesn't only have only QT prolongation. You have seen a lot of patients had like QT like 540, 560, but how many of them are turning to Torsades de Pointes? Just a few, right? Just a few, like 1%, maybe less than 1%. Why? Because most of the cases, when they overdose medication, they are healthy. So sometimes, just they are doing well, after overdose, even they have like QT prolongation. But those who have multiple risk factors like this may be at risk for Torsades de Pointes more than anybody else who had no risk factor at all. And we can divide the risk factor to modifiable risk factor and unmodifiable risk factor. For example, female sex, advanced age, heart disease, and clinical silent risk factor like congenital long QT syndrome. Like that, you cannot change it, but something you can change it. For example, the concurrent medication use that has potential for QT prolongation, rapid IV infusion, hypokalemia, hypomagnesemia, hypocalcemia, something like that, you can change it. And then you can, modify the patient risk factor. And I'm going to go over for the treatment. over the next 3 minutes. For this is the case scenario with a 41-year-old man ingests a handful of unknown medication 5 hours prior to the hospital presentation. He's previously healthy and he denies using any medication, alcohol, or cigarettes. His vital signs are stable and he's conscious. No lab information is available right now, and his ECG show QTC of 560 milliseconds with the heart rate 52 beats per minute and the QRS 80 milliseconds, and the rest of the ECG is unremarkable. Questions. 1. Would you administer IV magnesium sulfate? Who's going to say yes? Raise your hand. Don't be shy. Come on. Who's going to say no? And say nothing. Come on. No? No, no, no. Okay, I can see you like no. All right. Shake your head. I am okay with that. Next one, would you pace him? Yes? No? Okay. Next one, what pacing method do you prefer if it is indicated? Pharmacological pacing? No? Transvenous? Transcutaneous? Okay, next one. Would you increase serum potassium to 5 millimole per liter? Yes? No? No. No idea. Okay. I'm going to give you the answer. This is the HA guidelines in 2006. The class 1 recommendation is very clear that you just, remove all the offending agents that cause QT prolongation, okay? And the next one, the class 2A, is to give IV magnesium sulfate only when the patient already have torsade de poor, not for QT prolongation alone, okay? And pacing as well, you only pace them when they already have torsade de poor and also when they have recurrent torsade de poor. If they only have one time of torsade de poor, is not indicated yet. And the potassium as well, you no need to, give the potassium if the patient only have QT prolongation alone without torsade de poor, but just check potassium, magnesium, and calcium level, just normalize it, not keep it that high. And in 2010, they made it clearer for what to do for the QT prolongation alone, not for torsade de poor. So when you look it up from circulation 2010, you will not see ABC mnemonic like this because I think of it myself and I put it this way myself, okay, so that you can remember it easily. The first one, A, is to assess aggravating drug-drug interaction, assess the bradyarrhythmia, concomitant electrolyte abnormality like hypo-K, hypo-MAC, hypo-Cal, and also prepare defibrillator in case you need to use it when the patient has torsade de poor. And be aware of the QT prolonging drugs and avoid it, if you have some medication on for the patient. And then put the patient on the continuous cardiac monitoring. And what I going to do if your patient had torsade de poor already? This is the management for non-sustained and sustained torsade de poor. Firstly, you have to assess the patient if the patient is stable or not. If your patient is not stable, like no pulse, unconscious, you need to defib the patient. But if you can still feel the pulse and the patient is still conscious, and it's not stopped itself, you just do the cardioversion, okay? And also you defib as well if it's degenerate to BF. But if your patient has repeated episode of torsade de poor, that is the indication to give IV magnesium sulfate, and I would recommend you to give 2 grams of IV magnesium sulfate. And you can repeat it once if it's not terminated. What is the mechanism of magnesium sulfate? Why is not recommended to give for just QT prolongation? Because magnesium sulfate only suppress torsade de poor without shortening the QT interval, okay? By suppressing the early after depolarization, that trigger torsade. And the early after depolarization suppression by magnesium has been attributed to the calcium channel blockage by the reduction of the lead component of the sodium current. And that is why, verapamil has a limited evidence that it can be effective for torsade de poor. stop. And however, because this is just some case report, and verapamil also block the potassium channel, and also verapamil is going to cause bradycardia. So at this time, I would not recommend verapamil until we have more evidence for that. And also magnesium sulfate is also a cofactor in sodium potassium ATPase activity, so it may prevent torsade by facilitating influx of potassium into cells, that is to stabilize membrane potential. And this study is the classic study showing that when you give magnesium sulfate, it doesn't shorten the QT significantly, okay? And when your patient have repeated episode of torsade, another prevention that you can do is to pace the patient, but do not pace the patient with the high rate, because the high heart rate can also cause torsade as well. So just pace the patient at the 70 beats per minute, okay? You can use medical overdrive, or you can use the mechanical electrical for the transvenous pacing as well. For medication, you can use isoproterenol or aminophylline. And just remember that if your patient also have a congenital long QT syndrome, avoid adrenergic medication. Just use transvenous pacing instead, and keep the potassium high about 4.5 to 5 millimole per liter. Okay, and also be careful if your patient have acute myocardial infarction, angina pectoris, or hypertension. They are contraindicated. This is some new study that mexilitine is a selective sodium channel blockade that can be effective as well, but at this time there's limited evidence as well. Lidocaine has been used as well, but it's not effective when it was infused continuously. Many times patients will have recurrence of the torsade. So in summary, all the older people and those with multiple risk factors, they are prone to have QT prolongation and torsade de pointes. And I recommend you to use the more accurate QT correction formula, because it's gonna make another, different assumption if you use the wrong one. Or if you don't want to calculate it, you use a QT nomogram, okay? And below are the summary for the treatment for the QT prolongation. Mostly you just, place the patient on the cardiac monitoring, stop medication and correct electrolytes. And for the torsade de pointes, you just, do the same with the QT prolongation, and you use electrical termination if the patient has torsade de pointes. Use IV magnesium sulfate and water pacing when they have repeated episode of torsade de pointes, and to keep potassium that high. Okay, thank you for your attention.
Thank you. Thank you, Ritrak, for this very nice presentation. Any question from the floor? Maybe just one question. Okay, so it was so clear that we all understood everything.
Yeah, I have asked them so many questions. They have no question at all, actually. Thank you.
Thank you
for your
very
attention.
much. Okay, so we'll move rapidly to the second presentation. Dr. Sevile Vural. So Dr. Vural is Assistant Professor of Emergency Medicine at Yozgat Bozok University in Turkey. Her areas of interest are point-of-care toxicology and medical education. She will talk about diagnosis and management of drug-induced rhabdomyolysis.
Yeah.
Thank you very much.
Thank you. Hello, everyone, and I want to thank you to participate in MENA-Talks 2020 in Turkey. And we will be talking about drug-induced rhabdomyolysis in this session. Our goals for the session will be how to recognize and manage the patients with drug-induced rhabdomyolysis, and most importantly, how to avoid drug-induced rhabdomyolysis in these patients. Unfortunately, the literature has very limited specific information about drug-induced rhabdomyolysis. And most of the reported papers are based on case reports. But we can come across with some specific topic which are on specific drugs. For example, statins, for example, propofol, or MDMA. So we will talk much about rhabdomyolysis general principles for this issue. Rhabdomyolysis, aka rhabdo, or the other name for it, acute necrotizing myopathy. It's a life-threatening condition resulting from rapid destruction of skeletal muscle cells. So the consequence is release of intracellular constituents into the circulation. Luckily, it's a rare event, but the drug-induced rhabdomyolysis cases are increasing in number. If we talk about data regarding rhabdo, majority of the cases are adult patients, and the adults, for adults, trauma and the drugs are the major components. But in some studies, it's shown that most of the time, the cause is multifactorial, not only just drugs, not only immobilization. Generally, more than 2 reasons is present for most of the patients. Incidence for rhabdo is 100,000 per 100,000, 1.6. And incidence, for example, much specific point for statin-induced rhabdo, it's 0.3 to 13.5 per 1 million numbers. Most important concerns about the rhabdomyolysis is acute renal failure development, and it's present in 10 to 40% of the cases. And the mortality numbers are not so low as we expected. Rhabdomyolysis etiologies is commonly classified in 3 major groups, and the drug-induced rhabdomyolysis is belong to non-traumatic, non-exertional group. Most of the time, for physicians, the natural link between this situation and the results going to rhabdomyolysis or acute renal failure is quite evident. For example, in a patient trapped under a rock, of course, you immediately think about this patient will suffer from, is suffering from crash syndrome, and probably he or she will suffer from acute renal failure. But in case of drug-induced rhabdomyolysis, the natural link is not quite easy, even for physicians, even for emergency doctors, even though if you are a toxicologist. And that's one of the reasons that's the more silent presentation. But it's not that, it's not all. For example, again, if you think in general, a target organ for a toxicology, a drug toxicology generally targets an organ, and the most specific ones that we think that it could be central nervous system, it could be liver, it can be kidney, yeah, or it can be even skin. But we do not expect a skeletal muscle cell as a target organ of a toxicological state. So it's in summary, it's an unusual organ for us. More silent presentation, as I mentioned before. It was uncommon in the past because, as you know, the drugs we prescribed is such a low in number. But in nowadays and in the future, it will be increasing. And another one, that the complications can be prevented and reversed by early diagnosis and the high clinical suspicion. There are some clues that we can increase the natural link for a physician. For example, lack of pre-existing muscular symptoms. For example, lack of any other causes for the myopathy. Or the presence of a reasonable temporal relationship between the start of the treatment or change of the dose of the treatment or the appearance of the symptoms. And lastly, maybe partial or complete resolution of the symptoms after the drug is withdrawn can give us a clue about it can be drug-induced. The main groups of drugs that related with the drug-induced rhabdomyolysis is the prescribed drugs by us in our daily clinical routine. And the others are alcohol and the illicit drugs like heroin, like cocaine or amphetamine or what else? Lots of choices. The prescribed drugs or the drugs we use in our clinical routine have a huge list. The list is quite crowded. For example, in the list you can see antipyretics, you can see antibiotics, you can see antidepressants, you can see antipsychotics, you can see analgesics, you can see benzos, you can see lots of drugs that cause rhabdomyolysis. But we have to be extra careful, especially about statins, lipid-lowering drugs. There are some novel drugs about the related with drug-induced rhabdomyolysis. One of the most important ones, I think, the tyrosine kinase inhibitors, which are used in HIV treatments, and maybe you just noticed that propofol that we use in ICU or emergency settings. When I am working on this session, on this topic, I just realized, is there any internet resources for helping physicians, helping me? And I just came across a website, www.adratlas.com. And this website contains info about US FDA approved drugs and their potential for drug-induced rhabdomyolysis, specifically on this topic. So, for example, if you wonder any drug, for example, rovastatin, and what's its potential for drug-induced rhabdomyolysis, you can see such a result on the screen. Pathophysiology, yes, I will talk about with a few slides, but you know the story. The basic pathophysiology is common for all etiologies of rhabdomyolysis. Muscle injury, the origin point of it. And the injury is followed by myotic cascade and then release of all the inside content of the cell. Common steps, damage of ion channels, increased intracellular ionized calcium, activated destructive enzymes such as phospholipase and protease, and finally myolysis, cell death, and the leakage of the contents. And what drugs do? We can look at it in two categories. On direct category, inhibition of calcium metabolism by the sarcoplasmic reticulum. Impairment of the production of ATP causing disruption of the cell membranes and alterations in carbohydrate metabolism. The indirect mechanisms are drug-induced coma causing prolonged immobilization and muscle compression. For example, very long surgery, another one. Seizures, myoclonus, causing increased oxygen demand on skeletal muscle tissue. If we go step by step, yes, the injured cells then leaked into the circulation. One of the most important molecule in this leakage is myoglobin. Of course, it's not the only one. The other substance released into the circulation, CK, potassium, sodium, phosphate, AST, ALT, LDH, uric acid, and water. And so we measure high potassium levels, high sodium levels, high CK levels, high phosphate levels. But myoglobin has another thing, a unique feature in this pathophysiology, because it's physically, first of all, obstruct the tubules of the nephrons. And in cellular levels, it's nephrotoxic to the kidney cells. So the finally acute kidney injury is seen. So the primary cause of renal injury is myoglobin. Indirect and direct and cellular and physical mechanisms, it can be seen. And hypovolemia and metabolic acidosis also play a role in renal injury in rhabdomyolysis. Signs and symptoms, yes, we have a classic trait of rhabdomyolysis symptoms. It contains weakness, muscle aches, and tea-colored urine, but only less than 10% of the patients has a classic triad. And more than half of the patients do not complain about any muscle pain or weakness. And tea-colored urine, yes, it's very specific for this situation, but only seen in 3.6% of the patients. So, if we are going to talk about signs and symptoms, we can say that patients probably present without any signs or symptoms. Risk factors: female gender, older age, concomitant diseases, and multi-drug use are the reported risk factors for drug-induced rhabdomyolysis. Also, if we want to risk assessment about which patients go to do acute renal failure, what's the ratio of this, there is McMocan scoring system, but it's not very specific. It's a general scoring system for all rhabdomyolysis cases. Diagnostic tools, we have urinary analysis, blood, EKG, imaging, and muscle biopsy options. And most of the time, we use urinary and blood tests. And of course, EKG. Urinary analysis can be done by macroscopically or microscopically and dipstick tests. For example, on macroscopic appearance, rarely see tea-colored urine, 3.6% of the patients only. In dipstick tests, yes, there is blood. Dipstick test says the urine has blood, generally 4 positive, but it's a cross reaction because of the globulin part of the myoglobin. It's a cross reaction. In fact, on microscopy, you will see no blood cells. Because of that, this test, urinary myoglobinuria positivity, is not specific. And another point of the urinary analysis, myoglobinuria is not always visible or may be resolved early because of very, very short half-life. So this test cannot exclude the diagnosis. Another one, urinary analysis on macroscopic. As we said, we will not see any red blood cells. Diagnostics, we have to check lots of things on blood tests. If we start with serum myoglobin, as the urinary myoglobin, serum myoglobin has some limitations. Because of the short half-life, it rises and drops much faster. It just took 1 or 6 hours after the injury, so it's not very helpful for us, and very low negative predictive value. But serum CK has lots of advantages. Most importantly, it is the most sensitive indicator of the muscle damage. Rise approximately 2 to 12 hours after the onset, peaks within the same day, and declines gradually. Even the declination rate is relatively constant for CK. And degree of elevation correlates with the amount of injury. If you have at 1,000, yes, you have an injury. If you have 5,000, approximately you have 4 or 5 times more injured mass, muscle mass. Electrolytes, we have to check this potassium, sodium, calcium, and phosphorus, and we have to treat them as their specific treatment. We have to check the patient's renal functions and liver tests, and probably you will see high serum liver function tests in these patients. Also, we have arterial blood gas analysis for hypoxia, for electrolyte disorders or acidosis. Coagulation panel for DIC evaluation. Cardiac panel maybe, but generally falsely elevated, especially in elderly population, and toxicology panel for ethanol, THC, and MDMA. EKG show lots of things regarding electrolyte imbalance, especially due to hyperkalemia. The other options are, for example, imaging. Of course, not the prior one, but it can be needed during the ruling out or differential diagnosis processes. And muscle biopsy, it can reveal necrotic or fragmented muscle fibers, but it's not usually done for routine evaluation of these patients. Until we reach an exact drug-induced rhabdomyolysis diagnosis, we have to deal with lots of conditions as listed here. So you can see you have to differentiate, exclude sepsis, inflammatory myositis, burns, in child abuse, neglect, or ethanol toxicity, and moreover. Complications can be divided into 2 main groups, local and systemic ones. In isolated drug-induced patients, rhabdomyolysis patients, we do not expect so much local complications like second wave phenomenon or compartment syndrome, but please remember that even the patients have drug-induced rhabdomyolysis, the patients may have multifactorial states. The systemic complications divided into 2 subgroups, early and late. We call them early and late, but one of them is in the first 12 hours, the second one is in the second 12 hours, in fact. And even if it's early, even if it's late, the consequence is always life-threatening. Please remember that. And the complications are, I think you already know all these complications. Management, there is not a defined approved guidelines for treating rhabdomyolysis or drug-induced rhabdomyolysis, and we still go with the general rhabdomyolysis general principles. And of course, our initial priority is airway ventilation and perfusion. And for drug-induced situation, stop muscle destruction by causation of the drug that caused it. If we go point by point, eliminate exposure to the toxic agent. Begin BLS and symptomatic treatment immediately. Use pharmacological agents to prevent agitation, seizures, and abdominal movements that will cause, because they will cause muscle injury to increase. External cooling in the state of hyperthermia. Benzos to control muscle hyperactivity. Control electrolyte imbalances, alkalinization in the urine, and mannitol in some selected cases, and it's not approved totally. Evaluate the need of the dialysis of the patients, monitor the patients in all the way, hemodynamically, in fluid intake and urine output. Just monitor the patients. And of course, the other things, for example, check limbs for compartments, syndromes, further investigation to uncover the underlying causes or possible complications. And avoid prostaglandin inhibitors such as NSAIDs because they have vasoconstrictive effects on the kidneys. The general principles are that, but I have to talk about just for a few minutes on hydration, bicarbonate, and mannitol, because as I said before, there is no approved general protocol for all of them, in fact. First goal, correct hypovolemia to decrease the risk of acute renal failure. But our target is not normovolemia in this patient. Our target is hypervolemia in these patients, to flush the urinary system of these patients, to exclude the myoglobin casts in the tubules. So more fluid to save the kidneys. Because of that, hydration therapy is generally emphasized as hyperhydration, vigorous hydration, or excessive fluid resuscitation. But fluid types and rates are not well defined, but normal saline is a good option because it does not contain neither lactate or nor any potassium. The goal is a urine output of 150 to 200 milliliter per liter at an infusion rate of 1.5 liter per hour. Sodium bicarbonate and mannitol in some selected cases, but there are controversial information in the literature. Generally, alkalization is helpful because the main goal is a higher pH, urine pH. By that, we can achieve to decrease the nephrotoxicity of the myoglobin with high pH. But mannitol, yes, it's believed that it acts as a free radical scavenger, minimizing the cell injury. Also, mannitol has a vasodilatory effect on kidneys, but it's still controversial. And lastly, one of the controversial information, there are some studies, not just one study, by the way. And for the serious CK levels that indicate serious muscle injury, bicarbonate and mannitol is not found to be beneficial in these patients, for example. So further studies on drug-induced rhabdomyolysis are needed. So we can say new things. Thank you very much.
Thank you very much, Dr. Vural. Any questions? He works in the emergency department of Sydney Medical School in Sydney, New South Wales, and is also the toxicologist of the Western Sydney Toxicology Service. And we have the great pleasure that he will talk about the new N-acetylcysteine regimen in acetaminophen poisoning. This is a very difficult theme because there are so many protocols now. In the past we have just one, it was easy, and now it's too much complicated. So
by the end of this talk, you'll only have one again.
We're happy. Thank you, Naren.
Thank you. Thank you for inviting me to speak about acetylcysteine regimens. I don't know about your country, but we've stopped calling it N-acetylcysteine in the last couple of years. It's now just acetylcysteine. I don't think I need to remind you about the metabolism of paracetamol, but I just get you to keep your mind about NABQI as the hepatotoxic metabolite, which is formed from P450 enzyme metabolism, which then is detoxified. This is the traditional model of paracetamol metabolism and how it's detoxified. NAC is an acetyl moiety that is hitched onto the amino acid L-cysteine. So you can see the colored bit is the acetyl bit, and the rest of it is your normal cysteine molecule. What does it do? It's true, yes, it provides self-hydryl groups and promotes the creation of glutathione, but it also has other properties like scavenging antioxidants and provides some level of protection against free radical formation. But what started happening once N-acetylcysteine became a very prominent player in the antidote for paracetamol poisoning in the 70s is we started seeing adverse effects to acetylcysteine in the early 80s. And predominantly it was GI and skin. They were the predominant adverse reactions that people were seeing. When it started being given intravenously, the commonest error was somebody ordering it tenfold errors. So instead of giving 17 grams in a liter, they gave 170 grams in a liter. And these were not thought to be anaphylactic, and I'll tell you why in a minute, but non-anaphylactic, but anaphylactoid and non-allergic, so they were termed NAAR or NAR, and I'll talk about what that is. This is probably the first fully sort of going through every single adverse reaction paper, important paper to read by Parkeroven in 2008. And it talks predominantly about people getting abdominal effects, and then skin effects, and then other things like respiratory stuff. So it's the stuff that you're seeing already in your units whenever you see NAR. Why does NAR happen? One thing became clear, it was not IgE mediated, which is why it was not thought to be anaphylactic, and so thought to be anaphylactoid. Although the effects look very similar to anaphylaxis. And it had nothing to do with whether you'd had acetylcysteine before. So it's not like some kind of foreign protein, like let's say the sting of a bee or some kind of venom or some other foreign protein, that if you'd had it before, you were more likely to get it again in an IgE-mediated way. This was not like that. You didn't have to have previous exposure. The other thing was that there was histamine release, but tryptase levels did not go up, suggesting that it was not mast cell release of this kind of effect. When they did levels of NAC, so this is acetylcysteine levels as mapped across time, you'll see because we give a huge bolus dose and then the levels go away after that first 15 minutes to an hour. And then if you match that to what was happening to histamine levels, about, depending on how fast you gave that first one, if you gave it in 15 minutes like the original papers, then your histamine levels rose soon after that. And so that's why people often saw that reaction when the second bag started. That was the commonest time. I put up the second bag and the person had an effect. So that's what the nurse would come and tell you. And people were starting to blame the second bag, but it was really clearly starting to think that it was the first bag. This is another excellent paper that Steve Waring did also in 2008, where he confirmed, and it was already suspected, that if your acetylcysteine levels were low, that you were more likely to get an adverse reaction or a NAR reaction to acetylcysteine. But if your levels were high and you really needed the NAC, then the chances of getting a reaction were low. And this started to happen because in Europe and certain places, particularly Denmark and other places, they were giving NAC to everybody. Doesn't matter if you took 5 tablets or 100 tablets, everybody was getting NAC. And it's almost happening like that in the UK now. So this is the standard regimen that everyone's been using for the last 50 years or 40 years. There was a paper done which compared 15 minutes to 60 minutes, and they didn't find a statistical significance. That was done by Fergus Kerr, was the lead author. They compared 15 minutes to 1 hour as the first infusion dose, and they found that there was no difference, or the difference was too small and they couldn't find it to be statistically significant. So I'm assuming the majority of you are using this. Is anybody not using this regimen? Okay.
You're the only one.
I'm the only one. I'm not the only one. I'll tell you who else is using it in a minute. So with those histamine levels, those acetylcysteine levels, it started to become clear that probably that reaction is happening because of the very fast first bolus dose. So the SNAP study, probably the first big study to tackle a different thing. First time somebody had changed acetylcysteine in 30, 40 years properly. And here they gave acetylcysteine in 2 bags over 12 hours. The total dose was the same, 300 milligrams per kilogram, but not in 20 hours, but in 12 hours. They found a big difference in the NAR rates. It went down from 30% pre to almost 5% afterwards. That study was a little bit complicated because they mixed up the whole NAR situation with the vomiting and the gastro situation, the use of ondansetron. So it was a little bit hard to differentiate the whole gastro versus anaphylactoid reactions in that. Now this is called the SWAMP protocol of what we did in Australia. This is not, the word swamp is not published anywhere, not known to anybody. It was the word that we just used in-house because it was a handful of hospitals in Southeast Australia that were doing this. Sydney West, that was my hospitals. Austin Hospital in Melbourne, where the chief, one of the chief authors works at, which is Anselm Wong, and the Monash Centre protocol. So the SWAMP protocol, you don't have to call it that because nobody else does, but it was just because those were the hospitals in this study at the beginning. All we did was just merge the first and second bags. That was it. So 150 and 50 became 200. 1 hour and 4 hour merged to stayed as 4 hours. That third bag remained the same, 100 per kilo over 16 hours. So the first bag became 200 per kilo over 4. The second bag became 100 per kilo over 16. So the first 2 bags were merged. Total dose is the same. Total duration is the same. 300 milligrams per kilogram over 20 hours. And we're going to show you some data on that. This is our data from Western Sydney. The chief author for our paper was Richard McNulty, who's one of our clinical toxicologists. He and they worked very hard to make sure that they captured everybody. It was a retrospective study, so that's a limitation, but we're pretty sure we didn't miss any doses of NAC. There was a 66% relative reduction in adverse events if you switched from the 3-bag to the 2-bag. If you just compared severe effects, so that's people who became hypotensive, had breathlessness or any kind of skin swelling, there was a 77% reduction for those people, relative reduction. And there was a similar 60+% reduction in the use of anti-allergy medications like antihistamines and steroids. Now, if you compare that study and do a meta-analysis of other similar studies, so Anselm in Melbourne did his own study. That's the one that's number 4 on the list. That's Wong. Very similar results to ours with the odds ratio 0.39 versus 0.32 for us. Very similar, a repeat study done in Denmark just recently by Daoud. That's the study at the top. Also 0.36, so 3 times less chance of having an adverse reaction if you use the same 2-bag protocol. So all of these studies have done exactly the same. They have merged the first 2 bags. The only study that's done something different is Bateman, which is the SNAP study I showed you, which is the 2 plus 10. Okay? But Dawood, McNulty, Schmidt, and Wong have all done the same thing, pretty much. Here is the forest plot on that, on those papers. Now, if you look at this, I don't think any of you should be using the 3-bag NAC ever again. You're going to give me why?
No, because all these are side effects, but what is about the efficiency? That's the problem.
Yep, that's right. So all of these are about exactly that. So we haven't got enough data on the whether there's an inferiority issue. So far, we've been using this protocol in Western Sydney and in Australia for 5 years, and we haven't seen a change. It's not inferior to the previous because the dose is the same and the duration is the same. But certainly, adverse reactions are better. So what are the other advantages to this? The main issue is that there's less interruption between bags. So you have one less bag change. And often nurses will start the first bag. Once one finishes, by the time they start the next one, there's a gap. By the time you chase them down to come and put up the next bag, you've lost a bit of time without NAC. So less medication errors and preparation time. Now, to get this change in protocol across the countries has taken a long time. So Australia and New Zealand changed to the 2-bag NAC in 2019, and so did the Swedish Poison Centre. I'm not sure if anybody else has. I know California is still on 3-bag at the moment, and I assume France is as well. I'm not aware of any other places, but these 3... Rocky Mountain has changed? Oh, okay, great. Oh, okay, thanks. Great. And so what we're waiting for are these non-inferiority studies to see whether there's any difference, but I think it's unlikely at the moment. What's coming down the track is NAC Stop. NAC Stop's a study we're just about to publish shortly. Sorry, NAC Stop's been published, and the double NAC and a couple of other. The NAC Stop 2 is the one we're about to publish. NAC Stop was published last year, where for low-risk paracetamol toxicity, we are stopping NAC at 12 hours. So these are people with single ingestion. The LFTs are already normal before you start NAC, and then at 12 hours, you repeat the LFTs and the paracetamol's under 20 milligrams per liter, and it's at that point you can stop the NAC safely. So that's been shown to not cause any change in hepatotoxicity or death. So we think that in these low-risk patients, that you can probably stop NAC at 12 hours. NAC Stop 2 is still to be published, so I won't talk about that because Ansam should talk about that. It's his paper. The other thing that we're doing is double NAC. I know this is practiced in California and other places as well, and that is if at any point your result is double the nomogram line. So this is the nomogram line that we use in Australia, which is the same as in the US. So it's 150 at 4 hours. Let's say at any time, say at the 10-hour mark, your level is double the nomogram line. At that point, you should double that second bag. The first bag's given, that stays at 200 milligrams per kilogram, but that second bag is doubled. So we're thinking at the moment, the thinking behind that is that we're not actually giving NAC based on the dose ingested. It's based on weight of the patient. Now, if you say 1 mole of NAC counters 1 mole of paracetamol producing NAPQI, then really for a 70-kilo person, then that fights about 20 grams of NAC. So if someone takes a massive ingestion, more than 30, 40 grams, then you're probably going to need double or more NAC. That's the thinking behind that at the moment. Still controversial, not widely accepted. It is in the Australian guideline as of last year to double the NAC if the level is double the line at any point. Other things, there are other novel approaches that are being thought of all the time. I'm only putting dialysis there so that people don't forget it. There's nothing novel about dialysis. People have been dialyzing paracetamol for a long time. I've just put it there so that people don't forget that paracetamol is a dialyzable drug, and X-Strip has got guidelines on that already. Fomepizole, I don't know if anyone's used fomepizole or 4-methylpyrazole, but it actually, unsurprisingly, works, because if you remember back to my very first slide, our old friend that metabolizes paracetamol into NAPQI is our good old friend CYP2E1, which also is the same enzyme that's metabolizing ethanol and methanol and ethylene glycol. Now these are all, there's isolated case reports, there's not a lot of data on these other novel approaches. Metformin is thought to do some superoxide scavenging. Methylene blue may also have some effects on the electron transport chain, which may help. And another drug which I can barely pronounce, which is calmangafodipir, is on phase 1 trials right now as being a promoter to mop up superoxide radicals from NAPQI-induced hepatotoxicity. So it could be down the track, say in 10 years' time, that you'll be giving NAC with calmanga drug. That's a possibility down the track. Thank you.
Thank you very much, Naren. Any question from the floor? You have many questions. We'll start.
Okay, so thank you so much for this presentation. It's very interesting. I have 2 questions, basically. I know that when it comes to the side effects, though we are giving the same dose and the same duration, but in fact, you are not giving the same rate. So in the case of 3 bags, we are giving 150 milligram per kg over 1 hour, yes. Whereas in the other one, you are giving around 50 milligram per kg per hour.
Yes.
Right? So basically, the dose will be definitely less. Maybe that's the reason why you have less side effects compared to the 3 bags.
Absolutely.
And already that study showed that there is no difference between 15 minutes and 1 hour.
Yes, so that was the study showing that there was not a huge difference in adverse reaction rates if it was given between 15 minutes and 1 hour. So it's 150 per kilo over 15 minutes, yeah, or 150 per kilo over 1 hour. I absolutely agree with you that giving the first bag slower, not at 150 per kilo per hour, is the reason why that you're seeing less NAC reactions. So the dose is slower, and that's why you're getting less reactions, because that was the reason for getting those reactions. We were giving it very fast. The other thing is, if we think about the way NAC regimen was devised in the 60s and 70s, these were given in Northern England and Scotland to people who presented quite late. They were not coming 1-2 hours after their overdose and saying, I've taken 50 Panadol, please save me. These guys were presenting later. So at that point, giving a big bolus of NAC to someone who's heading down hepatotoxicity road probably made sense. Nowadays, we're giving it to people, sometimes we're giving it to people who've taken hardly any paracetamol. And so I think that also plays into why we're seeing more adverse reactions in our current cohort of population as compared to that published during Prescott time and things like that. Yeah.
Yeah, but that's the same thing in the study where you said that comparison between the 3 bags and the 2 bags, and there is no significant adverse outcome, and you are advising for the 2 bags, right, instead of the 3 bags. The same thing, the studies did not specify what was the time of the presentation and how much the ingestion was.
Yes, I haven't presented it here, but all of those studies have had matched demographics between the 2 cohorts and are very similar. I didn't put that table in my talk. But yes, there is an extensive table in pretty much all those studies about the cohorts between the 2-bag and 3-bag being very similar. Yeah, but that's important. Yeah.
One question from Ritwak.
My question is really short. Are you going to do 1 bag?
Yeah, that's a great question. I think we're going to get there. It's taken us 40 years to get from 3 to 2. I think eventually we'll get to 1 bag. It will be 300 per kilo over 12 hours in 10 years. I'm pretty sure. Good question.
Yeah, I agree in the cases where it's not, the poisoning is not so severe. But what about if the patient is seen with delay? What about if there is already an acute liver failure?
Yeah.
So my questions, is the bolus important or not? And do you increase the dose of NAC or not in these severe cases?
Yeah, good question. I think in those people with either established hepatotoxicity or ones that present late, giving 150 per kilo over 1 hour versus 200 per kilo over 4 hours in that later presentation, I suspect there's very little difference in that. I think it's going to be okay. Because these guys present maybe 12, 20 hours there. So whether they get it within 1 hour or 4 hours is probably not as big a deal as the fact that they need more over a longer period of time, which is why in those scenarios with established hepatotoxicity, we are already doubling that 2nd bag. We are already doubling or tripling if the level is really high.
So you double if there is an elevation in transaminases?
Yeah,
even though the paracetamol concentration is low?
Absolutely, yeah.
Okay. Yeah. Any other question?
You can double or just give it for longer.
Yeah. Longer, okay. Any other question? Okay. Thank you very much for this very interesting presentation. And we'll move.
Good afternoon, everybody. And it will be short. It will be different. So I'm going to talk about the concept of are we ready to deal with any botulism cases. So I will start with a small story which has a regional or sub-regional importance, and then come with lessons learned, which is about 3 or 4 points. First of all, it was about 1.5 years ago, my colleague from a neighboring country called us and he said, "Well, we have suspected case of botulism. Do you have the antitoxin?" I said, "No, we don't have it. We don't have it because we didn't see any botulism case for like more than 20 years. He said, "Well, we have 1 case and we need," and he said, "Well, you can call others and maybe international centers or other countries or maybe WHO." Then they called me, they said, "Oh, it is not botulism." Then I was talking to my colleagues, "Shall we have some of this antitoxin? What about diagnosis?" They said, "Well, it's an old disease, we don't get it." And this year, a family of Egyptian family in Qatar, the father, son, and daughter were affected, were admitted. It was really a new cluster of cases that are really, we didn't see it for a long time. Many of our colleagues, they say, "Well, this is in the textbook." So they were calling each other, "Come, see, we have an interesting case, and we don't need to miss it, because we may don't get it for another few years." So it was diagnosed clinically as botulism toxins. They were Egyptians, and we know that Egyptians are maybe one of the most affected countries in our region because they have what they call Shem and Nasim holidays, where they cook fish and make it they store it in special jars where it's really anaerobic conditions and it favors the growth of botulism. So we were investigating how to deal with this case. We don't have the diagnostic in our lab. We don't have the antitoxins. We have antibiotics and supportive, and some of them were intubated. And then we want the antitoxin. What shall we do? So I called WHO office, our regional office in Cairo, and they said, "We don't have it." Okay, what about the headquarters in Geneva? Well, actually, it finished. There's an order, and it might take a few weeks or so. That was really a bad situation. And we know that Egypt has it, because Egypt always prepared to have some cases, and every year there is 100 vials coming specifically to Egypt. And then we used our, I would say, ways to let the family talk to the embassy and the WHO officially coordinate, and eventually we succeeded to have it. A bit late, more than a week, and it has to be delivered by one person by hand, and it was really difficult. At the same time, we tried to map the producers, the pharmaceutical companies, and we found the best is the Canadian company that Egypt bring their products from them. And immediately we called our embassy to bring 3 vials as soon as possible, and then we made some orders to have more stockpiles. So the lessons or the story is that we were alerted 1.5 years back. We didn't take it serious. We had it in Qatar this year, and we learned from it. And even though there is an Eastern Mediterranean poison net, with some of the colleagues here are member, and we were talking to them, they said, well, we don't have it, we have only the antitoxin A and B, and we discovered that it's not only locally, it's regionally, and even to internationally, we are not really prepared to deal with these cases. So the lessons from these issues is that we need to have the diagnostic capability in our lab in the hospital, the diagnostic capability in the public health lab, or food safety or environmental lab, to diagnose the food and the people. And also to have something in terms of protocol, how to deal with these cases, and also to make our colleagues, doctors and nurses and healthcare workers aware of these cases and this disease and how to deal with it. Also, if we don't have it, it's not, because the antitoxin is very expensive. If we don't have it, at least we know where it is, or regionally in our region where we can find and order these antidotes. So from there, we took it serious, and we started some discussion internally and nationally. And also, we took that serious to our IMRO office with WHO in terms of mapping our region, and also identifying how many vials in each country, and then make it, regularly reported. In case any country needs, we can provide them, even with cost, sometimes without cost. And in our case, Egypt gave it to us for free because it was affecting Egyptian family. So the lesson or the message here is that we need to have it as a package. Increase the awareness of healthcare workers, decision makers, lab, clinicians, and even international methods or ways to order it. And we use the IHR, the International Health Regulation 2005, as a call for this statement. So basically, I'm just raising the awareness is that although it is quite rare, but sometimes you will get it, and sometimes you get it in a big volume, not only 1 or 2, maybe 3 or more. So we were lucky to have 3. All of them survived, but took a long time to recover. But we were really worried about them. So they were, alhamdulillah, we had a very equipped intensive care unit. So some of them were the 3 of them were intubated, but some of them stayed 2 months. The father stayed about more than 2 months, but eventually they recovered. But it is really bad because we didn't give them the treatment initially. Otherwise, it would be speedy recovery. And this is basically what I need to say. Increase the awareness, and thank you very much indeed.
Thank you. Is there any question? So if I understood, you have a project of mapping in the MENA region where the anatoxin are present, where the antidotes are present?
Yeah, we agreed with the IMRO office to start and do it with them together. So it becomes more official from IMRO and with our inputs in it.
Okay. Because I guess that in many countries, there are no supply and no possibilities to get the antidote.
And at the moment, we are in the process of recruiting 12 vials for this year, minimum.
Okay. Any question? Thank you very much. I'm sorry for my mispresentation, and welcome to our Congress.
Thank you. I really appreciate it.
Okay, so I don't know if it will be here or somewhere else. Here, so the walls will be open, the two rooms, or not?
Welcome, everyone. Sorry for the delay. We ran behind a little bit, so I apologize. But we wanted to just close the main scientific conference with this ceremony. RJ, Dr. Hoffman, for the abstract. So we will keep this short, very concise. We have a few objectives. The first objective is to first have a few thank you remarks. On my behalf, I really want to thank the participants who persevered through our scientific programs, which were quite lengthy this year compared to previous years. I'm very happy with the attendance. You know, we had hoped to have a very vibrant and engaged attendance, and I think we did that. And this is not surprising considering our membership as well as IPAT's membership and passion for toxicology, which was very apparent. We thank you again for your volunteerism. All our speakers volunteered their time and money to come here and speak and participate, so we appreciate that. We also want to thank the company Literature that provided all the logistical support, and thank our sponsors, Toxins, Randox, Response Systems International, Turkish Red Crescent, and the company that markets N-acetylcysteine in Turkey. We also want to thank, on behalf of Minatox, our partners, IPAT, for their support and partnership, and look forward to future programs together and development of toxicology in Turkey and the region. Thank you.
Thank you very much. In the end of the 2 or 3 day, very nice conference, and we take note for this. Toxicology is very important part of emergency. So we will continue to contact, and thanks for Minatox speakers from all the world. They come and join us and share their experience. Very valuable speakers from all the world. It's a big honor for us to see you in Istanbul and to know you, and we hope we will be in contact for the future cooperation. I think this is very useful conference, and around 100 topic, more than 100 topic maybe. 200 participants, no, very much topic about toxicology. We speak about toxicology, everything about toxicology. We will be in contact for the toxicology journal and toxicology textbook and another topic together. And I think don't forget, I think that you give promise for the 2 years later again in Istanbul. Don't forget about that. Inshallah. And I want to invite all these valuable speakers to our big conference. IPAT, very big family, not only in Turkey, in the world. We are in like international society. So I want to invite everybody to international section of IPAT. And we have your detail and email, and we will be in contact. We will send you email from IPAT. And I want to thank my team, my college, and especially Dr. Behjet behind of me always. I am front, and Dr. Behjet come to conference after the very difficult time. And we didn't share this, but I think I should say, because in this difficult time, after difficult 1 week, he never give up from job and working and join us. I want to thank to Dr. Behjet again. Thank you. Great effort. Thank you very much. We have very nice memory with you, and I hope like this, you think like us for the future. Thank you very much.
Dr. Bahshat, Dr. Gul, would you like to, Dr. Bahshat, would you like to say something? Okay, for the sake of time. What about Dr. Hoffman? Can you help me with the oral abstracts and the awards?
Sure, absolutely. So Ziad, maybe you could actually pose with the person when they come up. But so we have a selected best oral research abstract presentation, and that presentation was acetaminophen poisoning resulting from repeated supertherapeutic ingestion, circumstances and outcome, Dr. Bruno Magarben.
Oh,
At least stand up. Yes.
Do you want to take a photo with me? Come on.
I was looking for the camera right there.
What an honor. All right.
Okay, thank you. And our best, so the best oral presentation of an e-poster was the utility to test the salicylate level for all cases of paracetamol overdose, Dr. Ahmed Alabri.
Congratulations. The next award is actually a memorial award for one of our medical toxicology fellows, Dr. Saeed Al-Mazrou'i, who was enrolled in a medical toxicology fellowship in the US, at Emory actually, and then who was diagnosed with a brain tumor during the fellowship. And he actually succumbed to his disease, leaving his family behind, unfortunately, and leaving many friends in Oman and the Middle East, North Africa region, and MENA talks particularly. So in honor of his memory, we have an award that we give every year to someone who is passionate about toxicology and has served MENA talks. This year's Saeed Mazrou'i Award goes to Dr. Iran Gokta from Istanbul. Last but not least, we would like to thank our speakers with a small souvenir from this conference. And I'm going to actually read the name of the speakers. If the speaker is not here, we will just basically move on down the list and we will save their souvenir and certificate till after the ceremony. We'll start with Mr. Nabil Ahmad, Dr. Ihab Aki, Dr. Peter Agupnunu, if you guys give you a heads up so you can start walking to the podium. Dr. Faride Agul, Dr. Bahshat Al, you are here already. Dr. Ibtihal Lattas, Dr. Suad Labri, Dr. Khaled Laufi, Dr. Anwar Al-Awadhi, Dr. Hassan Al-Balushi, where's the camera? Dr. Jalal Isa, Dr. Badriya. Somebody can read, and I can stand on the camera. Thank you.
Kimi biliyor?
Peter Akamoğlu.
Peter. Hangisidir? Hangisi?
Buradan başla, Aylin Arıcı'dan başla.
Okay. Aylin Arıcı. Avni burada değil. Ashish, you are welcome.
Where, right here?
Ashish. Yes, Eileen, please.
I have to stand in the same place. I cannot move. This way, please.
Okay.
Also this. Thank you. Congratulations.
Ashish. Sen devam et. Sen devam et. Okay. Abdul Latif Alumi. Latif. Tamam. Abdul Kadir Gündüz is here. Okay. Amal El Kozai. Amal El Kozai.
He's not here.
Not here. Okay. Andrew Nelson.
Andy Nelson.
He was here. Bruno, he's already here.
Andy's here.
And he's here. Bruno, you are here? You are still here. Bedriya El Hatali is not here. She is here. Ah. Oh, she's here. Who is Bechet Al? This is mine. I'm here. Brent Morgan. In the morning he was here. Brent. Okay. Brett Erickson. He's traveling Istanbul, I think.
No, Brett was in New York. He did the phone.
In New York, not Istanbul. Charles Maki. Okay, he's here. Ahab Aki. Okay. Edwin Kilburney. Charles. Edward. Eva, my friend. He is in Bosporus. Elia Harmonic. Eren was here. Gökdağ. Gülseren is not here. Gürkan Ersoy. Gürkan was here, yes. Gaylord Lopez. Not here. Jalal Alashi. Jalal not here. Okay. Hussein Hassan, Iranian. Hussein Hassan. Okay. Hanna. Dr. Hanna. She was not here. Hassan El Belushi. Hassan kim geldi? Hussein Hamoudi. Where is Hussein? Hussein Hamoudi. He's eating. Ismail Sabei. Not here.
We had put discussion to the end, but I think we've got time for a few questions. If anybody has any comments or questions about Ivali or e-cigarettes. Are you seeing this in Turkey? There's plenty of cigarettes. Don't need e-cigarettes. Not common.
I'll mention one thing that, so I took care of a number of these patients, and because they were getting their THC products literally, I mean, they would say, yeah, you know, Johnny 3 houses down, he's the person I go to get my liquid that I use in my electronic cigarette. I would actually counsel them if they really needed THC to just smoke cannabis as opposed to using the electronic cigarettes. It's not the usual advice I would give someone as a physician or as a medical toxicologist, but I felt it was probably better that they use, if they're going to use drugs, that they use it in a way that's safer and than a way that was less safe in these cases. So there was some interesting conversations I had to have with patients about their drug use during this outbreak.
So on that point, Trayvon, we found that in Australia that people who were never cigarette smokers had started taking this fashionable sort of smoking habit up. Is that what you're seeing? And were they tending to be the ones who are more on THC type, or because people shouldn't just suddenly start going on nicotine, you would think?
Yeah, so that actually brings a lot more to nicotine marketing. So these electronic cigarettes were overtly marketed as an alternative to smoking. but were subversively marketed in a way that was attracting new, young nicotine users, primarily teenagers, in very fashionable ways. And as you can imagine, if you get a teenager addicted to nicotine, you've got a customer for life because nicotine is an addicting substance. And so yes, so we were finding, if you were demographically, most of the patients involved were young men, usually late teenagers through early 30s. And many of these people would not smoke cigarettes. They were electronic cigarette users. That's how they took their nicotine, or transitioning to their THC products. But yeah, it's an interesting concept in marketing that these products were marketed towards a younger audience to get new nicotine users, and then many of these ultimately went on to using THC as well.
Thank you.
Thank you. Excellent talk. I'm emergency physician and clinical toxicologist from Oman. One of the things I'm not sure if it came across to you is, since 50% of my customers are actually pediatric age group, did you come across like that nicotine syrup being ingested by kids? And do you have any data for that? Because it's